A very good afternoon, ladies and gentlemen. We are on 17th November 2023, the first day of the CHIP Summit, the complicated high-risk indicated procedures, and going with the tagline, enhancing outcomes in complex PCIs. May I request all the delegates to please come in and take your seats, please. You must have seen the panels going on, almost like Marvel Comics, and all the superstars are going to come here and be addressing all of you. So I'd like to invite Dr. Anil Kumar now, the organizing chairman, to kindly make his opening remarks before we move into the sessions. Thank you. Kindly put your phones on silent or vibrate mode, please. Thank you.
Good afternoon, all. Let me welcome all of you to this CHIP Summit 2023. It's a slow start, but we should get started on the scientific program. We have a detailed program on complex high-risk intervention procedures. This concept had come up in 2019 when we started the first conference, when CHIP was just a new terminology in the scientific parlor of cardiology. But we had a successful 2019 program in-house in Aster Medcity. We followed it up with a bigger conference in Marriott Hotel in 2022, and we thought we should make that into the next level, and now we are here at Crown Plaza. So complex high-risk intervention procedure. As we were discussing on the sidelines of this conference, we were telling that anyone should be able to deal with a CHIP case. A normal case can become a CHIP within seconds. It can become complex, it can become high risk, and you might need to do the most complex of procedures. I would quote Dr. Sanjog Kalra, the first CHIP fellow of United States. He says that everybody cannot do a CHIP, but everybody with training, mentorship, and good teaching can become a CHIP operator. So that is the aim of this program. And today we have called this session the ABC of CHIP. For starters, for beginners, for people who are already into angioplasty, all of them can learn the ABC of CHIP. So we have a galaxy of international faculty, some of them online, some of them on-site. So we would have sessions starting from the basics, going on to the advanced. So today will always be, we get started with the basics of CHIP program. So with that in mind, we will get started with the scientific program. The delegates are just coming in, but in the interest of time, we get the scientific program started. Let us start with the opening session.
Thank you, sir. Thank you, Dr. Anil Kumar. Now we will move on to the first session. Once again, may I kindly remind all the presenters to kindly stick to your stipulated time. May I invite for the first session, titled Basics, the chairpersons of the session, Dr. Shiva Prasad, Dr. K. Shiva Prasad, Dr. Mahesh, and Dr. Karthikeyan, please. Like the organizers have mentioned, some of the presentations will be online, some offline. So may I hand over the proceedings now to our esteemed chairpersons. The time for these presentations on the basic session is 15 minutes plus 10 minutes. Over to our esteemed chairpersons now. Over to you, sir.
Good afternoon. Welcome you all to this basics of CHIPs. We have two excellent speakers for this session. One is Dr. Vijay Kumar. He's a renowned cardiologist in India and abroad. He is an imageologist, and he's going to give us the basics of intravascular imaging in CHIP angioplasties. And let us listen to Dr. Vijay Kumar, who is a pioneer and who has a lot of publications in intravascular imaging, both IVUS and OCT. Over to Vijay Kumar, sir.
Thank you so much, sir, for the kind introduction. I thank Dr. Verma and Anil sir for this opportunity. And for the next 15 minutes, we shall see some of the basic aspects of intravascular imaging during PCI. So why do we need intravascular imaging? So intravascular imaging, whether it is IVUS or OCT, they provide additional information they'll supplement angiography in improving procedural outcomes. Where do we need this additional information? In assessment of intermediate coronary lesions, evaluation of apical lesion morphology, decision making on lesion proliferation during PCR, cell sizing, cell optimization, and finally, assessment of state failure. We shall start with the assessment of intermediate lesion morphology. There is not LMCA territory. The MLA cutoff value for perivascular imaging ranges between 1.6 millimeter square to 4 millimeter square among different studies. However, the correlation between MLA and FFR is poor. So intravascular imaging is not recommended currently by the guidelines for the diagnosis of pleural-distal disease in non-LMCA territory. However, in LMCA territory, the correlation between iris MLA and FFR is excellent. And the iris may be used for diagnosis of pleural-distal disease in LMCA territory, particularly in the presence of downstream disease. The second important role of intravascular imaging is evaluation of ambiguous lesion morphology. Observe these three lesions. They are AC, as they are appearing on angiography. However, I will show calcified nodule in the first one, thrombus in the second one, and the rupture block in the third one. All different pathologies requiring different type of treatment. The third role is decision regarding lesion proliferation. There is a 4-point iris score and the 3-point OCT score. When iris score is more than 2, or OCT score is more than 3, you need some form of specialized lesion proliferation technologies. And what about no reflow during TCL? Presence of iris attenuated clot, lip-rich clot, or OCT, pericardial hypertheroma and OCT or iris, and the presence of thrombus have been associated with increased resistance of no reflow and periphyral myocardial infarction. In a study, elegant study from Japan, when there is extensive attenuated clot, use of digital production has been associated with the decreased incidence of no flow and increased delivery counts. What about sensizing is based on the distal reference diameter. If the mean distal reference diameter, human diameter is used for sizing, you downgrade to nearest 0.25. If you're using external elastic membrane, you upgrade to nearest 0.25 for the stent size. You measure the distance between two references, that is your length of the stent. Which is ideal landing zone? Ideal landing zone is the one which is free of plaque. In case of diffuse disease, you have to select landing zone with less than 50% plaque burden or iris, or in the absence of a lipid-rich tissue, lipid-rich plaque in case of OCT. And what is optimally implanted stent? Optimally implanted stent is a one which has a minimal sustained area more than 5.5 on iris or 4.5 on OCT, or more than 80% of average reference human area, with no malposition which has an axial extent of more than 0.4 millimeter and the length of less than more than 1 millimeter, no extensive tissue protrusion, and the plaque burden at the edges less than 50% and no lipid-rich plaque at the edges, with no dissection which is more than 60 degrees in R, and flap extending to the media and lesion length more than 2 millimeter. Once you achieve all these parameters, your 1 year MACE rate is 1.5%, the best achievable with the current technology. And we move on to intravascular imaging in specific lesion subset. First, we'll start with ACS. The most important role of intravascular imaging in ACS is evaluation of ambiguous lesion morphology. For evaluation of ambiguous lesion morphology, particularly in patients with the Minoka, OCT is better suited for this purpose than iris. The various morphologies identified in Minoka, erosion, rupture, nodule, spontaneous coronary dissection. In some cases, there is no lesion. So, and for optimization, it is a class 2A recommendation in patients with ACS. And moving on to left main, as I already mentioned, it is accepted for evaluation of intermediate lesion morphology in the left main. And when your minimal lumen area less than 4.1 millimeter square, patient is qualified for revascularization. Any MLA more than or equal to 6 millimeter squares revascularization can be safely deferred. When you handle an area in between, you have to use some other technologies such as FFR or non-invasive stress test. If it is not possible, we have to take into account body size and age of the patient, the flask product, remodeling in that to make your decision towards or against revascularization. And in case of osteoligament stenosis, IVUS helps in differentiating between consecutive remodeling or flaw. And in case of soft lesion, then IVUS tells you the extent of proximal and distal extent of the lesion, whether you have to extend the stent for the osteo or you have to do a crossover morphology. And in case of bifurcation lesion, IVUS tells you when to implant the two-stent strategy than a single-stent strategy. Whenever there is a minimal human area in the thigh band is less than 3.7 millimeter square, the flask burden is more than 50%. It is a two-stent strategy rather than a single-stent strategy. Once you implant the stent optimally, should be aiming for at least a 5 millimeter squares and 6 and an 80 dominant polygonal confluence and 8 in proximal point. This is a bit older data, and recent one is that is about the 5.7, 8.3, and 11.8. And in case of bifurcation lesion, IVUS tells you whether the lesion is located in the thigh branch ostium or within the main vessel. The second role is it tells you what is a risk of side branch compromise by evaluating the presence of spiky carina and the flask burden and opposite to the carina. And the third thing is whether single stent or two-stent strategy as in left line, area of less than 2.4 millimeters square flask burden of more than 50% goes in favor of two-stent strategy comparing to single-stent strategy. And during procedure, IVUS helps in identifying distal or proximal crossing for your kissing balloon optimization. And for bifurcation with the 3D capabilities, OCT is a bit more suitable comparing to IVUS imaging because you can exactly see your lesion crossing by using 3D modality rather than 2D modality with IVUS. And in case of calcified lesion, and when your calcium score is low, you can go with a balloon-based strategy. When your calcium score is more, you have to use some form of specialized therapeutic strategy. And in case of CTOs, in antegrade, there are two utilities. One, where there is a blend cap, and if you have a suitable side plan, IVUS tells you where exactly is your proximal cap. And in case of failure of antegrade crossing, and IVUS can help, and if there is no retrograde option, IVUS helps you in intimal wiring and getting into the distal vessel. In case of retrograde, the most common mode we all know of reverse heart failure is presence of wires in different areas of your vessel, whether subintimal or intimal. So IVUS helps in identifying the exact location of wire and redirecting the wires into the appropriate space that helps in procedure success. Suppose you have an aorta ostial or side branch ostial CTO, and IVUS helps in identifying the true intimal or true lumen location of your retrograde wire that's avoiding side branch loss or major aorta ostial dissection. In case of diffuse disease, IVUS or OCT helps in identifying the true vessel size and the true landing zones and the length of stenting. And finally, you can select your balloon based on your vessel size. So that helps in getting a bigger lumen area comparing to angiography-based strategies. And when the patient has contrast allergy or renal dysfunction, then IVUS helps in doing the minimal contrast or zero contrast PCA by establishing a metallic salute with the wires and IVUS guided identification of landing zones, lesion preparation, and lesion length. And in case of stent failure, then IVUS or OCT helps in identifying exact pathology of failure. So treatment can be directed towards that pathology. In case of early stent failure, it is all related to your procedure, and late stent failure related mainly due to neoatherosclerosis, late acquired malformation, late acquired malposition, stent fracture, and uncovered stent cells. And moving on, what is the clinical evidence for intravascular imaging? This is the major registry of 8,000 patients with the 3,300 patients with the IVUS guidance. This registry has shown that IVUS usage is associated with the lower incidence of definite or probable stent thrombosis, myocardial infarction, lower incidence of overall MACE. The IVUS guidance is an independent predictor of lower MACE. At a 2-year follow-up, IVUS has shown a decreased incidence of MACE and definite probable stent thrombosis, decreased incidence of myocardial infarction, and in addition, decreased incidence of clinically driven TLR. And IVUS guidance has been resulted in improved outcomes, not only in complex lesion, but also in single vessel disease, not only in patients with the chronic stable angina, but means ACS, but also in patients with the chronic stable angina. And if you see carefully in the study from the ADOPT years, you can see IVUS guidance has been associated with the change of procedure strategy in 3/4 of the patients, most commonly resulting in usage of larger balloons and larger stents, and high pressure post-dilatation, correction of under-expansion, malposition, and the correction of edge disease with the additional stent implantation. And is there any difference between IVUS and OCT? This is after a study that has been presented recently. There is no difference between the outcomes of IVUS guidance and OCT guidance procedures. And what about Alzheimer lesion that has been evaluated in Ultimate trial, 1,500 patients? This has been associated with IVUS usage was associated with significantly decreased incidence of the target vessel failure. Suppose you achieve all the parameters of IVUS guided stent optimization, your 1-year event rate is about 1.5%. And these outcomes are maintained up to 3 years on the work. And what about left mind? Left mind is a one subset. IVUS has shown that about a 4 to 7% decrease in the mortality rate comparing to angiographic PCI. What about CTO? In CTO lesions, IVUS guidance has been associated with the decreased incidence of MACE events, decreased incidence of a composite cardiac death, even though there is no difference in the as the vascularization. In long lesion, IVUS XTL study, similar to Ultimate study, it has been shown to be associated with decreased incidence of target vessel failure with IVUS usage. Again, this has been sustained up to 5 years. We can just see that overall MACE events were lower up to 5 years. And what about bifurcation lesion? This is a recent study of OCT presented in ESC. You can just see that OCT guidance has been associated with the absolute 4.1% reduction in the comorbidity incidence of MACE comparing to angioguided PCI. And there is a meta-analysis of multiple studies. Again, you can show that IVUS has been associated with decrease in MACE, mortality, MI, stent thrombosis, TMR, and TDR. And this is the recent study, updated network analysis of 20 studies, and intravascular imaging has been associated with a decreased incidence of the TLF by 31%, and there is a 46% reduction in cardiac death, 20% reduction in MI, 29% relative reduction in the ischemia-driven or clinically driven TNR, and 52% reduction in stent thrombosis. And this is the only outlier study. The study almost like to equivalent to Ultimate study, but it has been shown OCT usage in patients with a complication not resulted in improved outcomes, even though there was a significant reduction in the stent thrombosis. What the current guidelines say, the current guideline recommends intravascular imaging for stent optimization, particularly in complex lesion and stent failure. Current indication is 2A. To summarize, intravascular imaging provides additional information that's subtending coronary angiography. The various roles in the capillary range from intermediate lesion assessment to evaluation of stent failure. Intravascular imaging outcome improves outcome both in simple and complex lesions, both in stable and acute coronary syndrome. And studies have repeatedly shown the utility of intravascular imaging in improving outcomes in patients undergoing PCI. Thank you so much.
Yeah, thank you, Dr. Vijay. It's a masterly lecture as usual. Basically for the fellows course, how many fellows are there in the audience? Can you just raise your hands, please? All of them are hiding. So, okay, who are just finished DM, somebody who like, okay. Now the way the thing goes is, either you ask the questions or we will ask you the questions. It's better that you ask the questions, make maximum utilization of the presence of Dr. Vijay. Anybody's got any questions from the audience, we'll give you first preference, then we will take on the discussion. Jay, I just got a few clarifications from your side. One is the Caribbean study on stent failure. I think it is predominantly with OCT and not with IVUS, if my memory serves me right.
Both actually. Early study failures, there all the studies are with IVUS. But correctly with this increased resolution, that is what you need to see the morphology of the new intima and to accurately see the malar position and all stent-related parameters. Maybe for stent failure, OCT is preferable to IVUS. Only one situation, maybe IVUS or combination of IVUS and OCT you need was probably when you have a big vessel, maybe 5 or 6 millimeter. Sometimes you see that the area of stent thrombosis, you see a big positive remodeling. And recently we had a case, so there OCT looked like everything okay. Then you put an IVUS, the vessel was actually 6 millimeter size with a lot of plaque, was probably a thrombus or plaque behind. So only when those type of things you need, all other situations OCT is better than either. In other two areas, OCT is better than either is one ACS, particularly in a menopause. If you want to know what is the ambiguous lesion morphology, if you see a recent study, in about 40 to 50% of the patients, but I think 40% angiographically normal coronary, and they evaluated OCT, they could identify some additional pathologies which is responsible for their troponin rise. So that purpose, I think OCT scores over IVUS. The third area is when you do a bifurcation. Again, 3D. 3D is 3D understanding of bifurcation morphology. That is again OCT scores over IVUS. And two areas IVUS scores over OCT is when you take left mind. Again, you need big areas to be assessed, ostium to be assessed, and the CTO. These are the two areas. And if you want to do a zero contrast enable card, even though you can do with OCT, these three areas maybe IVUS goes over OCT. So, but both modalities, you should not think that the competing modalities. Both are complementary modalities. They have their own utility. Some patients IVUS, some patients OCT. Maybe very few patients may need a utility of both for understanding the pathology.
Can I ask a question?
Yeah, please.
Okay. Continuing on where Mahesh left in CSI, I mean, if I say IVUS will be preferred in imaging in acute MI over OCT, would that be an overstatement or would you agree to that?
I can't totally disagree with it, but either can be used. See, for stent optimization, there is no difference between IVUS and OCT. Acute MI, if you want to evaluate the block morphology or lesion morphology, I think OCT scores over IVUS.
And currently in 2023, would you say that IVUS is mandatory in every cath lab which does angioplasty for the beginners if you want to?
Exactly, sir. I think we should have at least one imaging, one physiology modality in your lab, either wire-based or non-wire-based physiology, and IVUS or OCT is, I think, mandatory because now more and more people are doing complex lesions, not like olden days. I think all the cath labs, their complex lesions are routinely performed. I think intravascular imaging is mandatory. If you see the left mind, see the improvement in mortality. It is about 4 to 7% absolute reduction in mortality. So that is the type of improvement you get by using intravascular imaging. Any comments that Deepak said?
Vijay, it's as usual very informative, very scintillating talk. Dr. Karthik is on the dais. We do have a lot of doubts to ask you. Another 5 more minutes for discussion.
Yeah.
Yes, with Karthik.
Actually, I learned most of my imaging from Vijay Kumar only. So that I just wanted you to clarify two things because for the larger interest. One is density of calcium. Second one is when you do CTOs. See, we know we can predict vessel growth and avoid stenting in those underfilled, spasmodic areas. And also, how do you integrate coronary CT? Because we know intravascular imaging is good, but then with our experience with cardiac CT, how do you integrate that information, especially when we deal with calcium?
Yeah, calcium imaging is a second growing field. So I think it is integration of all modalities. So if you're available CT, start with CT, then fluoroscopy, then IVUS, then OCT. I think all the modalities give different type of information. A CT, if you do early, and whether contrast or non-contrast CT by facing a Hansfield units. They say that Hansfield unit, anything more than 300 to start with and up to 1000. More the Hansfield's unit, and maybe I think denser the calcium, more difficult for you to crack it. So that is still not known for sure. But one small study from Japan has shown that more than 600 Hansfield unit may be difficult in cracking. And another important information, even before going to the lab, you can identify which has concentric calcium, which is eccentric calcium, where you need additional preparation strategies. Sometimes if you see that there will be extensive calcium, if you see the CT, the calcium will be above and below. The reason that will be exactly free of calcium. So they end up not using an aggressive lesion preparation strategy. So before you enter the cath lab, you have an idea what is to be done. Suppose the patient has CT, but nobody is going to ask the patient after an angiogram to get a CT unless you have some anomalous coronary arteries, another thing where you need additional information. The second thing is fluoroscopy. Again, if you don't see calcium on fluoroscopy, most of the time you don't need an aggressive lesion preparation strategy. And the calcium which is not seen on fluoroscopy and seen at either, it is always thin calcium which responds to balloon dilatation. And in OCT, obviously, it gives more information, particularly about your thickness of the calcium. I think any modality is okay. I think if you have an IVUS, means information on calcium even before going to lab, I feel you don't even need an IVUS for OCT for your further procedure. But once inside the cath lab, first clearly, most of the time when you see angiograms done outside and they come, you don't feel that there is any cancer. But first time you go inside, take a cine imaging, then even before you inject, then you see dense calcium sitting over there. But fluoroscopy, again, when you see calcium, fluoroscopy, particularly you see tram-track calcium, or any calcium seen on fluoroscopy, it is always more than 0.5 millimeter in thickness. And again, once you go inside, then IRS or OCT gives you more information about calcium distribution.
Two questions for PDA. What is, in your practice, what is the percentage of imaging you do, A, in routine cases, B, in CHIP cases, C, in imaging in ACS? And second part is, should imaging now be made into a class 1 indication, at least in certain subgroups?
Yeah. Thank you, sir. About in a good high volume center, should be at least 35 to 30% should be the imaging integration. So in our scenario, it is very difficult to use for all the cases. I think, I don't know how you are one of the high volume operators, so it is about 25 to 30%. I think, again, it comes at a cost. It is either 60,000 rupees, maybe if you want to use HD, 80,000 rupees, and OCT is 90,000 rupees as the catheter. I'm sure many centers will finish CCA in that cost. But maybe a type A lesion, when you get some adequate information with angiogram alone, maybe a vessel is 3.5 and this thing. So, but when you do complex lesion, particularly in the mind, calcium, bifurcation, where your event rate is very high, chance of stent thrombosis may be fatal in the left mind. So those type of testing, IVUS or OCT is must. And ACS, if you're not sure about the pathology, whether you're treating the correct lesion, and again, imaging is must. The 25 to 30% is means that is amount of PCAs you can do the image.
Can you describe the usefulness of IVUS in no reflow? You mentioned it briefly, but I missed that.
Yes, ma'am. Well, not many studies have evaluated. So IVUS, I think there is a study from Kerala, Dr. Sajan, through SKIP, it has been organized. So that study, we have found few things that has been associated with no flow. Most probably the important thing is presence of attenuated clot. Attenuated clot, particularly when your attenuation starts closer to the lumen, that means the big necrotic core is sitting inside. And if it is extensive, suppose an attenuated block, which is more than 180 degree and extending for more than 5 millimeter in length, that is the one has been shown to be associated with the no flow. We have these findings is about the 15 to 20% incidence of no flow. That is the one area that has been evaluated. There is a study called Vampire 3 that I showed during my presentation. In that study, what they've done, they selected attenuated block more than 180 degree, more than 5 millimeter in length, they used to selectively distal filter or no distal filter category. And the usage of distal filter has been associated with the decreased incidence of no fluid and the improved kidney failure counts. So attenuated plaque, presence of thrombus, suppose you have thin cap fibroadenoma, and these are the ones have been associated with increased incidence of no fluid. And even then, stent thrombosis cases, if you have an extensive, it is not that all the stent thrombosis patients you have to go and aggressively redilate it. Because if you find an extensive thin cap fibroadenoma, that is your neoatherosclerosis, if you go and dilate, you end up with severe no flow. Those are the type of, we have done few cases, those type of plaques, if it is found, then you just go direct to stented things.
Vijay, couple of questions, Vijay. Yes. Here. Vijay, regarding the if you were to do a imaging for a chip case, what would be the most important point that you would want to look for? Is it the vessel size? Is it the landing zone? Is it the morphology? What is the most important thing you would want to look for while doing imaging in a chip case? That's number one. And secondly, regarding left main bifurcation staining, what would be your endpoints? In IVUS, what are the luminal areas that you would want to achieve? And in OCT, what would be the luminal areas that you would want to achieve at the end of the procedure?
The first question in a chip case, it is most important thing is maybe a plaque morphology. I think it is the most important thing. The second most important thing is the vessel size. So these are the things to decide your outcomes. Suppose whether you have calcium or not, and what is the type of the stent and size of the stent going to implant. So first, I think it is the plaque morphology, maybe the most important one. That is a main predictor of your stent expansion. The second one is obviously stent size. And so both are important, but more important thing is plaque morphology. And the second question, if you're doing a bifurcation, there is no more areas which are specific to the bifurcation. If you see that left main bifurcation, we all started with the 5, 6, 7, 8. Then it had changed to, I think, 5.3, 5.7, 6.3, and approximately 10. That was Excel criteria. Now, recently, there is another one which has come from Korea, which has specifically looked into double pitch graph. It has shown that, I think, 5.7, 8.3, and 11.8, that is the area that has been shown to be associated with the improved event rate. But a very easy thing to remember is should be each segment should be more than 90% of its consent reference. Suppose if you have a left main, should be more than 90% of your reference, and your LAD should be more than 90% of your distal reference, and MCX should be more than 90% of the distal reference. That is the easiest thing to remember.
Really, just a question. If the patient comes with an acute stent thrombosis, now we need to find out what is the cause for the stent thrombosis. Okay. Now, we say imaging is essential for any case of stent failure, but if it's stent thrombosis, you don't see anything in OCT, you just see thrombus.
Yes, you have to ask for a thrombus before doing your OCT. So, and if it is a big vessel, large amount of thrombus, maybe I would prefer IVUS rather than OCT.
Yeah, that's a question. Would you prefer IVUS for acute stent thrombosis rather than OCT, or would you still go with OCT?
If I'm going to get a good quality image, OCT is my first preference. If a big vessel, large thrombus, if you feel that you're not going to get a good image with OCT, and I will go with IVUS.
Given a situation like that, you would be looking at the distal vessel size, the proximal vessel size, then the stent size. All those things would be taken into consideration rather than just looking inside the stent. Is that correct?
Yeah, exactly, Scott. Exactly. We have to take into everything in consideration. But if you want to see inside something, then it is, of course, an old stent. You want to see neoatherosclerosis, what is the exact morphology, those things. And OCT is better, but provided that you are able to get good quality images. But acute stent thrombosis, if you do a good suction, I think you should be able to get a good quality images with OCT. What is your preferences, sir?
I would also agree with you, Vijay. But then regarding the image quality, like what Dr. Madhu has raised the concern, I too have that concern. So what I try to do is in those situations, try to get a guide extensional catheter. Probably the guide plus would go till the area of the stent, then you can inject it properly and then have a good looking image. So always suck, then go with a guide extension catheter and have the image.
Thank you, sir. My question is really because, it had a couple of cases of stent thrombosis, and in OCT, it just could not get images because it's all sometimes thrombus. You're right. So, and when I did an IVUS, and IVUS, you could see what the size was and what was the reason for the stent thrombosis to an extent. So I just wondered whether you do OCT at all in stent thrombosis. We do. What only tendons, you should be able to get the good quality is needed.
That was an excellent discussion on imaging in CHIP PCI and also in various subsets of coronary artery disease. Vijay sir has done a wonderful job in explaining each evaluation by OCT and IVUS, and also in various situations and new areas in which this is being tried. Thank you very much for your excellent talk, and we are going to the next talk.
Vijay Kumar, thank you, sir. With us tomorrow. I'm here tonight. I'll be there, sir. Thank you. Welcome. Thank you, sir.
The next talk is going to be by Dr. Sanjog Kalra. Due to some technical issues, he couldn't land up here, nor could he come online. So this will be a recorded talk. So the discussion will be by the panel and the audience. So please take active part in this. The topic is, what is CHIP actually means complete high-risk indicated percutaneous coronary intervention. And the first CHIP course was started in 2016. And Dr. Sanjog Kalra is the first graduate of Columbia University Irving Medical Center. He was a CHIP fellow in 2016, the first person to start this course. And he's also got a master's in clinical pharmacology. I was just going through his resume. He's also got a qualification in cardiac critical care and cardiac imaging. Extremely well-read and very, very well multifaceted personality. Hopefully, you'll be able to hear him live in the next talk onwards. He's currently the Brompton Professor of Interventional Cardiology at Peterman Cardiac Center in Toronto. He'll be speaking to us on what is CHIP PCI and basic introduction about this concept called CHIP. We can start with Dr. Sanjog's talk.
My name is Sanjog Kalra, and I'm a cardiologist at Peterman Cardiac Center from Oslo. Thank you very much for your gracious opportunity to be with you at the CHIP Summit in Koji. It's 2023. Unfortunately, can't be every person that's integrated somebody else. This is the talk about CHIP PCI. Fortune savers the prepared mind. I think what I'd like to express most is that all of your success, complex cases, is about planning. Use your superior intellect so you don't have to use your superior techniques. But this is what doing CHIP strategies of finding 10 minutes or less time at scale like. It's a couple of information with a lot of discussion and a lot of consideration, but an awfully short period of time. So what I'm instead going to do is give you framework, right? Anything you should consider thinking about. And then I'll use a case to illustrate us working through those frameworks. And what we ended up doing, hopefully, as reason was, complex PCI plan is a generally speaking a 5-step process. It starts with identifying the right patient, moving towards a sort of objective evaluation by this IRT to ensure that we selected the right patient and we're offering the right procedure. Then and only then do you do the technical case plan. When we recognize that this is the territory we want to treat and this is how we're going to do it. Our brain sits jump to the, I'm going to do a bifurcation using this approach, right? I'm going to do a retreat, just add a frame. But really, we really over the first 2 steps, which are, am I doing the right thing at all? Those are probably the most important steps are. The performance of the actual procedure comes much later. That's step 4, where we then use our equipment, our skills to be able to execute. And then, of course, no procedure is done until the patient leaves the hospital. Is it not about getting them on the table? It's about getting them the right result. And so the recovery after chair and the CICU step down is absolutely straight out any of the other steps. So let's start with our case. The 16-year-old at class 3 or class 4 range is the usual cardiac risk factors. It's how long is your coronary arteries, but also the strength in knees. Age 5, baseline creatinine 2.8, free blood water assessment. It really, really will discharge. Better don't be sent as well. Long history of coronary disease, as I mentioned, previous damage times 4 in 2014 with grafts to the LAD, diagonal, rainless, idiot, Unfortunately, all of his vein grafts are included, and he lives on the same much the LAE, which then provide collateralization, all kinds of graft, all hands on the territory. He also has issued complete HPCI, a little bit more challenged. This for again described worsening angina despite maximally dosed medications, all limited by dose limits. And he described his life, I'll remember it forever, as living in a box where the box seems to keep getting smaller every day. His EF was 45%. He had demonstrable ischemia in the lateral, anterolateral, and inferior walls. Forgive the still images, but these are the diagnostic images. A heavily calcified RCA that was chronically occluded. This was supplied by thin left system collaterals from the Lima LAD system. Not surprising, he was ischemic. There was also some epicardial collateralization from the distal circumflex into the RPL system with a potential target for intervention up near the stenosed left main. So this was that occluded ramus branch that had a bypass graft going to it that is now occluded. And then there was this other there was this other target to a proximal diagonal branch that might have been worth considering that was isolated by an occluded left main. So when we think about peri-procedural considerations in this type of an individual, what we're thinking about are trying to identify a patient that's actually likely to benefit from the procedure that we can provide. It doesn't make sense to do an ankle surgery on somebody with a knee problem, no more than it makes sense to fix a coronary artery in somebody with shortness of breath as a result of valvular disease. So it is really important for us to make sure that when we're going to subject patients to high-risk procedures, we're doing right by them. And that means recognizing that the coronary disease is actually approachable with PCI. This is a reasonable thing to try. There is a big enough area of heart that is being isolated by this critical lesion, and that there is a complete or near complete revascularization feasibility if that is the goal. And if not, that there is a reasonable likelihood of large territory gain by opening a single vessel. And that there is a likelihood of improvement in the patient's symptoms and potentially their survival depending on the situation. And then, of course, there are additional considerations. Can they tolerate DAP? How much contrast are they going to tolerate? Both of which are important considerations in this gentleman's case. So what we did was we had nephrology see this patient early. This patient was seen by a dear friend of mine who's now a guidelines author of the cardiorenal syndrome guidelines. And even she, with whom we developed a very fruitful cardiorenal program, was a little bit nervous about this guy because his kidneys were so brittle. But ultimately we did well. We had a preoperative clinic visit with her where the risks and benefits of the procedure were discussed, where there was careful informed consent discussion documented in the chart. And in particular, we discussed the possibility of ending up on dialysis, doesn't matter what we did. Then came the multidisciplinary evaluation, where I wanted our surgeons to be able to say that this is a reasonable revascularization strategy and that there is little to no potential for a repeat surgery. Ultimately, these are the types of procedures when you're really on the edge of the benefit versus risk paradigm, that you need to have everybody's buy-in. At our current center, we have a process where whenever I take a complex PCI patient, particularly one who's going to require mechanical circulatory support, heart failure, anesthesia, and surgery all touch that file. Everybody has a documented note. It's presented at multidisciplinary rounds, and that's documented in the chart. And the beauty of that approach is nobody from anywhere in the hospital, clinical or administrative, has any issue with these patients going onto the table because they know that there are 4 layers of physicians, all of whom work very well together, that have signed off on these files. So in this case, we thought about what the best revascularization strategy was, given that he had so many targets. But what we really wanted to go after was the target that was the most likely to give benefit on symptoms with the least likelihood of needing a long procedure and a lot of contrast. And then, of course, we considered very carefully how long the stented segment would have to be in order to be able to get this done properly. And so we discussed with CT surgery. They said no because of the severity of his kidney disease and the fact that they had a patent Lima. And then we discussed primary medication adherence with the cardiologist, who felt that this gentleman would be safe on his usual antianginals and that he would be able to tolerate DAPT. And that was verified by GI as well. So then when doing the case, one considers what type of equipment they're going to need. So they're not reaching for equipment before after the case starts, right? You need to make sure your toolbox is available. Are there additional tests that you might need before you do the case so you can optimize your target and optimize your approach? And then what might be your bailout plan? These are all relevant things that can be revealed by preoperative testing. And so in our case, what we chose to do, given that this patient's disease was stable, there was no urgency to revascularization, was we got a gated, low contrast CCTA to define the nature of his grafts and precisely what we were likely to get into if we were to try to recanalize them as retrograde conduits. And then we also wanted to understand how long the areas of the occlusions were and precisely what the angles of anastomosis were to the target vessels, so we knew where to go if we were going to end up going retrograde and then trying to get into a native target vessel. So this is what it looked like. This was the CCTA. So here you can see that he had a severely calcified graft occluded going to his ramus, which was tented upwards. There was a calcific occlusion there. There was tram tract calcium in the proximal part of the ramus going into the left main. And then there was this area of contrast dropout, which was the CTO. And there was a big, juicy patent lima to the LAD with some distal LAD disease, but otherwise good runoff. So we didn't want to mess with it. And so then we did a 3D reconstruction to further define precisely where the SVG was going to anastomose into the ramus. So we started to understand that the anatomy was actually difficult to sort out because the vessel was so badly tented. This is that large ramus. This is the tenting, actually, of the native ramus up here. And this is actually the rest of the vessel. So we need to understand then that this anatomy is not going to look a lot like what we recognize from a typical angiogram. And we recognize that the area of occlusion within the SVG was actually very short. So we really only had to get through a short area of occlusion before being able to reconstruct this native vessel. Now comes doing the PCI. This is obviously a very large chart that has lots of technical details in it that I'm not going to go through, but the bottom line is whenever considering a complex PCI or a chip PCI, we've got to consider what the type of PCI is that we're going to do, what the potential hemodynamic risk is to the patient and whether or not we need any hemodynamic support. And then, of course, what the technical strategies are to be able to address the anatomic challenges that those PCIs are going to lay upon us. So what's our plan A? What's our plan B? What's our plan C? Are we going to monitor hemodynamics with a right heart cath? Are we going to use a hemodynamic support device? Or is the EF normal and is there absolutely no reason for either of those things? These are all reasonable considerations, and there are both considerations and tools that can then be used to be able to create plans, which are what you see in this table going from left to right. So in our case, our treatment plan was bifemoral access because his radials were not that great and because I wanted plenty of support, given the amount of calcium I was going to deal with. 7 French long sheaths and 90 centimeter guides so that I could go retrograde if I needed to, with the plan to monitor his right heart cath, given that he had a stiff ventricle with chronic kidney disease and he had an EF of 45%. What I didn't want him to do was get very, very short of breath. My plan was get the occluded SVG and then try to recanalize the ramus. If that failed, I could consider the epicardial collateral into the distal part of the ramus from the diagonal branch, but to do that, I would have to fix the proximal part of that big diagonal first. I didn't want to do that because I knew I'd have to stent back to the left main, and there was no way I was going to get that done and then get the retrograde ramus out at the same time. I'd have to stage them. And then we thought about whether or not we'd need the RCA, if at all, if the symptoms resolved. And so what we aimed to do was address the least risk target. And what we felt that was likely the one with a good graft to it that was with a short occlusion. So that was the ramus. So this was our setup angiogram, right? You can see that this ramus is sort of coming down here. It's badly tented. This is the occluded segment up here. This is the distal part of the ramus right here, coming down, coming retrogradely, filling from that epicardial collateral from the diag, and then there's the occluded segment. So here's what doing the PCI looked like. We got a good supportive guide in, we got a nice guide extension in, and believe it or not, with a microcatheter and a sharp pointed wire, in this case we used an Astato 20 to get through the calcium, and then we used laser to laze through the occluded vein graft, we were able to transit through that calcium without too much difficulty. And we were able to set up a retrograde base of operations at the level of the anastomosis. Now, as you recall, from the CT, we knew that there was a bunch of calcium that was going to direct us away from the anastomosis and back retrograde. This came in very handy because we were able to get a wire down antegrade past that calcium. And in this limited angiogram, you can see how badly tented this vessel is right up here, right? It's almost a 90-degree angle. And so we use that calcium to our advantage, pulled the wire back, bounced off of it, and we're easily able to get retrograde.
And that's where we are here. And then this is our retrograde wire that's crossing back into the native body of the circumflex. And this, we used a directed penetration wire, popped right into the circumflex, as you can see. And then as we advanced, we came right out into the aorta, which was the ideal circumstance. We may have had to do reverse cart at the ostium of the vessel if necessary. We were prepared for that, hence the microcatheter antegrade here in the circ. But thankfully, we got lucky and popped right out into the body of the circumflex and into the left main. And the other thing that approach told us was how difficult it was to tell the anatomy in this post-bypass patient, even with the CT, because the ramus actually came off that high OM came off very proximal. We didn't necessarily realize how far it was. Now with an anchor balloon, and after preparing the left main into circumflex, we were able to deliver a fairly long stent, as you can see, delivering, popping right into that ramus with that anchor balloon in situ. And then finally, we used an IVUS catheter set up near the ostium of the left main, and this gets tight in the 7. Okay, so it has to be a fairly small IVUS catheter. And we were able to pull the stent back and define an ostial deployment of this stent that was quite precise, so that we ended up with a nice post-stent result, right? And here's where your ramus is back. It's a big territory. The whole procedure only took about 20 cc's of contrast in a post-bypass patient with very severe calcification throughout. And then we went ahead and we popped open the vessel towards the diagonal as well. And so then in recovery, what do you do? Well, these are the types of patients who need careful post-procedural monitoring. Is there myocardial stunning? Do you have to watch out for bleeding? Have they been peri-procedurally hydrated? According to the Poseidon protocol, which we know is very important for patients with risk of CI-AKI. And have they been adequately observed? Are they stable on DAP? Sometimes these patients require a 2-week run-in on DAP to make sure they won't bleed. And then we give them the education and instructions for follow-up, both for blood work as well as to know what to watch out for. So in this case, this gentleman did great. He had no bleeding post-PCI. He reported a substantial improvement in his chest pain just with that one vessel. His creatinine improved from baseline to 1.5 at follow-up. And at 2 years, he remained CCS class 1 to 2. And so at this stage, off 2 out of 3 anti-anginal medications, he says, I don't want anything else done because now I can live my life. I don't go around running. I don't go around doing super heavy physical activity. But he did want to go out and be able to go for walks with his wife and play with his grandkids, and he can do both of those things without any trouble. So we achieved what we needed to achieve using the lowest risk target with the least amount of contrast possible. So high success rates and low complications in CHIP PCI are grounded in careful planning and information gathering. It's all about following this sort of multi-step process of carefully thinking through the procedure, selecting the right procedure for the right patient, planning it well, executing it well, and then following them up appropriately. And that framework is key to being able to get a good CHIP program off the ground so that everybody can see that you have a rational approach to what you do. Thanks very much for your time and attention.
So since Dr. Sanjog is not here for the discussions, we have a lot of senior cardiologists here who do CHIP cases. So we would spend about 30 seconds to 45 seconds from each of them for their opinion. We'll start with Dr. Raji, then we'll go over to Dr. Deepak, then we'll go over to Dr. Madhu, and then we'll go out to everybody who is prepared to volunteer. My concept of CHIP is much, much below what Dr. Sanjog has said. This kind of case, I don't think I'll be able to do, but let's see what Rajiv's got to say.
Yeah, what Sanjog told is very important because you have to plan. Just seeing a few lesions is not enough. What will happen if you do a particular lesion, and is it going to benefit the patient? Because you are going to do a lot of things which are risky, whether it's going to make a lot of difference to what is already there. That's the very important thing. So planning is the thing you can discuss with your colleagues. Then when you have a good guy who can be with you during the procedure, when even if he is not at your senior level, but he can continuously talk to you, so you'll be comfortable and you are doing the right thing throughout, and using all the appropriate imaging modalities support, cardiac support if needed. And everything should be properly arranged if you start. And do minimum if, as you said, the renal failure is quite bad, then whatever is going to be the best with the least amount of intervention.
I have Dr. Deepak's
These sort of difficult cases, having a procedure done, it's maybe at times, most of the times, it might be technically not very challenging. But then, as Dr. Rajiv has mentioned, strategizing is always extremely important. First and foremost thing, given a chance, I wouldn't take up any chip case as an ad hoc procedure. That's point number one. Secondly, would invariably have the patient admitted 1 or 2 days prior, get the surgical colleagues involved, the anesthetist, the nephrologist, all those people involved to evaluate this particular patient. Always arrange blood transfusion, start off with this particular case. That's the first case in the morning. Then we would always have a bladder catheterized, because many of us, we do most of our case without having the bladder catheterized. So invariably we'll have the bladder catheterized. Simple things like getting the defibrillator ready, all the lines, multiple lines, defibrillator ready, get the anesthetist in the cath lab. These are the things that I would prefer to have. And even going through the femoral artery, always get the probe lights ready, have the ultrasound guided puncture of the femoral artery. These are the things that I would prefer to have. And even a couple of days earlier, prior to having the procedure done, stop the antihypertensive agent so that we have a little better blood pressure on the table rather than having lower pressure, give a lot of interferon draining nitrate and nitroprusside, things like that. So these are the few things that I would also give a lot of importance prior to have these sort of patients. Technically, most of us, we would give it a try. At times, you might end up having problems with these sort of CTO cases. But then, apart from the technical aspect, these are the few things that I would also give a lot of importance.
Thank you, Dr. Deepak. We'll let out all the secrets. Now, Dr. Madhu, some secrets. And Dr. Rajshekar Babu, Dr. Anil. And finally, Karthik would conclude.
Yeah, thanks for that, Mahesh. I think when you're doing CHIP, planning is absolutely important. And as both Rajiv and Deepak has said, I mean, you have to get everything, and all the armamentarium should be available. You should have, you should not be looking at that time for whether it's an IVL or a rotablator. And finally, in our setup, I think finance has to be looked into. Only if the person is absolutely certain that, you know, they can afford something. There's no point spending a lot of money for an end of it, not get a good result.
Thank you.
I think, as pointed out, CHIP is all about planning, and I would make sure that we have all the team members around, as what Dr. Deepak had clearly found. I would like to make one warning about patients who have ejection fraction 35 to 40%. Not severe enough to warrant mechanical support, not severe enough for an IABP. You will start doing the procedure. The longer the chip goes on, you don't realize that the myocardium is getting depressed. So be wary of the 35 to 40% ejection fraction. If it's 25-30, you are prepared for it. So make sure that your procedures are not long. Stage it if required. If possible, do the second procedure after giving a gap for the myocardium to recover. These are a small few points that I have realized along the years. So Varma is our keenest, most aggressive chip of health.
Thank you. First and foremost, never do a network. Anytime angioplasties are done as ad hoc. You do the angiogram, you find a lesion, not just CHIP cases, any complex case for that matter. You find a CTO, have a temptation to go and poke it with the wire, whether the wire goes through or not. That sort of approach should never, ever happen. Always plan for the case. As Dr. Sanjog said, all the steps that he has pointed out, all of them are very, very relevant. Admission the day before, assessment by the anesthesiologist will take care of the agent of the patient so that you're not worried about any pain, discomfort, restlessness of the patient, etc. Have an extra venous and venous line in all these complex cases. Bladder catheterization has been pointed out by Dr. Deepak. I think these are all very key steps. Doing the procedure, yes, you should have the ability to do the procedure, otherwise probably you should not even attempt doing a chip. You do not have the ability to do it. I don't think you should do a chip. And then, of course, just because the procedure can be done by you, just because you have the technical ability to do it or any other complex procedure, does not mean that you should do the procedure. There should be a definite medical indication when the patient will definitely benefit from the procedure, and only then should you embark on a very complex and high-risk procedure. Only if you can document that the procedure will have some definite benefits for the patient. Dr. Werner has joined us, and maybe sir can comment on some planning for the chip.
Yeah, well, coming late and having not heard all the arguments, difficult comment. But just in general, I personally think that some lesions like chronic occlusion is not ideal chip lesion. Think more of left main, depending on maybe a RCA, CTO, where you have to risk the whole coronary tree. Singular CTO could, in most cases, be managed by good planning and treating the plying lesions before. So I think CTO in the context of the chip would be rather an exception. But there are many other situations where we are forced, for the patient's sake, to leave a CTO and first treat culprit lesion, and then I think you need support.
Okay, now we have got almost a 360-degree thing of how to go about planning and how to start. And also, the only thing I think to add on is that many times we just have to do a viability testing, know which territories to target and which one is going to give us the maximum benefit. And also, it's not a bad idea. Sounding off, because there's always CHIP CTO is going to be a planned procedure, and sounding off our experienced colleagues also, so that if anything out of foresight, we just miss out something, it'll be warned in time. I think all our senior colleagues have given us good insights, and this is not going to be a very hasty decision, but it's going to be a well planned and a decision to, because this patient's not going to get other chance if he fail. So we have to be really careful. I think we'll conclude the session, and thank you all.
Thank you very much, sirs. Quickly move on to the next session, the session on bifurcation. May I please invite the chairpersons, Dr. Madhu Sridharan, Dr. Sajeev, please, and Dr. Krishnakumar.
Good.
Once again, may I request the presenters to kindly stick to your stipulated time. I hand over the proceedings now to our state chairpersons. First presentation to be made by Dr. Shiv Prasad. 15 minutes, just 10 minutes discussion. What is?
First of all, let's thank Anil and Varma for this excellent meeting. Now, we'll go on to the first talk straight away. Dr. Shiv Prasad talking about a provisional layer stent strategy.
Good afternoon, everybody. First of all, let me thank Dr. Anil Kumar and Rajshekhar Verma for giving me this opportunity. And today we start with the bifurcation session, of which the most common procedure done for bifurcation is usually provisional stenting strategy. And this has been recently labeled as stepwise layered provisional stent strategy, the UBC. This is recommended for majority of non-left main bifurcation diseases, where the side branch lesion is less than 10 millimeters in length in left main stem, and also in non-true non-left main stem diseases. Two types of provisional stenting is available, that is standard provisional stenting strategy or inverted provisional stent strategy. As the picture shows, if the stent extends from the proximal to the distal main vessel across the side branch, it is standard. And if you happen to put the stent from proximal vein vessel to the large side branch and a smaller distal main vessel, which can be now the assigned side branch, then it is inverted provisional stenting strategy. stepwise layered. What does it mean? It is actually explains the versatility of the procedure, where you can adjust the procedure plan according to the complexity of the lesion, starting with an idea to implant a stent in one branch and if possible leave the other branch undisturbed if it is flowing well. But in case needed, you need to stepwise implant the second stent in the other branch, only and only if it is required. When will you consider that I should respect the side branch? If the diameter is more than 2 millimeters, it is more than 73 millimeters in length, that means it is likely to supply more than 10% of the myocardium, or if the operator is unwilling to lose the branch considering the patient's anatomy. Most common causes are the carinal shift or longitudinal plaque shift, the reason for side branch compromise. There are certain predictors by imaging and even angiogram. The spiky carina, as you have already listened to Vijay Kumar sir. Then high lipid content in main vessel lesions, contralateral location lipid in bifurcation area, narrow carina tip ankle, by the branching point to carina tip distance less than 1.7 millimeters, a calcified plaque in the main vessel, or severe disease of both branches, at lesion length, bifurcation angle more than 90, and thrombus containing lesion. And this is certain scoring systems are available. Resolve study have shown this scoring system where the score more than 10 is likely to have a compromise of the side branch at 20%. So you can take all those things which you have listed now, that plaque distribution, TIMI flow in the main vessel, pre-procedure diameter stenosis of the bifurcation core, bifurcation angle, and diameter ratio. All these things determine the score, and the higher the score, the more likely that the vessel can get compromised. This is the definition criteria to respect the side branch. That major criteria, one major and two minor criteria will give you this scoring point. And these are the ones which are given by the EBC as the risk factors for possible compromise of the side branch. This is a prototype case where proximal LAD has got a disease and a large diagonal is arising from that. Seemingly the ostium of the diagonal is not showing much disease, and this is Medina 112, 2.5 millimeter diagonal, and the angle is around 50. What should we plan? It was planned before entering into the procedure. You should plan the bifurcation anatomy very well. Study the bifurcation anatomy, the lesions, the distribution in calcium, if any, and then plan for the strategy. Here, the professional stenting strategy was planned. This is considered in 3 stages. That is, stage A is wiring the both vessels. Usually, it will not be that difficult, but there are situations in which the side branch wiring or the main vessel wiring can be difficult if there is a complex anatomy like calcium or bends, tortuosity. So then you may have to modify the tip of your workhorse wire, either 2 to 3 millimeters from the tip, or 4 to 5 larger tip, or single wide bend, or double bend, or dedicated tapered tip hydrophilic wires like Fielder family. Then calcium modification techniques are sometimes needed to have a pre-dilatation, or then in cases of where retroflex origin of the branching point is seen, you may have to use a hairpin technique of acute and retrograde pulling back of the wire so that it will get into the lumen, and then you can wire the side branch. Then you can use dual lumen microcatheters or angulated microcatheters, deflected microcatheters in case you find difficult to wire the side branch. It is always the principle is you wire the side branch which is more complex to wire first, so that the problem of the wire wrap can be reduced. After wiring, you prepare both vessels. Both vessels means the main vessel should be prepared, and the side branch vessel should be disturbed only if you think that there will be a compromise of the flow or there is more than 90% lesion in the side branch. And here we have prepared the main vessel, and then IVUS was done in this case. Both this shows that the lesion, the main vessel has got a bridge beneath, and after that the lesion, which is around 16 millimeters in length, and good landing zones with the bifurcation point. And the ostium of the diagonal is not having that much disease. Now we decided to go the next step, that is stage C. This is actually inclusive of 5 steps, in which the first step is stenting the main vessel. It is the important point is you always size the stent matching the distal main vessel diameter, and always use a jailed wire so that you have a clue to the side branch. And the proximal end of the main vessel stent should be at least 6 to 8 millimeters away from the carina so that you can do a pot. After step 1, implanting the stent, the next mandatory step is a pot, proximal optimization, which is done in this case with 3.5 in a non-compliant balloon. And we now have balloons which have very minimal overhang, that is port balloons which we are using now, so that you don't have to compromise to the proximal to the stent. Now, you can use methods to protect the side branch. Most commonly used technique is jailed wire. But there are certain methods of active protection of the side branch. You can use a jailed balloon on the wire, or you can use a balloon stent kissing. You can use a modified balloon dilated side branch ostium and the main vessel stenting. You can use a semi-inflated balloon, that is which we call as balloon embedded technique, or a jailed crosshair, which is active protection. Sometimes after implanting the stent, you may lose the side branch. In that case, you have certain troubleshooting. You can use wires, regular wires with different shapes you can try, then hydrophilic coated wires you can try, or pre-shaped wires or CTO wires can be tried, or you can use an angulated catheter to aid in tracking to the side branch, or deflectable microcatheters can be used, or you can use a small balloon through the jailed wire and open up and then try to finish the job. Here we implanted the stent and can see that there is some pinching of the side branch. We analyzed it further and found that the FFR is low, 0.73, and we want to do an IVUS on this, and the IVUS showed the ostium of the side branch is actually 1.82, that film is not there, 1.82 millimeter square, and there is a definite plaque shift. With a reduced FFR, we wanted to have preparation of the side branch with the side branch kissing balloon, with dilatation of the D1 with the 2.5 millimeter NC balloon, that is 1:1 size of the side branch, along with the kissing balloon, which is diameter matching the distal main vessel 3 millimeter. And this is done at 12 atmospheres, and then the proximal port was given. After the proximal port, I was run after the kissing balloon showed the fully expanded main stem stent with an achieved area of 5.92 distally, and proximally it was 8.8. Then the diagonal ostium after kissing is 4.22 millimeters with a good flowing diagonal. So this is the final picture you can see. Usually the provisional stenting procedure can end after implantation of the main vessel stent, provided you have a good flow in the side branch. There is only compromise of the side branch flow, then you do a functional assessment, and if the functional assessment shows a reduction below 0.75, you may intervene by dilating the ostium of the side branch. Seldom you require a stenting in the side branch, but in situations where the side branch, after ballooning, the side branch flow is not acceptable, then you may have to resort to provisional side branch stenting. This I took from Relax flow chart. Here you can see that what type of stenting strategy we can adopt after provisional stenting of the main vessel, maybe a reverse thrust culotte or tab depending upon the ankle. And here is one prototype case where I had to do our strategy was, you can see that there is a lesion, the proximal LAD and diagonal, and also there is a ramus inside. All the three vessels are having disease. And this is true Medina 1-1 lesion, and main vessel is 3 millimeters in diameter, and there is a discrete disease at bifurcation. Bifurcation angle is about 55, and the size of the side branch is assessed to be 2 millimeter, and there is ostial lesion which is extended to 16 millimeters. We planned for a provisional layered stenting strategy, but we were worried about whether we predilate the ostium of the side branch because almost 90% diseased, Ramus intervention, all these were issues, and we proceeded with stenting the main vessel after preparing both vessels. Here, we dilated both the side branch, the ramus and the main vessel, and then we decided to keep a balloon in the side branch and partially inflate it and deploy the stent in the main vessel. After deployment, we removed the balloon and we optimized the main vessel stent and then rewired. Before post-dilating the main vessel stent, rewired, and there was some difficulty in rewiring. Probably that must have caused some dissection of the side branch or maybe the previous dilatation because the lesion was very tight. So after seeing that the side branch has got a nasty dissection, we decided to go ahead with the protecting the side branch because that was the only diagonal which was available, and all other there is only another diagonal seen which is lower down. So we decided to protect the 2.25 millimeter stent. After dilatation, we can see that this technique used was reverse mini crush with the balloon inside the main vessel and just the minimal protrusion of the stent to the main vessel, and we implanted the stent, crushed the ostium of the stent which is protruding into the main vessel, and we got an excellent result. So proximal stenting, the basic steps: 1, identification of the coronary bifurcation lesion. You assess the main vessel, side branch, or assign side branch lesion characteristics, angle of the bifurcation disease. You look for any calcification, flow in both vessels, area and importance of the vessel to be assessed before deciding on the strategy. One strategy will not fit for all bifurcation diseases, but provisional will be successful. Provisional stenting will be successful in most of the cases and is the preferred strategy in a bifurcation lesion. 3 main stages for the provisional stenting strategy. 1 is wiring both vessels, preparing both vessels in case the side branch is having a tight disease, otherwise should not disturb the side branch, and stent the main vessel, preserving the side branch. What is important here is proper sizing in the main vessel stent, which is tuned to the distal main vessel diameter. Precise spot are the key to success in avoiding the side branch compromise. Rewire if it indicated through the distal strut, and should make the bifurcation procedure as simple as possible so that you will not land in problems. Thank you very much.
Nice, Dr. Singh. So this is a couple of things. Now, of the definition criteria, which are the ones which you think is the most important one when you would think of 2 stents versus provisional?
The one is the size of the vessel, size of the side branch. If the size of the side branch is 2.5, definitely, and it supplies more than 10% of the myocardium, the length more than 70 millimeters, 73.
Now, when would you think of a provisional rather than a 2 stent?
If the lesion in the side branch is less than 10 millimeters, if definitely less than 5 millimeters, I do not consider upfront 2 stent strategy. I'll go for a provisional.
Would you do a kissing balloon for all bifurcation provisional, or would you just leave it with just the main vessel?
No. Kissing at the end.
Kissing balloon inflation, if it's a provisional and a good flow in the side.
No, it is not mandatory that you should be kissing all the provisional stentings to the side branch. Only if the side branch is compromised.
In your practice, would you do it?
No, I do not do in all cases. I do not do in all cases.
What is your experience with this balloon embedded technique?
Now, I think Dr. Vinay Kumar is not here, but I am also using in large number of patients balloon embedded technique, and more than 300 I must have done, and analysis showed I had problems only one in retrieving this balloon. That too is an ox balloon. If you use a new balloon, I never had any problems with retrieving. And what I have seen is recrossing to the side branch is much more easier when you keep a partially inflated balloon. I do not fully inflate the balloon, go up to 2 to 4 atmospheres and keep it there, and that to one size less, just to keep the ostium patent. But I have not have a randomized comparison between the jailed wire and versus embedded balloon, but I think it is technically more easier to recross.
Because one of the sides of the vessel is side branch is significant. This balloon embedded technique may be really useful in clinical practice. If you're taking a
We are regularly using it in the medical college.
With a balloon embedded, we are also using that. If the lesion, side branch lesion is not significant or long, it may be very useful. And I think I didn't have postally up till now any difficulty in retrieving the balloon.
Even retrieving the balloon, it's not a problem. Usually, one important problem is if you use aux wires, aux balloons, and then maybe it becomes a problem. If there is calcium, proximal well, some calcium, then there could be a problem of entrapment of the wire or the balloon. That is there. And when you retrieve the balloon, always make the Duhibo loosen and then retrieve it. Otherwise, the guide can get sucked into the proximal LED lesion and can cause problems, the deformity, longitudinal deformity of the stent. In mainstem also, we have used balloon embedded techniques for the circumflex and stenting from the LM to LAD.
Maybe it is easier to use in the mainstem because larger.
the main vessel with the balloon on the side, or do you go the high pressure only after you take out?
No. The thing is, I inflate the side branch balloon first to 2 to 4, then implant the stent, then deflate simultaneously and remove the side branch balloon and then go to optimal pressures again, so that whatever deformity I caused by pulling back the balloon is reshaped back to normal. Then you remove the wire, rewire, after proximal optimization, rewire, and then try to optimize the main vessel stent.
Thank you. That was a wonderful presentation. Which kind of balloon do you keep for side branch? Is it the NC balloon or a semi-confined balloon? I mean,
if you're you're asking about balloon embedded technique, in that case, I use only a semi-compliant balloon because the new NC balloons are bulkier.
Thank you, sir. That's a nice talk. We'll go on to the next one. It's Dr. Varma, Culotte steps.
Good afternoon. Let me straight away go into my topic, bifurcation angioplasty with the Culotte technique. Culotte stenting is an important technique of the two-stent strategy, as you all know, popularized by Chevalier way back in 1998. From 2% in the COBIS 2 registry to 66% in the Nordic Baltic bifurcation study 4. So that was the increasing popularity of the Culotte stenting. The original technique involved stenting the main branch first, used bare metal stents, and there was no pot. And it was also compatible with provisional stenting. Provisional stenting, if you wanted to do a second stent, you can convert that into a reverse culotte. Of course, that's not described as a technique for bioresorbable scaffolds. So when do you use culotte stenting? In a true bifurcation, when within a 1-1x1-1-1, need for a two-stent strategy, you need to stent the side branch first. Generally, that is the general current practice now, to stent the more angulated vessel first. If it is an important vessel, if it is difficult to wire the side branch due to angle, ostial disease, or the extension of the disease beyond 10 millimeters as stressed in the previous talk, or if you want to do a crossover from the provisional strategy, if you have a narrow angle of bifurcation, and if you have similar sizes of the main branch and the side branch. The narrow angle of bifurcation is important because you don't want to strain the metal too much, if in case of a wide angle. And again, you need similar sizes. That was a requirement in the past, not so much of a requirement now because the current stent manufacturing techniques are so good that you can expand the stent to quite a high diameter. You need to know the stent expansion sizes also. So how do you do? So the first step, as in the provisional strategy, is to wire both vessels. So this is an example of a bifurcation, true bifurcation in the LAD diagonal. You wire both vessels, then you dilate both vessels. And then you deploy the stent in the angulated vessel, usually the side branch. So once the stent is deployed, you can actually withdraw the balloon a little bit and then dilate at a little high pressure so that the main vessel the ostium of the side branch is well covered. The degree of protrusion into the main branch will depend on what type of culotte stenting you are doing. The next step is the most important, that doing a POT, a proximal optimization strategy, because the stent is sized to the side branch. And the main branch is, the proximal main branch is generally bigger than the side branch. So you need to do an optimal POT. Once you do that, it's very easy to bring the wire from the side branch, cross through the struts into the distal main branch. Once you do that, there are instances where you can use the same balloon to dilate the struts. But again, generally you need a smaller balloon first, and then you need progressively higher sizes of balloons and optimally dilate to make an opening from the side branch into the main branch. The next step is to send the main branch through the side branch stent into the distal main vessel. So you take the stent across, and the stent is again sized to the distal main vessel. So again, you need to do the POT proximally to optimize the sizes. Again, the optimum POT will ensure that the recrossing of the wires again becomes easy. And now we have opened the struts to the side branch with another balloon. Again, the serial balloon dilatation may be necessary to achieve a good opening into the side branch. That should be the diameter of the ostium of the side branch. Once you've done that, you can do a stepped kissing balloon dilatation. You inflate the side branch balloon first, and then you go up on the main balloon, and then you do a simultaneous kissing balloon inflation. After that, you can do a final POT, and then you see the good results. So here the most important thing to remember among all these steps is that the wire that you use initially for balloon dilatation and stenting in the side branch is the wire that you are going to use in the main branch also. And that single wire has to be maintained well. And that is the important wire on which you are going to do all your work. The other wire is just going to be there. So in an LMCA lesion, this is how a pre and post image would look. In an LCXOM, this is how the pre and post imaging would have looked. In an RCA distal bifurcation CTO, the initial step was to cross CTO. Bilateral injections were used. And then after culotte stenting, you get very good results. Again, you can preserve the branches, the PDA and the PLV are preserved, and you get good results. So this is a video from the Medtronic visible heart. This is in an animal model where the stent has been deployed. You can see the stent from the side branch, from the main vessel. You can see the side branch ostium which has been jailed. This is a main branch too, distal main branch stenting that has been done. That is on the left-hand side, you saw the ostium of the side branch. Now this is the balloon which is going into the side branch, dilating the side branch ostium, making an opening. You can see how the struts have been pushed apart. And then you take you can see the opening of the struts. Then you take the wire in from the side branch and push it into the main vessel. And then you take the next stent and you do the stenting from the main vessel into the side branch. This was the original culotte stenting, where the main branch was stented first and the side branch was stented next to that, after that. So after this, you can see that there are two layers of stent in the proximal main branch. There are struts across the main vessel, or the distal main vessel. So you need to wire that. After the POT, you can wire that and then use a balloon dilatation to push away the struts again. So that is being done now. Yeah. So once that is done, proximal port will help. One important thing is here to remember here is that you may have difficulty in crossing because of wires getting wrapped with each other. So wire wrap has to be sorted out and carefully managed outside. Now you can see that both branches have been open. You have a good carina which has been covered appropriately. There's no failure in covering the carina, and you have good optimum results. So OCT has been used, even IVUS has been used to, and there's a structured protocol which has been described in the October trial, where OCT has been used after the pre-dilatation. OCT has been used after each rewiring from the side branch to the main branch, from the main branch to the side branch again, and then final OCT, and this based on a checklist. So this is a LED diagram by Medina 011. Side branch stenting has been done first. So this in the side branch, the pre-stent OCT assessment to whether sufficient pre-dilatation has been done, the stent and the port sizing, and measure the reference sizes. So all these things can be done. The port balloon has been used in the proximal part, which has been determined to be 3.5 millimeters, proximal main branch size. The initial rewiring was to a proximal strut, and that has been pulled out and recrossed at a little more distal strut that has been identified by the OCT. The OCT again after rewiring. The OCT in the main vessel after the kissing balloon dilatation. And then after the stent has been put, to do a final OCT, you find a single bridge of jailing struts, which may or may not be pushed to the side. And then the final OCT, you can look at the expansion. You can identify optimal stent expansion by having a minimal luminal diameter more than 90% of the reference in both the main vessel as well as side branch. So the challenges that occur are basically in rewiring and recrossing. Unfavorable anatomy, maybe because of the large discrepancy in size between the side branch and the proximal main branch. Dissection of both branches after pre-dilatation because of the risk of vessel closure during recrossing. Difficulty in rewiring may be because of side branch crossing proximal strut. Use a second wire or prolapse a pullback from the distal strut. Prolapse pullback and use a distal strut cross with a balloon tip guidance. We can use a main branch proximal underexpanded stent, which can be a cause, and port and IVUS will help in identifying this. In case of wire wrapping, we need to exchange the wires. Difficult balloon crossing may be because of wire wrap. Again, you can change the wires. You can also advance both the balloon and the stent simultaneously on both wires. This is a technique which has been popularized by Dr. Sameer Sharma, where the wire wrap can be overcome when you advance both two balloons on each wire simultaneously. If you advance, then you can probably overcome the wire wrap. The main branch underexpanded stent can be overcome by port, and the strut over the side branch, you can use a balloon or a second wire, open the cell stent with routed struts. Potential problems include a need for similar sides of main branch and side branch. Multiple steps are there. You need to remember all the steps and follow the steps very accurately. You need to recross at least twice. You need the good hardware. You can find a circular under expansion bend, but that can be overcome by appropriate balloon dilatation with non-compliant balloon at higher pressures, appropriately sized balloons. Malposition of these stent struts again can be overcome if you use good imaging and use appropriate size balloons. A greater degree of stent thrombosis, TLR and MACE has been described in some trials, but a careful attention to heparinization during the procedure and careful follow-up and good imaging guidance to ensure optimum stent sizing and placement and expansion, avoidance of malposition, all these things do help. Modifications of the culotte technique include the reverse culotte, which is now the standard technique which is being described. Imaging guided culotte, we have seen OCT can help give a very good optimum procedure. mini culotte is when you have very minimal protrusion of the side branch stent into the main vessel. And you can have a balloon in main branch during the side branch stenting. That is another modification that has been described. A double kiss mini culotte has been described by Fan et al. In 2014, which is probably now the procedure of choice because it ensures that the ostium of the side branch is well covered. You can have a very good entry and cross from one vessel to the other. Here, the initial kissing balloon is done after the side branch stenting. You have a balloon in the side branch and you have a balloon across the struts into the main vessel. You do a kissing balloon dilatation there, and then you do the final kissing after the main branch stenting. So the first kiss is after the side branch stenting, and second kiss are the final kiss after the 2 stents. So this has been associated with very shorter metal carina length, a shorter maximum distance of Malapose stress, and and much smaller side branch ostial area stenosis. So these are the decides that you need to remember for overexpansion. Most of the stents have 3 different categories. They are basically 3 different sizes, and depending on the balloon size, the balloon diameter, the stent goes up to the particular diameter. So remember that the newer stents can go up to 5.5 or 6 millimeters very easily. You need to remember that there are very few balloons which are available which have 5.5 millimeters and 6 millimeter sizes. So you need to have those balloons on stock. So thank you very much. This is a very short practical guide on culotte stenting.
Yes, Varma. When you do a culotte, then which modification of culotte do you use now? Is it a DK mini culotte or?
Yes, wherever possible, the DK mini culotte is probably the procedure of choice because of all the advantages of the
would there be any concern about the stent size? Because the napkin ring is a possibility when you have when you can't overexpand the stent.
Yes, that was a problem I think in the past. But with the current generation of stents, I don't think that is a problem anymore because the stents can really be oversized to 5.5 or 6 millimeters. So getting an appropriate expansion is not a real problem as of now.
Now, the napkin is at the side branch because the opening is the side branch to a higher one. So all the same, the overexpansion is for the proximal part, which you can overexpand. But for the side one, is there any particular type that you use or any of them is fine?
Yeah, the side branch, again, the cell size can be expanded when you have an open cell structure. When you have the newer stent generations, these do achieve very good stent sizes, and you don't have napkin ring appearance unless you have not sized the side branch balloon appropriately.
Even with DK mini culotte is the discrepancy in size between the main branch and the side. There should be a reasonable equality of sizes, isn't it?
That is the general criteria. Again, that is not really applicable when you have good stent sizes of the current generation of stents. You can have a 0.5, 0.75 millimeter mismatch, and that is really not a problem. And a proximal size of even 1 to 1.5 millimeters, again, not much of a problem with the current generation of stents. We don't find so much of a distortion when you use some imaging.
Do you routinely do imaging or?
Routine imaging is a very difficult practice in our setup, considering the costs. But wherever possible, wherever the resources permit, we do imaging. OCT is generally the more preferred choice with OCT staining because you can identify which strut the virus crossed. They can identify the complications. I think the position, all these things are better seen in OCT. The post-stenting evaluation is much better with OCT. So I think wherever possible, it's better to use OCT.
Well covered.
Yeah, 2 points. One is that the concept of pot, side pot, repot gives you a better concentrically shaped side branch as compared to a kissing balloon. So this concept is replacing kissing balloon in a bigger way, and you'll end up with a better result and lesser number of steps. That is one point. Second point is you have a dedicated side branch stent which is available in the market. It's phenomenally good because of the two things that has been said by the chair. One is that napkin ring. It doesn't happen because there is no closed cells at the junction between the main branch and the side branch. They're just connectors, so there is no napkin ring. Second is size discrepancy. So when I use a side branch stent, I use a 3.5, 2.5 side branch stent. That means the side branch is being covered with the 2.5 closed cell towards the side branch. From the ostium of the side branch into the mid part of the main branch is just connectors. There are 3 connectors only. And then there is a closed cell, which is at 3.5. So I get this much of size discrepancy can be covered with the one dedicated branch stent. It's actually very good, but not being utilized because probably people are not used to it. Try it out. If it sticks, then you may just replace culotte with the side branch.
Dedicated side branch stent is definitely a good option. So the limitations are the lengths that are available. So you will need an extra length of the side branch stent if the size doesn't match. I mean, the length doesn't match. So that was the only difficulty. Again, of course, the cost is also an issue. But
the same cost is a normal fit.
Yes.
Same cost, and length is now been increased from 9 to 26.
Yes.
So, two things there, Mahesh, your question. The side pod, the distortion of the main stent would remain, which is one of the reasons why they say kissing balloon would still be better than a side pod. That is a Penn study which showed that.
That's my presentation tomorrow.
And the second one about the dedicated side branches, you would finally end up with 3 stents, while in culotte you have 2 stents. No, you would need one for the distal stent one and one across the main, apart from the side branch stent, isn't it? The side branch is only 2.5 there.
2.5, and it comes into the main branch is 3.5.
Yeah, and you would need another, if the side branch is long, you would need another side branch.
That is the previous 9 millimeters. Now it goes as much as 26 millimeters. You just need to take the side branch of your choice. 19, 16, 26.
The pod side pod versus the kissing balloon versus pod has not yet been studied in trials not in good enough numbers, and we still the jury is still out on which is superior.
Right, Parma. Thanks. Thank you. Great talk. Now we'll have the last talk of the session. That's DK Crush, Rajiv.
So, bifurcation stenting, DK Crush. The aim of any bifurcation stenting technique is to accomplish a satisfactory final minimum stent area, both in the main branch as well as the side branch, which translates into appropriate and reliable long-term clinical outcomes. The side branch in bifurcation disease. As Madhu earlier asked, what's the important side branch? How do you define a side branch is important? One is the size of the branch, then the area of myocardial supply, and whether it's a contiguous territory. For example, if there are 2 diagonals, then if there is only one diagonal is already occluded, then the other diagonal becomes very important. Or if it's a PLV is occluded and the OM is occluded, then again it's a contiguous territory. So that branch becomes more important. Sometimes some branches can be small, but still very important, like a single large RV branch or a synodal branch, which can cause occlusion, which can cause sometimes hypotension or bradyarrhythmias. Then how does the side branch get occluded? This is something called a carinal shift or a plaque shift. Generally, it's both, which causes a major side branch occlusion. This is how a carinal shift happens. When you have an very low angulation, small angulation of the side branch, when you dilate, put a stent in the main vessel, that carina can shift towards the side branch and cause a carinal shift and occlusion even without a plaque shift. Whereas if it's a 90 degree, there can't be any carinal shift. If it is obtuse angle, it's even better. There won't be any carinal shift. And the tackling of the side branch, default strategy is a single stent with provisional stenting of a side branch if the TIMI flow is less than 3. Upfront 2-stent strategy when the important and big branch with significant side branch, that is more than 10 millimeter, or if there's a dissection of the side branch, or there's a large branch with an acute angle where you can use a technique like decay crush or a mini crush. This is the ABC approach to treatment of a complex bifurcation lesion using the peripheral stent strategy. I'm not going to that because it has been dealt with earlier today. Then there's the definition of the criteria for complex bifurcation lesions. If it's a major criteria, LM with side branch lesion more than 10 millimeter and side branch diameter is more than 70%. If it's a non-LM, side branch lesion more than 10 and the side branch diameter is more than 90%. And there are a few minor criteria as well. So I will go to the technique, a topic proper of decay crush, how to do a decay crush, what are the various steps of doing a decay crush. So first, you wire both the main and the side branches, then prepare the lesion very well. Especially if you have a problem with the ostium of the side branch, if it's calcific, if it's a fibrotic lesion, you may need to dilate it with maybe a cutting balloon. So the lesion has to be prepared well so that the stents will open up very well subsequently. Then the side branch is positioned, the stent is positioned with about 2 millimeter into the main vessel, and keep an uninflated balloon in the main vessel. That's very important. And of a size which is about the size of the proximal main vessel. Unlike in normal cases, the balloon has to be big enough and should be sized to the proximal vessel. So you deploy the side branch with 2 millimeter into this. Then you remove the balloon as well as the wire in the side branch. Then you have to crush the stent with the balloon in the main vessel. You should never undersize it. Very, very important step. Then after that, you have to recross the side branch through the proximal strut. Again, different from a normal strategy where generally it's a distal strut which is being used. Here you have to use a proximal or non-distal strut so that you avoid going through the side and beyond the distal. You can go out of the stent. So you have to try for a proximal or a non-distal entry. Then you do a kissing balloon. This is the first kissing balloon. Again, size up according to the size of the side branch as well as the distal main vessel. Then you remove the wire, then deploy the main stent. And the main vessel stent again sized according to the distal stent. Then you can have a port, a proximal optimization, and again recross through a non-distal strut in the side branch. Again do a kissing balloon and the final port. So these are the various steps of a double kiss crush technique. Okay. So this is a mini crush technique where some steps are much less, and this called the classic crush where there are a lot of metal was inside the main vessel. Now after that it became mini crush. Now it's nano crush. This is what I'm generally trying to achieve. You have to just cover the upper end of the side branch and a minimum of maybe about a 1 millimeter into the main vessel and then the lower. But depending upon the angulation, it can vary. If the angulation is very much angulated, then you'll have more struts at the lower part. So there have been various trials which have shown that the decay crush is probably one of the best techniques if you are going for a two-stent strategy. There have been many decay crush trials, decay crush 1, 2, 3, and then DK Crush 5, then Definition 2 trials, all showed that there is a significant benefit with either provisional stent strategy or other strategy like Coulomb. So the messages: decide on the importance of the side branch, then judge the likelihood of side branch occlusion, and wire the side branch, size the main vessel according to the distal vessel or the selection of the stent, then decide on the provisional stenting versus upfront two-stent strategy. You can utilize upfront two-stent strategy in complicated side branches. I have shown you earlier how you define a complex, not complicated, complex bifurcation. Then DK Crush has the strongest data, and kissing balloon and POT are very important, and imaging, especially OCT or HD IVUS, can give valuable inputs. I will show a case of a 69-year-old gentleman who had a bifurcation lesion of the LAD diagonal. The median 0.11, and the angle is about 40 to 45 degrees. So both, and he had also other lesions like OM1 lesion and mid-circumflex lesion as well. So there were 4 lesions: the LAD-D1 bifurcation, then mild ostial LAD lesion, ostial circumflex 50%, OM1 90%, about a 2 millimeter vessel, and mid-circumflex 75%. As was fairly all right. And the strategy for LAD-D1 was, LAD was about 3 millimeter, D1 2 millimeter, LAD-D1 angle 45 degrees. So the options were nano or mini crush or DK crush. And Coulomb was out of option because of the gross size mismatch. And for the circumflex lesion, ostial to mid, there are 3 options: ostial to mid circumflex and OM1 bifurcation, or stenting of mid circumflex and ostial to left circumflex to OM1. I chose the second one, and leaving alone OM1 was another option. So we wired both the D1 and the main LED, then prepared the lesion with balloon dilatation. Then the side branch stent was selected, the 2 into 15 millimeter stent, about 2 millimeters into the main vessel. Then that was deployed, and after deployment, and the balloon was withdrawn and dilated to slightly high pressure so that it opens up very well at the ostium, the side branch. Then the side branch wire was removed, and the balloon removed. Then this is the crushing of the stent, side branch stent with a large balloon in the main vessel. Then after that, crossing the side branch through the proximal strut. Then I had some difficulty in crossing the side branch with the balloon. So I used a Nick Nano to cross dilate. Then did the first kissing dilatation. And by this time, I thought I'll finish the circumflex before finally deploying the main stent in the LED. So I did the mid circumflex and the circumflex ostium to OM1. Then after that, brought this is the optimization of the proximal part of the circumflex stent. Then the LED stent was positioned from the ostium. And again, this final, again, second kissing dilatation. Then the final port. So this is the final result with a. Then this angiographic result was confirmed with an OCT. So this is that side branch, this is very well open, and this is proximal LAD. Again, this is the opening of the diagonal ostium. So the steps of DK crush, finally, to recap once again: extending of the side branch with 1 to 2 millimeter protrusion to the main vessel, main branch balloon crush, proximal wiring of the side branch through the crush stent, first kissing balloon inflation, removal of the balloon and wire from side branch, extending of the main vessel, port, side branch wiring, final kissing balloon, and final report. The DK crush stenting technique has a better side branch ostium stent coverage and apposition, and 100%, near 100% final kissing balloon inflation success rate when compared to other bifurcation stenting techniques. Probably the good result of DK crush compared to some other techniques is because the near 100% final kissing balloon dilatation. In many of the early trials, after the classic crush, the ability to do a final kissing balloon was about in the tune of about 60 to 75%. So DK crush is a technique with robust data and gives gratifying results. However, it's a challenging technique which needs more time and patience on the part of the operator. So I generally do more of nano or mini crush because it saves time. But if you have time and the time, then you can do it. Thank you.
Thank you, Dr. Raji, for the excellent presentation with the pictures. I just have two questions to ask. For the first crushing of the side branch stent, do you size it to the distal or the proximal?
Proximal, you have to size it proximal.
So if the proximal one, will there be a chance of dissection distally if you have a larger balloon there? Because that place is unstended.
Yeah, but you have to crush it very well. In case it dissects, then you might have to put a larger stent. But it just generally doesn't dissect. Though theoretically we say that we always size it to the distal. But here the crushing is so important. As many people, as Madhu himself would have experienced it, crushing is so important. Because if it is not crushed and part of it is extending into the lumen, that's bad. So your recommendation is also for proximal sizing for the balloon.
If the stent, when you do the first crush, and if there is a significant dissection in the main vessel, will you have to will you have to go away with the first balloon? First kiss.
No, if it's a dissection, then you might need a longer stent. That's all.
No. If there is a dissection in the main vessel after the first crush, then you will have to do away with the first balloon kiss there. So you will be obliged to put a stent in immediately if that's significant flow disturbance.
You can always.
I think Raji, there's a bit of what Manu is saying. So you have to first go with the distal balloon, and then probably you have, especially with the left main, you have to have a step kiss. So go with the LAD size stain for the distal one, and then take a left main, and then go with the higher pressure to crush it fully. So
that can be done. So you don't need to go beyond that carina.
Because the size research is what he's saying. If you take a proximal, you can have dissection of that.
Yeah, that can be done. But generally, this is enough. But if that's a major concern, then you can do up to the carina.
Now, in all the bifurcation trials, you say, like, if you're doing a provisional, you can do a T-tap or a culotte.
Yes.
But a mini crush or the crush is not to be done in many of the trials. And one of the reasons why I say the mini crush is not to be done, is probably because there are more number of MIs in the mini crush group. Could you reason on why it's so? Because many of
after provisional stent, you mean?
Yes, when you do a mini crush, the MIs are more, which is why in the ABC they say the mini crush is not recommended. If you are doing a 2 stent after a provisional, you can do a T-tap auriculate. A mini crush is not recommended. In fact,
it won't become a mini crush. See, once it's a classic mini crush, you put the stent, side branch stent first now. So after, if it's a provisional, then it's basically, the technique is same. It's called T, is really not T. It's something like a reverse mini crush only.
The reason they say is that you have a slightly, in all the mini crush group, they had a higher incidence of MI. Probably because it kind of came more in and probably more starts there or whatever.
That's, you have to limit the metal there. So that's why I said in most of the elective cases, nano crush or maybe just 1 millimeter.
In the case which you showed, I mean, you did a circ to OM1, which is brilliant. Yeah. Why did you just put from left main to LED? I mean, you could have had a better result, because you had said that LED had minor plaque.
No, there is not much distance. You see, it's fairly proximal LEDs. So there is I generally don't leave 5 millimeter, 6 millimeter proximal LEDs. Whenever I've done that, generally the resonance happens proximal to that. So if it's fairly close to that, I put from the ostium. But it's also possible I could have put a slightly shorter stent also.
I don't know whether this question is okay or not, but what type of stent do we now recommend for the side branch in a DK crush? What type of stent?
What type?
No, that's not that.
For this side branch, anything is fine, I think. So you have got some 61 millimeter to 81 millimeter thickness stents. Yeah, crushing is generally not a problem with all these stents, even the 81 millimeter stents. Crushing is not a problem.
One doubt regarding POT, sir. In some diagrams, it is shown that the distance distal to the side branch is also covered. In some, just proximal to the side branch is covered. So POT should cover only the proximal part to the side branch, or the area of the side branch and the proximal part?
Up to the carina. No, don't go beyond the carina, that's what.
But in some diagrams, it's shown.
Yeah, for the DK crush, generally use a balloon size to proximal. But the normal POTs, the technique of POT, you have to keep just above the carina.
Just above the side branch.
Carina.
Above the carina.
Maybe for DK crush, the sensor good only if you do all the tests.
Yeah.
Okay. So in achieving all steps, I don't know whether it is.
Yeah, final kissing balloon is very important. Then the final POT is also important, because after the final kissing balloon, it may be a little oval shape, and that oval shape is made into a round shape by the final POT. So all these steps will have to be meticulously undertaken.
No more questions. Thank you, Rajiv, for a very nice talk. We can come to the end of the session. Thanks a lot.
Thank you, sir. Thank you to our chairpersons. Move on quickly to our next session on CTO. I'd like to invite chairpersons now. Dr. Gerald Werner. Welcome, sir, to India. Dr. Rajashekar Verma.
Dr. Anand Gyanraj and Dr. C.B.I. Singh, please. Again, in this session, our first presentation is by none other than Dr. Kalra. May I hand over the proceedings to our chairpersons now? Over to you, sir.
Good afternoon. We start the CTO session. Dr. Sanjog, who had the initial talk, is unfortunately held up. I mean, despite our best efforts, he could not get the visa in time. So he is right now shuttling between two airport terminals, then is unable to come online. But he has sent us recorded lecture. He said he'll try to log in online by around 6 p.m. So we'll have his talk at that time, and where he can probably respond to some queries. So the first talk, I think I invite Dr. Sharath Reddy from Hyderabad. This is on antigrade wiring, the techniques of antigrade wiring.
Yeah, good evening. Thank you, CHIP organizers, for bringing me to Cochin again. So, my talk is on antigrade wiring and tips and tricks and techniques. So, if you look at any algorithm, the presence of clear cap and clear distal vessel are the fundamentals needed for antigrade wiring. And the vessel course is also important, which you should know to cross. You can see here, so there is a clear cap. So there is a clear cap in the CTO, and also the distal vessel is very clear. So you know where you have to enter into CTO, and you know where you have to reach with the wire at the distal vessel. So that's a very important. So you can see here, so if there is a clear cap, you can enter into the cap, and then you go across the CTO and then reach distal vessel without perforation, with most probably an intimal tracking, which may not be true always. In 30% of the cases, you might go subintimal and re-enter, and preferably without making much space, either in intima or subintima, which affects your directability of the wire. So when there is an unclear cap, so you have to use a methodology to make it clear before wiring, because you don't know where you have to wire by fluoro. And if the distal vessel is unclear like this here, so the distal vessel is too small and it's not greatly visible in your fluoro. So when you start wiring antigradally, and you can't really differentiate or decipher where your wire is in relation to the distal true lumen, that's where you will struck. So, and these are the vessels where you end up in doing retrograde. Coming to the wires, I think this is the most confusing thing, but you can look at this paper of APCTO, which really simplified, the wires classification: high penetration force, intermediate penetration force, and low penetration force, blunt tip as well as taper tip. I think this is a nice classification. Are easy to understand classification, or more practical. So in antigrade wiring, it is proximal cap puncture, which is the first step, and then crossing CTO body, and then reaching distal true lumen through the distal cap or beyond the distal cap, based on the situation. So coming to the puncture of proximal cap, you can see this is a clear cap. There is a clear entry point, and also there is a clear channel which is visible, which you can make it much more evident by using a microcatheter injection. And in such scenarios, you better take a low penetration force taper tip wires, and usual wire of choice for me is Fielder XTR, that's a common wire which I use. And most important, how to use this wire. So never push this wire. It is only the rotation. You can keep watching, my fingers here. You just keep rotating. The wire will choose the channel available in the CTO. That is all about, channel tracking wire. So never try to direct it or push it in the CTO. So that's when we create a problem. So we can see here, so we just confirmed and advanced, Fielder XTR by rotation, and it took its own course and reached, distal vessel. And here is a case where there is a clear cap, but unclear channel. So in a distal RCA, in such a scenarios, again, you can start with a channel tracking wire, either XTR or XTA.
So when there is no channel visible, you can use slightly more tip load wire. XTA has around 1.2 tip load when compared to XTR, slightly more than XTR. So you can use XTA or XTR, and you can just keep rotating it, it will take the channel. You can see here it just reached a distal vessel effortlessly. So do nots with this channel tracking wire. So you can see there is a clear channel here in a mid RCA CTO. And see, operator went with the channel tracking wire. You can see here how it is buckling. So these wires should never buckle. See, this indicates basically it's a push on the wire. So when you push the wire and when the wire buckles, then it creates huge subintimal space and it minimizes directability of your subsequent wires. And you can see here, so since later I did a dual injection in this for the patient, so and you don't know whether this is true lumen or false lumen created by filter XTR wire. So in such scenario, it is very difficult to wire antegradely. So we went directly retrograde and and we externalized. When I did IVAS, you can see how big the subintimal space was, which was created by that fielder XTR push and looping in the subintimal. You can see here, it's all subintimal space created. I mean, this is a graphic, just convert. You can see complete subintimal space, true lumen is completely compressed. So when this happens with your first wire, even if you escalate to, directable wires like Gaia or whatever, intermediate force or high penetration force, you can't really direct it because there is a huge space already created. So the directability of all these wires is lost. So they won't listen to you. And of course, we got a good result after doing fenestration with cutting balloon and stunting. But there is likelihood of losing, side branches in such scenario if we are not careful. So those are the don'ts with filter channel tracking wires. And when there is a clear but hard cap, which needs a wire escalation, you can see here. So the cap is more or less clear for me. So I know where I have to puncture in this scenario. But what happened in the first, when they tried is, so you can see here, when they are trying to push this wire, the guide is coming out. So for any wire, intermediate penetration force wire or low penetration force wire, guide stability is the most important to use your penetration force. If the guide is coming out, that means the penetrating force of the wire is reduced. And more importantly, you can't really control the wire. So wire will go wherever it goes. It won't go to the place where you want it to send. So that's what happens. So you can see here, the wire just slipped into subintimal space at the proximal cap itself. Ideally, it has to be punctured here, but it just went, on the side of the proximal cap into subintimal space. And you can see it's a short CTO. Distally, they ended up in a subintimal space. So, and they took almost 4 hours of procedure and 300 ml of contrast. And the simple reason is a poor guide support, and which really killed the directability of wire. So what we just did, we anchored a balloon. So, and make your guide stable first. Though it is AL, still we have to use an anchor balloon and make it stable. And then take a microcatheter and take your Gaia wire. So directly we escalated. Any flat caps usually will be hard. Take your directable wire, keep it onto the point where you want to penetrate, and then push it. And we entered cap in a desired location, and we continued further, and you can see it just reached true lumen. So it's a short CTO. If your entry is correct, usually you will also exit correctly into true lumen. And how to use this wire, unlike your filter XTR wire, once you position your wire on the cap, you can see here, these are the two fingers with which we can push, and this here, you change the direction of the wire. So that is very important, while using this wire. So direct with this and, push with these two fingers. And when cap is clear or ambiguous but hard, and you can use escalation and de-escalation. Like in this case, you can see it's a kind of ambiguous cap. We did an IVIS from diagonal, and you can see this is a cap, and you can see there is a slightly high opaque, a structure sitting here. And you can observe what happened. This is Gaia 2 directly. I took a Gaia 2, but you can see it is just buckling at the proximal cap. So I am pushing, and it is just buckling, you can see. So, and this is a point, which really made it buckle. So based on the structure of proximal cap, you can decide, what wire, you have to use. You can still see this is Gaia 2, which is buckling, and 114, it just enters into the cap. And once you created a perforation, you pull it back and send Gaia 2 again, and you can see how it goes into the proximal cap. It just goes through the perforation which was already created by 114. So this is just escalate and de-escalate back to your Gaia 2, because this wire, 100 wire, it just goes straight, so it won't take turns in a vessel. This is, and subsequently, we directed Gaia 2 and it went into distal to lumen, and, we finished. So this is my usual wire escalation strategy in all antigrades. I use Gaia 2, and sometimes I escalate to Gaia 3, or many times I just go to either 114 or Conquest Pro 12 or 20, and I immediately try to de-escalate. I never try to continue with the same wire. So these wires, high penetration force wires, are used only to cross the resistance or create a pathway in the resistance, and come back to the intermediate force wire again. In an ambiguous cap scenario, your wiring techniques are very important. So you can see here, so this is Gaia. You can observe the difference, how it behaves. You can see this. So we directed into the cap, and when I pushed, it just buckles and goes into the side branch. So that's a problem with the Gaia. And you can see the harned wire, how it behaves. You direct under IVIS and then push, it just enters into your proximal cap. So this is mainly because of the hard core in the wire. And this is how we shape wire in ambiguous cap puncture. So this is the primary curve around 1 millimeter, and you can make a secondary curve around 4 to 6 millimeters with overall angulation less than 60 degrees. And the secondary curve, you can decide based on your angle of attack. So to make your procedure comfortable. So once you enter into the cap, you have to de-escalate. Advance your microcatheter and then de-escalate wire to 1 mm tip end. That is very important, because if you continue with the same wire, that wire tendency will be to go into the subintima again because of the two curves. So that's why, you send microcatheter and then advance. You can see here, I have advanced microcatheter and consolidated my position in proximal cap. And then we switched to Gaia 2 wire. You can see how it just went inside. So that's what happens when you de-escalate wire 2 with a 1 mm tip bend. Crossing CTO body, you can see, it's intimal tracking, but many times we may not go intima to intima. And sometimes we go directly subintimal. So you can see here, so it's a very hard cap. I couldn't able to see with IVIS, so I directly went ahead with a side base and knuckle, and we advanced knuckle into CTO, and then later we tried re-entry distally. Sometimes wire may go, visualizing wire is very important. So in scenarios where your distal vessel is filling from two collaterals, it is always better to give dual injection to understand where your wire is. Because of the streaming of collateral flow, sometimes you may not understand where the wire is. Here wire appeared almost subintimal, but when I gave dual injection, I understood it is intimal, and then we continued. And the distal cap, when it is too hard, in such a case, where there is a venous graft, and we were going through the LAD CTO to open RCS CTO, my wire went up to the distal cap, but there it is getting deflected. Can I take a couple of more minutes? Yeah, there it is getting deflected from distal cap. So I escalated to Gaia 3, but even Gaia 3 is deflected at the distal cap. And this is what happens when there is a graft. Your distal cap will be hard. And then I took this is Harnett. You can see this is Gaia 3. Still it is slipping off the distal cap. We took a Harnett wire and confirmed its direction in two views, arrhyvocranial and allocranial. And I pushed, you can see now how it jumped. So the resistance, you can understand. And immediately you advance your microcatheter, and we confirmed its position, and then advance microcatheter, and you close it. So in a hard distal cap, you might end up in escalating to high penetration force wire. When your antegrade wire escalation is in subintima, so these are the options you have. But the first three options are mutually exclusive. If you try too much of any of it, it will prevent your next step. So, but tip detection ADR can be tried in all the any patient, and retrograde is always an option. And you can see this is, antegrade wire is subintima, so, and we switched on to parallel wire with a double lumen catheter. This is, and always the second wire, Dr. Gerald Werner is here, from whom I learned parallel wire. So escalate, second wire should be a high tip load wire. Here it is Gaia 2, the first wire is Fielder XTR, and your first wire straightens the vessel, and it marks your vessel so that your second wire can be directed in two orthogonal views. So that's the advantage. You can see the wire reached distal 2 lumen, and you can complete procedure. And again, the similar case, parallel wire with double lumen. So we are in subintima here. That's a Gaia 2. Next wire I took Gaia 3, but even that was subintimal. And then again, you can use either wire to direct, but don't try to create too many spaces. That will spoil directability of the wire, and also it will spoil your further options of antegrade. So only thing remains is retrograde when you create a bigger space. So finally we could reach with the Gaia 2. Sometimes even de-escalation can be done in a parallel wire. So yeah, we reached distal lumen and we complete it. I'll skip this part. And when the wire is in subintima, you can also use a re-entry with Stingray. You can see this is an LAD CTO, and redirection of wire is attempted for a longer time, and it created a huge subintimal space. This is a pilot wire, and we went with the Stingray to re-enter. Because of the huge subintimal space, the first attempt at re-entry was unsuccessful. So to exchange to Stingray, Miracle is the best wire, which gives a huge support. And to give a sting, you can use these wires, any of these wires. And I always use stick and swap approach. This is a swap wire, which is pilot. But unfortunately, because of the subintimal space, you can see it is just dancing in the subintima. So this is what happened. So what we did, we came back to a place where the intimal space is very close to your Stingray, that is the proximal most area, and perforate it. And you can see here, I'm perforating with Stingray wire, and then it is swapped to pilot wire, and you can see it just went in. So when the gap between your true lumen to your Stingray is less than 0.5 millimeter, your success will be quite good. So, and this is another case, simply, ambiguous cap. We did IVUS guided cap puncture, successful, but the wire entered into subintima. And then again, we completed with a Stingray re-entry after failing, retrograde wiring because of the stuck microcatheter within the collateral. Yeah, I think I'll just skip. So this is the final thing. So when you have an ambiguous course, how to plan your antegrade wiring. So this is very important, see, because if you are not course is not known, then it troubles you, and your high penetration force wires may go out of the vessel. So the first attempt, it was failed outside. So what we did is, see, you just go park your microcatheter there, and then you escalate your wire, enter into the vessel, confirm it with a vessel movement, and then take a knuckle wire. You occlude this, you trap this microcatheter, take a knuckle and go with the knuckle till it reaches, the knuckle becomes coaxial with the distal vessel, and then take a directable wire and direct it into the distal vessel. So that's what we did. So you can see microcatheter sitting there, and then we advanced wire into the CTO, and now I am trapping my microcatheter is embedded into CTO. It is trapped with the 3.5 balloon, and then so we are advancing a knuckle with a Fielder XTR wire. This is a knuckle. So knuckle is advanced, and once it went out of all the loops, then I switched back to the directable wire after sending microcatheter beyond the lost loop. So you can see this is a lost loop, and I crossed that loop with microcatheter, then turned on to Gayatri wire and entered into the true lumen. So this is a kind of escalate, embed your microcatheter, knuckle, and then shift to directable wire. So, and you will have always true, false, true lumen in such cases, and you can see this is a final result. So it's not just the wire. You have to have a strategy for the CTO with your wires available. And to conclude, antegrade can be the initial strategy, except in ioto-hostile CTO. An ambiguous cap and clear distal vessel are prerequisites for antegrade wire navigation. Ambiguous cap can be made unambiguous with IVIS. Clear cap and clear channel start with a channel tracking wire. Wire escalation pattern is operator dependent. This is my usual wire escalation, de-escalation, and ensure stable guide before wire escalation. And de-escalation is preferred to avoid subintimal entry. And antegrade wire escalation ended in a subintimal position. These are the options. And if you anticipate a hard distal cap in these scenarios, prepare for it. And have a clear plan for ambiguous curves. Knuckle wire can overcome this in many situations. And this is one technique which can be used. Thank you.
Yeah, thank you very much for this very extensive overview of which probably you cannot compress in 15 minutes. You managed in 20. Very good points. But I have two different opinions on two things, maybe on little variations. But the first is the Fielder XT type wires, they don't work because they are microchannels. When we see channels, then these are subtotal occlusions. Then there is a channel that you can even pass with a whisper wire. But why does the XT work even in a 3-4 centimeter lesion is because there is soft, loose tissue. And I agree with the manipulation of the wire, but it's not microchannels. Microchannels are not there by anatomic examinations in these old CTOs when they are beyond 6 or 8 months.
So loose tissue tracking wires, yeah.
Just for terminology. Then just one final remark. I don't think that when you do parallel wiring, you do away with the other option of re-entry, because the parallel wiring concept is stay in front of the distal cap. So you manipulate to get inside the distal cap from before. If you do not manage, you are beyond the distal cap subintimal, then you can still move to RDR, for example. So I think it's not exclusive. The only rule, what you mentioned, is do not inject antegrade. Then you can switch from parallel to RDR, I think.
Sir, you have explained in detail how you do the procedure. I have two questions on the preparation for the procedure. One thing, do you use CT when the course of the vessel is not very clear? Do you take CT angiogram guidance for the probable track of the vessel? So one slide you show that the vessel might be having a curvy course, so that when you push the wire, there is a chance of not entering the lumen.
Yeah, see, in that case, CT was not done actually. So I do use CT in aorta oscillations. So, and when I'm thinking of ADR, where to understand my re-entry zone, so to define calcium, and also ambiguous course scenarios. But once we are comfortable, you become comfortable with using knuckle wire technique. So you can overcome many ambiguous courses with knuckle wire, provided you are diligent in using knuckle and you have a clear goals, clear objectives, where you have to start your knuckle, where you have to end, and that is when the knuckle becomes. I use most commonly Fielder XCR, but you can use cyan block as well, and the latest wire like Gladius is also recommended for knuckle. But Gladius gives you kind of a power knuckle. I'm literally scared in using when the course is ambiguous and very loopy.
It's the Gladius MG. There are two Gladius. The MG has a knuckle point, which makes it a little bit safer.
One more question. When you plan the procedure, do you always take the opposite groin also prepared, so that anytime you can change to a retrograde approach?
No.
Because I have seen a lot of Japanese operators.
We start with two punctures. You have to start with two punctures. You have to start with dual injection. That's where your C2 intervention starts. We have to understand the major limitations in take any algorithm, the major limitations are the time and contrast. If you have wasted your enough time and contrast in exploring your antegrade in a single, with a single guide, you are going to fail. So your chances of failure will be very high. So when you are approaching a C2, always approach with a full-fledged. Then you can save your time, you can save contrast, and you can, your success chances will be very high.
Yeah. So unless you have an antegrade filling, or you have a homologous collateral, or you have a left dominant system with a LPDA filling the LAD, I think you have to take a double puncture. There's no other alternative to that.
Yeah, but in these situations, we must make sure when we go parallel or whatever, we stop injecting. So if you have the homonym or ipsilateral collateral, you have to put a microcatheter in this side to avoid hydraulic dissection that you showed nicely in this example, that the Fielder XT can make such a big hematoma. I want to make a remark for the CT. CTs are helpful, but the problem with the CT in such a case is CT is mostly only done end-diastolic, and in end-diastolic, the loop is straight. So the loop is during systole. It's moving, and that's not often caught on the CT image. Would have to have several CT sequences during the cardiac cycle to understand these.
And another problem in it, at least what I'm facing is, bringing your CT into your fluoro is, not there in most of the labs. And whatever the labs available also, it is not completely accurate. You can't really say it is intimal.
Buy a Siemens lab from Germany.
Have you had situations where one part of the distal vessel is filled by collateral from one vessel, and another part is filled by a different collateral from a different vessel, so that you need 3 simultaneous shots at the same time to fully get the.
That happens with the post-EBG patients commonly.
You know, when you try with because your topic was anti-grade escalation, when you start with the soft wire, when the wire buckles or after some time you escalate the wire. So do you have an approximate time after trying with one wire, you change to another wire, or it is just your personal experience you...
No, it's basically, I think, couple of minutes. And if the wire is not advancing, I escalate. I don't keep on struggling with the same wire. And for your first question, wire shouldn't buckle. I mean, that's how you have to only rotate these wires, never try to push it. Because the moment you push it and you buckle it, you create a bigger space, and your next wire directability will come down.
Any experience with the new ST Conquest Pro? Maybe Dr. Komatsu can.
Yeah, I think it's mainly for tip detection ADR to go across your flap and enter true lumen. But I don't know whether it is available in India as of now.
Have you tried, sir?
It's not available outside
Yeah.
Japan.
Yes, so this guide wire is a quite new one. So basically the same as the former types, Conquest 12, but a little bit change the shape of the board tip, and a little bit change to the how to say that fast tip curve. And so due to these the minor change, the penetration efficacy is very high. So used to be that this Conquest Pro 12 ST is developed for the ADR, but nowadays we use for the IVUS guided.
Okay.
And so I have the answer for your question. So when we have to change my manner and during anti-grape procedure, and we have the data from the Japanese CTO expert legacy data, we already published via JACC. And after that, the procedure time is 20 minutes. So 20 minutes is the time that for the thank you very much. And for the thinking about the changing the manner to the letter grade or the parallel or the IVUS guidance. So actually the single wire the manner and by the undergrades, the median time for the guide wire the passing is 16 to the 20 minutes. So that's why we support the 20 minutes is a good the milestone.
Yeah. I think a little bit more clarification. There are two things. One is wire escalation, another is change of strategy.
Yes, sure.
So both are different.
Okay, thank you, Dr. Reddy. Now, Dr. Nagamatsu will talk about the next step when the antigrade fails. Then we have the option of the reverse card, how to make a connection.
Okay. Thank you very much. And so first of all, I would like to say that I deeply appreciate the invitation. Thank you very much. So my topic is the steps in the reverse card and how to make a connection. This one you might see. And looking back at the history of the regular PCI, so actually the reverse card techniques published 2010. So basically, the Dr. Kato performed this reverse card and around 2008. So actually, this reverse card is like a game changer procedure for the letter grade PCI procedure. And the after quarter channel guide wire, we have we can get the very high success. So this paper showed, and this paper that using the Japanese CTO expert legacy data. And after that, the guide wire passage through the letter grade channel. So actually, this technical success is quite high, 91%. But the wires we 9% failed. the fail factors, the one is a reverse cut and success. The other one, the device crossing. Then the another one is the complications. So I think the reverse cut and the device crossing is the main the fail factors. And even if after that, the guide wire passing through the channel. So maybe you have the main experiences, the reverse cut. The occasionally it is difficult to make anti-retrograde connection. So this depict pictures is the procedure. Looks like okay, but very difficult to make a connection. Very difficult to stick the from the retrogradely. So change the ballooning part, but very difficult. But finally success. So even if it looks like this reverse cut, it looks like a very simple technique, like this picture, like this schema. But actually, we have to do some techniques. So I would like to strongly recommend please use the IVAS and for the reverse cut. So we call the IVAS guidance for the reverse cut. So what is the benefits? One is recognizing the wire positions of the retrograde and the antegrade. And please look at this one. So the horizontal lines show the antegrade guide wire position. The vertical one is the retrograde guide wire position. So if this antegrade guide wire be in the intimer and the retrograde be in the intimer, it looks like so we call the same position and being in the both guide wires. And this like situation very easy way to make a connection. And antegrade be in the subintimal space and the retrograde be in the subintimal space too. But on the other hand, the antegrade guide wire be in the subintimal space and the retrograde one is intimer. So those like different spaces, and antegrade be intimer and the retrograde be in the subintimal different spaces. This is like a situation, so it's very difficult to make a connection. And I show the actual case. This case is as a CTO. So this time very easy and very easy way to make a connection like this. And in this time I check the IVAS and how about those like guide wire positions. So as you can see, this one is a flips IVAS, broken IVAS. So the center of this picture is here antegrade guide wire position. So looks like this guide wire position be in the subintimal space. So that's why we can see the interplug 3 to the 6 o'clock. And how about the retrograde guide wire position? Is here be in the subintimal space too. So that's why the very easy way to make a connection, because both guide wire be in the same positions, like this. And I will show the difficult to make a connection. The case during the performing the reverse cut technique. This one is a LED CTO, and already get advanced antegrade guide wire like this, and they already get advanced retrograde system via septal channel, and go into their microcatheter too. And I tried to performing the reverse cut technique, but very difficult. That's why. So I would like to check the guide wire positions. So as you can see, this guide wire, so in this time I use the Boston IVAS, and the antegrade guide wire position be in the interplug. But on the other hand, this retrograde guide wire be in the subintimal space. So we can confirm the both guide wire positions using the IVAS. And I will show it again that with using this picture. And antegrade guide wire be in the interplug, but on the other hand, we can see the retrograde guide wire here. So this guide wire be in the subintimal space. So and refer to this schema, and antegrade guide wire be in the interplug, and the retrograde guide wire be in the subintimal space. So both guide wire be in the different spaces. So that's why it's very difficult to make a connection. But due to this like information, we can give the options for this reverse cut. One is optimal sizing of burn. We can use here maximal the size of the burn. and changing reverse card, changing the card position. And looks like this part is be in the different spaces, but the distal part sometimes be in the same spaces. So we have to check the longitudinal position. And the third one is move the cap, the base. So in this time, so antegrade guide wire being into the plug, maybe we can do and antegrade guide wire going to the subintimal space using the intentional cracking technique like a base or the scratch and go. And fourth is the original card. It is sometimes, but actually the very rare case, but still and beneficial, this original card. So actually, this case now we performed a base technique using the 3.0 millimeter balloon impression and intentionally make a cracking from the antegrade and the proximal and in front of the CTO projection cap, and then. So in this time I use a UV3 guide wire, but basically I would recommend the polymer jacket guide wire, a low T Pro like Fielder FC and Sion Black. Okay, anyway, so in this time I use a UV3 guide wire. So as you can see, this UV3 guide wire automatically change the knuckle shape, and this looks like going to the subintimal space of the CTO region. So please remember, so in this case, so delegate guide wire be in the subintimal space. So finally, we can make the good positioning in both guide wires. And then I try to the reverse card technique again. So in this time, very easy way to make a connection. And finally, we can get a good result like this. Okay, I know. So due to the advancement, the problem, and sometimes very difficult to use your eyebrows, but we had option. A double knuckle wire procedure is one option. So usually, so there's like a knuckle wire going to the subintimal space automatically. So from the antegrade going to the subintimal space with using the knuckle technique, and the retrogradely and going to the subintimal space using the knuckle technique. So in this time, maybe both guide wire be in the subintimal space. So maybe we can make a very easy way to the connection. So from the data, my personal data, very old data, and the 10 to 50%. So I performed those like both double knuckle wire technique. So I already mentioned about the knuckle wire is the prefer I would like to use a Sion Black and Gradius Mongo and Gradius EX. Maybe the Gradius Mongo is the best guide wire for the knuckle. So but we have the problem when difficult to insertion guide wire antegradually to the CT region. What is option? So this paper published from my friend Dr. Matsuno and explain about the reverse cut technique. So let me look at this one. So this like extended reverse cut. Extended reverse cut is the inflation by balloon the in front of the CT region and making a crack intentionally. And please look at this one. This guide wire is a retrograde guide wire. So make a connection in front of the CTO projection cap using the region. Extended reverse cut will be one option. And I showed actual case. This one is RCCTO, and quite a long one. This CTO region that started from the beginning, the posterior part of the RCA like this, and we can see the contralateral injection, and we can see the collateral channel be a septal and another the AB group channels, and the CTO the exit it be in the bifurcation, the outer the AB and the PD branch. The big quite long CTO and the tapered entry and the bending part is there, and classification and at the CTO exit, and the exit have the major bifurcation. This is specification of this RC CTO. So, and for the keeping this bifurcation, and due to the very long the RCCTO, and in this time I started from the retrograde, and I use the Corsa Pro XS and a tip injection, the very easy way to pass through the decision guide wire. So that's why this one, the J-channel score is too easier. The guide wire success rate is 50%. Maybe this one is the interventional from the Japanese expert latest data. And I take the tip injection like this. And unfortunately, there is no microchannel from the retrograde, and we can see the very hard the calcified lesion there. So firstly, I try to stick the using the Gaia second and some the good penetration the guide wires, but paired. And then okay anyway. And so and after that, the passage that this the retrograde system, and I started from the antegrade preparation for the performing the reverse cart. The guide wire is a Miracle Nail 3, and for the not so hard and penetration efficacy, but this guide wire have the good support power, and for the insertion the balloons. And I use their 2.25 balloon, and I set up the active grading technique using guide extension. But I would like give the address the please and attention please. And for the saving the bifurcation, antegrade preparation ballooning should be performed far from the bifurcation. So nowadays, usually I try to the retrograde sticking and using the Gradius EX guide wire. And if this Gradius the guide wire stop to the CT region, and after that, and I started to do the antegrade preparation for the reverse cut. So anyway, the active grading technique is a very beneficial, and I will show the benefits in the shorten the length of the retrograde wire route. And the second is the prevention of the retrograde wire advancing to the subintimal out of proximal part of CTO. And even if the make a connection and going to the retrograde guide wire to the antegrade the guide and guiding catheter, but sometimes automatically going to the another extra plug. So for the avoiding these phenomenon, so this active grading technique using the guide extension is very useful. And last one is the backup for delivery of antegrade devices. Okay, and I try to the stick from retrograde, but due to the very hard classification, and so the very difficult. So the final option is using the dual lumen microcatheter. So after that insertion, the Sasuke dual lumen microcatheter, very easy way to stick to the beyond the CTO distal cap like this. So I try to make a connection, the reverse card, but paired. And I try to the reverse cut position. I change to the guide wire, more harder guide wire, but paired. What is the next option? The differently I was guided reverse cut. And I check this longitudinal and the antegrade guide wire route using the IRIS. And the other part is here different spaces, but this part is here same spaces. This both guide wire be into the plug. So very easy way to recognize where we have to do the perform the reverse card here. So after that, very easy way to make a connection, and we can get a good result like this. So for this case, and I check the time allocation. So please look at this one. I waste the time, 51 minutes for the reverse cut. So the other IRIS use would have the shorten the procedure time, maybe the more than at least 30 minutes and we can that's shortened. Take home message: the steps in the reverse cut, how to make a connection. The recognize of antegrade and the retrograde wire positions is a key of a successful reverse cut. IRIS is useful for understanding the both guide wire positions. And how to do guide antegrade wire migrating to CT region, the base technique will be one option. So when difficult to use IRIS, the bilateral knuckle wiring will be one option. Thank you for attention. Thank you very much.
Thank you, Dr. Nagamatsu, for a very nice presentation with good examples of the difficulties. Collateral passage is just the first step, but the connection is the point where we may fail. You showed in the last setup also the time allocation.
Yeah.
And an important point, I think, on that slide is that almost then 40% is dedicated to ballooning and stenting. So we should not, we work a lot on the CTO, but we must be aware to achieve a very nice outcome that a lot of time is after crossing.
Yes.
You mentioned the study from the Japanese registry. Do you have an estimate of time allocation to crossing and then to finishing the case?
But yeah, and sorry, so I just know the wire crossing time. But anyway, so you know that usually the Japanese physician usually waste their time. Yeah, and so nowadays our APCT club, so we have the concept that triangle concept. The one is your success, one is your safe, and one is your time. So we have to keep the good balance, the time and success and safe. So usually the Japanese people, the Japanese physician, usually they waste the time for the too much keep the safe, I think. Thank you very much.
Any more questions? No, no answers.
Any questions from the audience?
All answers given. Okay. Then thank you very much.
Thank you very much. Thank you very much.
One question?
Okay.
Then we will go to the recorded session.
He's online, sir. Dr. Kalra is online.
Dr. Sanjog is online.
Yeah.
Welcome, Dr. Sanjog, to our CHIP Summit. Over to you for your talk on selection of guide wires for CTO.
Hello, everybody. Thank you very much for having me. I'm sorry for having to jump in kind of on the go.
Is your video on?
Should we play the
Should we play the presentation or would you be listening? Yeah, we can see you now.
Yeah, I'm here. I may have to turn my video off intermittently just because I'm sort of shuttling to the airport, but I'm here.
So do you want your recorded talk on while you're shuttling or how do you want it?
Yeah, no, you go ahead. You go ahead. I don't want to delay the meeting. The recorded talk we can start with.
Then we'll get you back for the interaction. Okay.
Sure. Thank you.
Thank you. Go ahead.
Good afternoon. Thanks very much for having me back. The second talk I'm doing today is called Wires, Wires, and More Wires. And really, it's about matching or choosing the right guide wire for the right task in CTO PCI. These are my disclosures. So there are a plethora of wires in CTO PCI, hundreds, by all kinds of different companies. So are we supposed to have one of every one of these wires on our shelf? Is that practical, reasonable, or even safe? Of course not. What we aim to do is have a toolbox when we do these difficult cases that we understand, that we can manipulate as we require, so that within our toolbox, we choose tools instead of run through lists of things that we have on our shelf just to try to see what one might work. A rational approach to these things results not only in efficiency for the procedures, but also safety, so that you're not using the wrong wire for a particular task. And so then when we think about how to choose a tool, be it a wire or a microcatheter or a balloon for a particular task, what we have to think about is, what is it that that tool is designed to do? And what is it that we are asking it to do? Only when those two things are a match do we end up with success. And so then when we're choosing a wire, what we have to ask ourselves is, what is the task we are asking this wire to accomplish? And what are the engineering properties of that wire? And are those properties designed to help it accomplish that task? So that if you have a wire with a particular set of properties, and those properties don't lend itself well to solving a particular task, then that's the wrong wire to choose for that task. Generally speaking, there are 7 different things that we ask our wires to do. We do routine and complex access, so that's class 1. We do microchannel or intralesional crossing. It's where you get a wire to try to get right through from one end of the CTO to the other. You do directed penetration, where you take a stiff, sharp, high tip strength wire to penetrate into calcific or resistant tissue. You do directed navigation, where you start with a similar sort of penetration paradigm, but with slightly less tip strength and a little bit more trackability, you navigate all the way through an occlusion. There are those wires we use to cross collaterals, so the very tortuous connections that sometimes come up between vessels around CTOs. There are wires that we use specifically for knuckling. So they're blunt dissection instruments, essentially, and we need those wires to never leave the architecture of the vessel. And then, of course, we have wires for externalization. So generally speaking, each of these task classifications carry with them ideal design properties. For a workhorse wire, for example, you need a wire that has a low tip load, so something that you can manipulate around corners and curves, but that is not going to poke through the side of a vessel if you push a little bit too hard. You need it to be torque responsive, so it'll go where you need it to go. You need it to be hydrophilic, but not polymer jacketed, because the more polymer jacket you have, or the more coating you have to the point where you have a polymer jacket, the less tactile feel you have. So if you want something to be tactile responsive where you can feel it, you don't want a polymer jacket, you want a hydrophilic coat. You want moderate core thickness, because the core of the wire is what determines whether or not it will go around curves. Those wires with very thick, stiff cores want to go straight, but as a result are very supportive. Those wires that have less core thickness, or like a whisper, a parabolic grind, where the core thickness reduces over the length of the wire, those wires do a good job coming around curves, but are not as supportive to carry equipment. A microchannel or interplaque crossing wire is something where you may want a tapered or a non-tapered tip, but with a low to moderate tip load. Okay, so something that's not overly stiff at the tip, but stiff enough to penetrate plaque, and then is polymer jacketed, is highly lubricious, because what you want it to do is slip through the plaque that's in front of it. And then you want something with a reasonably flexible shaft, so it'll go around curves, but a little bit further back into the shaft, something that will support tracking of a microcatheter. This is different than directed penetration. Directed penetration means you want to penetrate resistant tissue. So what you want is a very high tip strength wire that you can feel, that has a stiff core so that it has the ability to track a microcatheter along it. And the other thing that you really need is very, very good torque responsiveness. So with this tapered tip, very high tip load, pointy wire that you're about to use to penetrate through resistant tissue, it'll go exactly where you want it to go and no further. That's similar, but slightly different than directed navigation, where what you want is maximal torque responsiveness, because now you're going to use a moderately penetrative wire, maybe a little bit less penetrative than your directed penetration wires, but moderately penetrative. So I'm thinking Gaia second, Gaia third, to carefully navigate right through an entire CTO segment. You want moderate tip stiffness, and you want a shaft that can go around curves. That's further different than a collateral crossing wire, where now, knowing the collaterals are very soft and very easily perforated, you want an ultra low tip load, or a spring coil where it's going to bend the moment you hit something that you shouldn't. And then you want that wire to be hydrophilic or even polymer jacketed, so it can slip around very tortuous segments, but with perfect torque responsiveness, so that you can turn it around these very challenging collaterals that are very, very tortuous, with a flexible shaft so that it can track around those very acute and circuitous bends. A knuckling wire is similar to an intraplaque tracking wire in that it's low to moderate tip load, and it's polymer jacketed. But the unique feature of a knuckling wire is that you need a core that is going to allow the tip to fold onto itself and then put some support behind it. So if you can imagine then, if you have a core of a wire that is stiff, and then the last little bit of the wire is a little bit less stiff and is able to knuckle, then when that wire knuckles, the entire stiff core behind it will allow that knuckle to advance. And there is just a wire that's designed like that. And then, of course, you have externalization wires, which are just extra length, low shaft stiffness wires that can go right from one artery through the CTO segment and collateral and out the other, and give us enough strength and enough support to be able to deliver our gear, but also have enough shaft flexibility to be able to come around curves and through tortuous segments. So let's use a case to illustrate this. This is a 56-year-old, the usual cardiac risk factors, who has a AAA, needs surgery, but also has exertional chest pain and dyspnea, and a very large reversible anterior and anterolateral perfusion defect. Here's his diagnostic angiogram. So you can see a big right coronary artery that's dominant, and now you see retrograde collateralization of the LAD. Okay, you can see those collaterals coming up to light up this LAD, but uniquely now we see that the distal cap is right at the level of a bifurcation of a large diagonal branch that we really don't want to lose. And then to make matters more interesting, here is the left system angiogram, where now you see a big ramus branch, a circumflex, and here's the proximal LAD with a very large proximal diagonal branch, and then an extremely ambiguous proximal cap. You have no idea where this LAD occludes. Is the cap here? Is it here? Is it here in the middle? It's very, very difficult to tell precisely where that is. And this is proof of that, looking at it from the cranial view, where you really have a very smooth surface over which the diagonal comes off. It's very difficult to tell where this begins. So you really have a blunt proximal cap and a blunt distal cap. Okay, here's one more picture to show that concept. So this is the case we have. These are your dual injections where you have a 20 or so millimeter CTO, but with ambiguous proximal and distal caps and big diagonal branches coming off at both caps. So this is a difficult scenario because you can't afford to lose either one of those diagonal branches. There's some visible calcification, and there may be some tortuosity. So our plan was to use IVUS-guided proximal cap puncture to puncture into the CTO segment and then try to navigate through it. And while navigating, be very careful not to go past the distal cap in the subintimal plane. If we're there, we're going to have to switch over to a retrograde approach because we need to preserve that distal diagonal branch. So our first task is proximal cap entry. What is the task we're trying to accomplish? What are the tissue characteristics of the proximal cap? Therefore, what is the wire task classification that we are going to access? And what are the wire characteristics we would want? Well, what are proximal caps like? As we know, they're challenging, thick, calcium and collagen-packed tissues. So they're blunt, they're fibrotic, they're tough. So what we want is something that's going to penetrate or puncture into a proximal cap. But we need a wire that we can feel, right? Something that's going to give us resistance. And as a result, you need a high tip load with a tapered tip, but that is hydrophobic, with a real core behind it that can help you push forward through the resistant tissue. So this is the typical directed penetration wire, examples of which include the Warrior wire from Teleflex, the Confianza Pro 12 wire from Asahi, or the Hornet 14 wire from Boston Scientific. And you can see that all three of these wires have very similar characteristics. They all have tapered tips and very high tip loads. So you don't need all three on your shelf. Pick one, maximum two, because you need to then learn how these wires feel in your hands very, very well so that you can be reproducibly comfortable with them. So this is what we did. There you can see a Eagle Eye IVUS catheter showing us where the proximal cap is. And here's our directed penetration wire penetrating just slightly through the proximal cap and allowing our microcatheter to transit forward. And you can see here on the IVUS that when we confirm the position, that in fact the wire is indeed inside the CTO vessel. All right, let's move now to problem number 2, which is getting through the CTO. So this is antegrade crossing. So what we're trying to do now is an intraplaque crossing with a wire of choice. So what's the task we're trying to accomplish? Well, we need the wire to transit through densely packed CTO tissue, right? So this is going to have some collagen, some thrombus, maybe some calcification. But as you can see, the vessel is quite tortuous. So you don't want something that's going to exit the vessel. because you don't know precisely what the vessel path is. That means that you're going to want some wire that's going to be very torque responsive, that's going to be able to navigate through tough tissue, and that is going to be able to be directed very precisely with torque responsiveness. So if we think about what kind of wire that would be, you know you're going to have to cross through fibrotic or tortuous tissue. You want a directed navigation wire, which has perfect torque responsiveness, a moderate tip strength so that you can get through dense tissue, but that it doesn't go right out the side of the wall, and with a flexible shaft so that that shaft can allow the tip and the core to take a turn through this tortuous vessel. And if you get nice and close to the distal cap, that perfect torque responsiveness should allow you to poke right through the middle of that distal cap and avoid creating a dissection plane that will close off the diagonal branch. These are examples of directed navigation wires. You have the Gaia Next wire on the left and the Judo wire by Boston Scientific on the right. The Gaia Next wires are beautiful wires where instead of having a thick core that doesn't necessarily want to bend, so it doesn't give you sort of trackability around curves, Asahi has learned to sort of cheat that physics by putting an X-strand coil in, which is actually 64 wires, right? So multiple core wires around a central wire, multiple coiled wires around a central wire that allows you to put torque control on each of those wires, and that torque control then gets translated right to the tip to give you very precise movement. That's different than the Judo series of wires where the core is actually fused to a tip with multiple wires around it. And what that does is allow you to transit this wire as well with very good torque responsiveness, but this one, differently than the Gaia, actually has tactile feedback. So this one you feel, whereas you have to look at the screen and watch the Gaia bend to recognize that you're hitting tissue that is resistant and that you need to change the wire's direction. So this is what we did. We did an antegrade crossing attempt, and unfortunately, you can see in the right side here that we failed to puncture the distal cap and that this started to move towards the diagonal branch. This is obviously after that wire has been changed over. So having entered into the subintimal plane in the diagonal, we have to be disciplined at this stage to say we are not going to keep poking forward because we're going to shut that branch down. And instead, we're going to move towards a retrograde approach. So we tracked a trap liner balloon into the CTO segment to provide occlusion of flow into the subintimal space of that diagonal to protect it, got us close to the distal cap, and then made our plan to change to retrograde. So at this stage now, what are we trying to accomplish? Well, now we need to wire retrograde collaterals. It's always more difficult to wire from the RCA to the LAD because even those septal collaterals take circuitous bends just as they enter the PDA. So what's the task we're trying to accomplish? Well, this is retrograde collateral wire. What are the nature of what are the tissue characteristics and the nature of the tissues we're going to move the wire through? Well, these are soft collaterals, which are going, in this case, through muscle. So you want something that's not going to perforate your collateral, that can go around lots and lots of bends, and that can slip through very thin spaces. So clearly the task classification would be collateral crossing, right? That's what you're trying to do. And so for this, then you need something that's going to be very soft at the tip, that's going to tell you if you're hitting something like the end of a collateral that you shouldn't, but that is very, very torque responsive and either hydrophilic or polymer jacketed so that it can slip around and through very, very narrow crossing areas. So collateral crossing wires require very special characteristics. You need torqueability so you can get into a curve, but then you need the tip to be lubricious enough so that it'll slip around that curve, because sometimes it is physically not possible to torque around some of the extreme curves that you see in some of these collaterals. You need the tip to be ultra low tip strength so you don't perforate. And you need flexibility within the tip and for several millimeters behind the tip so that that tip can lead a wire through a collateral that is quite tortuous. So this is an example of an epicardial crossing wire that I use often called the Shuo 3 from Asahi, where you actually have an Act 1 type of core, which is like the Xi'an wire, so 1-to-1 torque control. But then you have a twist wire connecting to the very tip of the wire at the very end. And what that does is allow the very tip of that wire to be extremely floppy so that it almost becomes like a leading edge of the wire. It can engage a curve and then come right around that curve and allow the rest of the wire to follow suit. That's why it's particularly well suited towards epicardials. That's different than the Xi'an black, where this is a little bit like a regular Xi'an or Xi'an blue wire, but with a polymer jacket and a lower tip load. So it's very lubricious. It'll slip through all kinds of collateral segments, but it also retains its one-to-one torque control because of this Act 1 core that it's got. And so in retrograde wiring, what we need to do is septal crossing. So you can see, as I mentioned, there's a lot of tortuosity when the septals come into the PDA. So coming back from the PDA, you need to navigate that tortuosity. You can see what that looks like here. So then, as you can see on the left panel, this wire is going to come out and it's going to slip and hit something. And so it has to be sort of used very gently to manipulate past what is a very acute bend right there in that collateral. And then once it catches that simple straight segment, then it's just slippery enough to slip right through. And here you go right up into the LAD and into the distal diagonal branch. And here then we can confirm our wire position and move on. So now we've got to do reverse cart. In order to do reverse cart, we're going to need to puncture the distal cap, which is, generally speaking, less rigid than the proximal cap, particularly when it's a tapered distal cap, like is the case here. And then we need this wire to be able to knuckle into the subintimal space so that we can do reverse cart within the CTO segment. So between the proximal diagonal and the distal diagonal, to make sure that we don't result in dissection planes covering either of them. So the task we're trying to accomplish then is to transit through the middle of the distal cap and then knuckle. The tissue characteristics are the distal cap's going to be a little bit rigid, and then we have the same packed fibrotic tissue in the CTO segment. So the wire task classification that we're going to want is an intraplaque tracking wire or a directed navigation wire. Both will work because ultimately all we're trying to do is get through the middle of the distal cap and then into the CTO segment where we can perform reverse cart or even go retrograde true to true with a directed navigation wire right into that guide extension catheter that is waiting for us. And so one of the very best intraplaque tracking wires is the Gladius Mongo, where it's got the same Act 1 core that we spoke about that sits in the Xi'an or the Shuo, so it gives you perfect torque control. But this now has a polymer jacket and a moderate tip string. And a unique feature of this wire is what we had mentioned earlier, where you've got a nice rigid core, then the core tapers into a very thin core towards the very end. And as a result, when this segment of the wire bends or knuckles, it knuckles tight, so it's a very small knuckle, but then with this big rigid core behind it to be able to push forward and advance that knuckle. That's what gives this wire its unique ability to create such nice tight knuckles and transit through tissue well. Other options are the Raider wire, which does not have, it tends to have larger knuckles, so it gives you a big target when you have an ambiguous proximal cap and you're using a big retrograde knuckle as your target to poke antegrade, versus a Pilot 200, which I think we all know pretty well and does a good job of knuckling with a moderate sized knuckle. So here's what we ended up doing. We took a Mongo, it transited through the middle of the distal cap, and as it turns out, we were able to wire directly into the that guide extension catheter, though the ballooning that we did to track that guide extension in is probably what made the tissue soft enough to do that. Here on the right side, then you can see transiting of our microcatheter into the antegrade guide extension. Now what's problem number 5? Now we've got to externalize. Well, this is easy, right? There's only a couple of these externalization wires available on the market. They're extra long, they're low shaft stiffness, they're flexible around corners, and they allow us to just transit through, right? So one option is the RG3 from Asahi, which is stainless steel, versus the R350 from Teleflex, which is a nitinol core. The nitinol core is going to give you superior kink resistance through tortuosity, but as a result, if you've got very tortuous collaterals, may produce pseudostenoses. The Asahi RG3 is very nice in that it will come around and preserve those curves, but then if they're extreme curves, can actually kink and not give you enough support to be able to pass your gear along it. So here's your externalization. You can see the wire zipping down the RCA, up the septum, and up the LAD, over which we were able to deliver balloons. There is the IVUS of your stent result right here. Okay, so reasonably well expanded. And here's your angiographic final result. And the key here now is, look, got one stent, but you've got both diagonals home, okay, where you've got one diagonal here and one diagonal here. They're both preserved. They've both got good flow, which is what ultimately ended up getting this guy a good result. So there are tons of wires in CTO PCI, and that portfolio has dramatically expanded over the past 10 years. So we need a way to classify these things and make sense of them. It's important to classify them into task classifications and have 1 or 2 at most from each task classification on your shelf. You get to know how to use them very, very well. And once you know how to use them extremely well, you're going to be able to predict their responsiveness in different types of tissue. Once you understand the tissue you're treating, you will be able to choose precisely the tool that you need to solve the task in front of you. Thanks very much for your time and attention.
Sanjog, hi. Can you hear us?
Hi there. Yes, I can hear you.
Yeah. So that was a brilliant talk. Good task-based classification of the guide wires. Any word on shaping of the wires?
So generally speaking, I think one of the mistakes people will make early on in their CTO PCI experience is using big curves for these wires, thinking that it's the curve that's going to reach the area they need to go, where in fact, I think what people need to get accustomed to is setting up a proximal base of operations using a microcatheter. And then your tip shaping ends up being angulated and very short. And using your microcatheter to bring your base of operations forward, it gives you access to the tissue that you're trying to puncture and allows your wire to access precisely the area that you're trying to access. The other note that you can make is that when you bring a microcatheter close to the tip of a wire, it dramatically stiffens that wire. You can stiffen even a workhorse wire that way. And so it's important to recognize that when you choose a wire, whether it's a directed penetration wire or a directed navigation wire or anything, if your microcatheter is right behind the tip, that's going to be a very stiff tip. And it should be treated as such.
Do you use Gladius wires, and where do you put it? Between Fielder and Gaia, or what is the place?
So Gladius wires are 200 centimeter core to tip, polymer jacketed, moderate tip strength wires. The Gaia and the Fielder XT are completely different wires, and they do completely different things. The Gladius wire would fall, it's marketed as something called a Mongo extra support in Canada. So that effectively functions like an intraplaque tracking wire, but in a segment where I know I'm going to have difficulty transiting the microcatheter, because the shaft of the Mongo ES is quite stable and quite it's quite supportive. So it's a little bit easier to track equipment along that. I treat it more like a Mongo or a Pilot 200, but with a lot of strength behind it. I don't typically knuckle that wire because it's very, very aggressive to do so.
The stiffer the wire, the bigger the knuckle?
No, not necessarily. The distance from the tip that the core will taper or terminate will derive how big your knuckle is. And it's not just that, actually. It's actually that plus the strength of the core. So for example, in a Fielder XT, the core strength is low, right? And the tip strength is low. So then when you create a knuckle, the knuckle can actually become quite tight and even fold upon itself. So you have multiple sort of superimposed knuckles that you're advancing forward. That's different than a Raider, where the core is a little bit thicker, goes all the way to the tip, so that when you push that wire forward, you create a larger knuckle. And that's different still from a Mongo wire, where the core effectively terminates 10 millimeters proximal to the tip. So when the tip folds on itself, it's got almost nothing behind it. And so that tip then folds very tightly. But then as you advance, you have the core of the wire to advance along.
Dr. Sharad? Dr. Nagamatsu?
I mean, whenever I'm using knuckle to traverse, Sanjog, I'm Dr. Sharad from Hyderabad.
Hi, Sharad. How are you?
Hi.
How are you?
Yeah. So whenever I'm using knuckle to traverse ambiguous chords, I tend to use either Fielder XTR knuckles or sand block. I don't use Gladius Mongo. And when I know the vessel chords and calcified vessel not able to cross with the antegrade wire escalation, and that's when, if I'm doing a knuckle, so I used even Gladius Mongo also, because as Sanjog already mentioned, it forms a very small knuckle. It won't propagate proximally. So, and it remains the size what it is at the 10 millimeters tip. So, it is a good wire to knuckle. But I'm scared to use it in an ambiguous chord scenario, because it may just go off your vessel codes as well.
The experience that I've had, for what it's worth, is that, I mean, the construction of the wire is the same construction as a Pilot 200 with respect to polymer jacket and with respect to likelihood of the tip to fold. And that's why it's going to ultimately, you know, in my experience anyway, function a lot like a Fielder XTR or a Pilot 200 or whatever, the knuckle, right? Ultimately, these types of wires don't tend to exit unless they go out the side branch. And that, I think people do be quite aware of, where if you start, you know, and your point's well taken then in that regard with respect to the ambiguous course. And I think that's why some people lean back towards Fielder XTs, because the knuckle that they make can be initially larger and fold upon itself, and as a result avoid side branches. So that point is quite well taken. I think it just depends on, you know, so you're comfortable with that particular wire. Ultimately, it's not about having 20 different wires on your tool in your toolbox. It's about having one or two that you understand well.
Okay, so this is Nagamatsu from Japan speaking. Thank you very much for the very excellent your lecture. So I would like a little bit mention about I would like a little bit mention about the Gradis Mongo. So maybe there about 8 years ago. So then the Asahi in this era, and the Asahi that developed this Gradis Mongo guide wire. So very happily I am the one of the investigator. So actually and I am the first physician that used this Gradis Mongo for the accuracy of PCI. So anyway. So in this era, we have the two types the Gradis Mongo guide wire. One is the hard guide wire. The another one is the now available one. So so actually the Gradis Mongo wire is a little bit have and a little bit to have their the very easy way to making the complication the perforation. So anyway, and so we discuss about which guide wire is better for the making knuckle. But I would like to mention about additionally the microcatheter position is a very important. So we have to purchase the knuckle shaped part so every time the before the pushing. Thank you.
I think because of time, we have to stop the session. I think all the speakers did a good job. It was a very well. It's a tough subset CTO, but both the antigrade, retrograde, virus escalation, everything was discussed. Thank you.
Thanks, Sanjog, Sharat, and Dr. Nagamatsu for excellent talks. Thank you.
Thank you, Sanjog, for doing this exercise while checked in and all. Thank you. We appreciate your contribution and see you in live next year in person. Thank you.
Thank you, Dr. Kalra. We move on to the next session. Thank you to the chairpersons of this session. The next session on calcification. May I please invite to chair the session Dr. Ramakrishna Pillai, Dr. Deepak Davidson, Dr. Shiva Prasad, and Dr. Krishna Kumar, please. Quickly, once again, may I remind you that we've overshot time by 10 minutes, 5 to 10 minutes. So the first talk is by Dr. Deepak Davidson. Over to the chairperson's talk.
I would like to start by congratulating Dr. Anil, Dr. Verma, Deepak Davidson, and the whole team for organizing this brilliant, elegant conference. Now, the next session will be on coronary calcium. It has been traditionally the enemy of the interventional cardiology. We have some means of tackling this enemy. Of those measures, rotablation and IVL have been the foremost in recent years. First, Dr. Deepak Davidson will tell us about the tips and tricks of rotablation techniques. Deepak, please.
Thank you so much, sir. Good evening to all of you. First of all, let me thank each and everyone who has assembled here, taking your weekend off from your busy schedule, staying away from your dear ones and joining us today this evening. Over the next 15 minutes, I shall share with you the very basics of rotablation. When I speak on rotablation, I'll be using these two terms. One, the drive shaft, the pink arrow that points towards the drive shaft. You see the burr, and the burr is attached to the drive shaft. And then you have a sleeve over the drive shaft. So I'll be discussing these 2 points very frequently during my presentation. Well, I'll start with the case history of a 83-year-old gentleman who had an inferior wall MI long ago, was on medical management, now present with a recurrent inferior wall myocardial infarction. We started off looking at the right coronary artery. It was totally occluded. Probably this was a MI producing vessel long ago. And now he has a large OM branch, which is totally occluded, which can be very clearly seen in the second image. It was difficult for us to open up this particular OM branch. We started off with a 3.5 millimeter, 3.5 curve guide catheter. We had to switch over to a 4 curve guide catheter for a backup support. We had to use a guide extension catheter, the guide plus catheter. You could see in the second image that we had to get across the lesion with the guide extension catheter. Then through that, we were able to track the stent distally, and then we were able to stent it, and we were able to achieve a good result for that inferior wall myocardial infarction. Well, in the second image, you could see that he also has got a very critical stenosis in the left anti-descending artery, which is a heavily calcified vessel, which is almost 90% RC is retrograded filling from the left coronary system. So we decided that we wouldn't do anything for the right coronary artery. He's 83 years. Probably we should bring him back at a later date and do an angioplasty to the left anti-descending artery, that particular calcified critical stenosis. Well, how do we manage this particular heavily calcified left anti-descending artery? Most importantly, you need to plan and then go ahead with the procedure. How do we plan for this particular heavily calcified left anti-descending artery stenosis in an 83-year-old gentleman? Now, we always try to avoid ad hoc procedures when we have a heavily calcified vessel. Have a look at the coronary angio again and again multiple times so that we become more confident managing this. We try to control the heart rate with good dose of beta blockers so that on the day of procedure, the heart rate is around 50, 60. Try to reduce the antihypertensive agents on a couple of days prior to that so that we have a better blood pressure during the procedure. Arrange Paxils, inform the surgical team, anesthesia evaluation, nil oral, start off early morning with these cases and have the Impella ECMO and either IABP ECMO, and even probably one could think of an Impella standby. When we did this, the angioplasty, primary angioplasty to the OM, before we came out of the of the radial artery, we had a look at the radial artery just to make sure that the radial artery is good enough so that we can go in with a second 7 French guide catheter for a rotablation of the left anti-descending artery. So we were aware that the radial artery was good enough to have a second procedure done through the radial artery. And secondly, we also decided that we'll start the procedure with a EBU 4 curve guide catheter because of our first experience, because it was extremely difficult for us to open up the OM branch. So we decided that the second procedure also should be done with a good backup support. Many times we do our procedure with a 3.5 EBU, but then in this particular situation, we decided that we should go with a 4 curve EBU. So that was the left anti-descending artery, which we were planning to go ahead with. Now, what are the basic steps of rotablation? When I started rotablation almost 10, 12 years ago, this is how I used to divide things. Get the team ready for the rotablation, get myself ready for the rotablation, then do the rotablation, getting out of the vessel. So these are the 3 things that I decide on, the steps that I started off when I started with rotablation. Getting the team ready, one. This is how we start off. When we decide on a rotablation, the cath team as well as the staff nurses, they start off with all these things. They get the console foot switch connections ready. They get the hospital 7-bar pressure line connected to the console. Then the rota flush, the pressure bag, the micro catheter, rota wire, and even the advancer. All these things are made ready within a couple of minutes. Nowadays, when we decide on rotablation, these things are the team, they get all these things ready within couple of minutes, and then we start off with rotablation. How do we start off? Many times we go with a 7 French guide catheter, even though a 6 French guide catheter can take up an 1.5 7.5 millimeter burr, majority of the situations we always start with a 7 French guide catheter through the femoral approach. If it's a tortuous vessel, then we go with a long sheath. It could be either a radial or a femoral approach, but then a 7 French guide catheter is always better. Then cross the lesion with a workhorse wire, get the microcatheter across, and then remove the workhorse wire and exchange the rotafloppy over the microcatheter. Because if you do this particular exercise many a times, you wouldn't damage the rotafloppy, but then if you try to do primary wiring with the rotafloppy, many times we tend to damage the rotafloppy wire, so that the burr finds it difficult to go through that particular damaged wire. Now, the second problem would be if you have the microcatheter that doesn't cross the lesion, what are the options that we have? We have the workhorse wire across in the distal LAD, but then the microcatheter is stuck in the proximal LAD at the calcium. What are the things that we could think of? Keep the microcatheter well inside the lesion where it's stuck, keep the nose well inside the lesion, remove the workhorse wire, and then try to do wiring with the rotor wire itself. The second option would be to get an OTW balloon across the lesion, that is a 1 millimeter or a 1.5 millimeter OTW balloon could track in through these particular critical stenosis distally, so that you can exchange it with the OTW wire. And the third option would be you could have this Caravel, the tapered tip microcatheter, so that could cross across the lesion. Now, there are situations where the microcatheter wouldn't go across the lesion, and even the rotafloppy might find it difficult to go across the lesion. Like in this particular circumflex, a failed angioplasty to the circumflex artery. In the second image, you could see that it's a 90-degree bend at that calcified area. We were able to wire it with a Fielder FC wire. Then we tried to get the microcatheter across. As seen in the first image, it wouldn't go across that particular calcified area. We were not able to get the microcatheter across. So we removed the Fielder wire and tried to go with the rotafloppy wire. That is what you see in the second image. The rotafloppy wire wouldn't take the 90-degree bend. That point of time, what we could do is we could get the Fielder FC wire by the side, so that it straightens that particular vessel, and then with that particular wire by the side, we were able to get the rotafloppy across. Then finally we were able to rotablate and then get a reasonably good result at that particular area. Now, this is yet another situation where we were not able to get the microcatheter across. You could see that the RC is anomalous. So, coming from the left coronary sinus, we were able to get the guide catheter that was in short Amplatz left guide catheter. And you could see that there is a distal lesion in the right coronary artery. It was extremely difficult for us to get across the lesion with a regular Fielder FC wire. We had to use a Fielder XT wire. It was looking so simple, but then none of the wires would go in, and ultimately we had to use a Fielder XT wire to get across the lesion. Now, once we were able to get across with the Fielder XT wire, the Caravel catheter wouldn't go across. So you could see that the guide support was extremely bad, because we're going through the radial approach. It was 7 French short Amplatz left catheter, an anomalous vessel. We were not able to get the microcatheter across the lesion. So at that point of time, we have a handy option. We used a laser catheter, that's a 0.9 millimeter laser catheter at high energy and high frequency. We were easily able to get across that lesion with the laser catheter. We didn't have significant backup support from the guide catheter. Despite that, you could see that the laser catheter went across that particular lesion at high energy, high joules. And then once we were able to get across, it was easy for us to remove the laser catheter. Then we were able to get in the first image, you could see that we were able to get the Caravel catheter across, then exchange with the rotafloppy wire, finally rotablation, and then we were able to achieve get the stent across with the guide plus catheter, and then we were able to achieve final result. Now, once again coming to the basic steps of rotablation. Once you're ready with the rota wire, rota advance ready, get the burr near the Y connector. So we are threading the burr over the rota wire, and in the second image you could see that the burr has reached near the Y connector. Now, once you reach near the Y connector, you need to look for 4 important steps. That is, you look at the drip rate, make sure that the drip rate is good enough. Second important point is make sure that the burr is working well, the RPMs are stable. try dyna mode, try rota mode. We usually keep the rota speed at 180,000 RPM when we start off with the procedure. Then the next two important things is look at the advancer, whether the advancer knob is easily moving backward, and finally also make sure that the wire clip is in position. So these are the four important things one need to evaluate before getting the burr into the guide catheter. So drip rate, the rotor speed check, the advancer, and the wire clip. These are the four important things one would look for. Now once we are ready with this, now I would be getting ready for the procedure to be done. I need to introduce the burr through the guide, advance it, and park near the lesion. Now again, that is also challenging at times in certain situations. This is how we always do that. We try to push the burr with one hand and pull out the wire from the other side of the advancer, the push-pull technique. That's what Matthew Samuel sir says. So this is how we do that. And there are certain situations wherein the burr gets stuck. It wouldn't take the curve of the EBU catheter. You can see that these are the two areas at times the rota burr might get stuck. And also there is a third situation wherein you have a distal lesion, and if the proximal vessel is calcified, the burr wouldn't reach the distal lesion. You can see that the distal lesion is tight, has got a critical stenosis there, but then because of proximal calcium, this 1.7 millimeter burr wouldn't reach that particular lesion. So in these situations wherein the burr wouldn't move forward, you can go for an activated burr advancement. Now, how do we do the activated burr advancement? The second operator would be holding on to the wire, the rota floppy. You could see that the second operator is holding on to the wire, and then go to dyna mode, press the brake defeat and take the entire advancer as a whole so that it moves towards the lesion. So that is how you could see that the 1.7 millimeter burr is moving towards the lesion, and once it reaches the lesion, then you could do the burring and get away with the final results. Now, once you reach near the lesion, always remove the tension built on the burr before you start the rotablation. This is what happens. This is how the tension occurs inside the sleeve. What happens is, if you look at the first image, you can see that the rota burr is almost 2 centimeters out of the sleeve. Now, as you push the sleeve or as you push the rota burr into the coronary artery, what happens is the burr moves into the sleeve. That is, now you can see in the second image that the space between the sleeve and the burr is too less, which means that the burr has been pushed into the sleeve. Many times this happens when you get the burr into the coronary artery through the guide catheter and reach near the lesion. Now, if you start burring in this particular position, what could happen is the burr would jump forward, it could go across the lesion and then get stuck there. This is just a video of showing that. You can see that as you push in, the burr would actually go into the sleeve and you have a tension built up over there. So you need to relieve that tension before you start burring. So this is how you would do that. You could relieve the tension. When you go inside the coronary, always keep the knob of the advancer halfway in the position, and then once you are inside the coronary near the lesion, move the knob backwards so that the tension can be released, and then you could start burring. Now, regarding rotablating, these are the steps probably one should keep in mind. One step burr many a times, except in heavily calcified lesions. Avoid RPMs over 180,000 or so. Less than 5,000 RPM drop during the burring. Around 15 seconds. This is what we routinely do. 15 seconds of burring followed by religious waiting for 1 minute so that we have a breathing time for the coronaries. And then we again repeat the burring. Never stop the burr beyond the lesion, and plaque modification to be thought of rather than debulking, which means that we do not have to go in for aggressive debulking with 2 millimeter burr or 2.25 millimeter burr. In the present era, majority of situations it's 1.5 millimeter. You could go up to 1.75 or maximum 2. So now there are certain challenges that could happen during the burring. This is a mid-LAD calcified stenosis. While doing the burring, the burr wouldn't cross across the lesion. At some point of time, what happens is the wire comes backwards. You can see in the first image that as we keep burring, after a point of time, the wire comes back towards the lesion. So how do we take that wire forward? You need to do dynamo. You go to dyna mode, and then the second operator, as you keep burring, what you could do is the second operator could press on to the brake defeat and then push the wire across. Now look at the second image. If you concentrate on the second image, as I am doing the burring on dyna mode, the second operator has pushed the wire distally across. So this is the only way of getting the wire distally into the vessel if it comes back proximally during the burring. Now this, again, you could see that the wire has been pushed distally and then rotablation has been done, and then finally we were able to get the balloon dilatation and final good result. There are situations wherein the advancer knob doesn't move freely. Why this happens is when the pressure drops inside the Dyna bag, that is inside the fluid, if the pressure drops, what happens is blood seeps between the drive shaft and the sleeve. Blood gets into the space between the sleeve and the drive shaft, so that, as seen in this particular image, when the blood seeps in, the knob wouldn't move forwards and backwards easily. So always make sure that the pressure is well maintained inside the rota fluid. That is the nurse or the scrub nurse who is assisting you probably should make sure that always the pressures inside the bag is more than 300. So coming back to our patient, I'll stop in another 1 minute. Coming back to our patient, that was the heavily calcified stenosis in the left anterior descending artery. We started off with an 1.75 millimeter burr. It was difficult for us to get the burr across near the lesion because of the heavy calcification. With activated burr advancement, we were able to get it near the lesion. Started burring at 180,000 RPM. At 180,000 RPM, we were not able to go across. We increased the speed to 200,000 RPM. We became more and more impatient because it was not going across, and at some point of time 220,000 it wouldn't go through. Now when it doesn't go beyond the lesion at 220,000 RPM, we downsized to 1.5 millimeter burr, and even the 1.5 millimeter was finding it difficult to go across the lesion. Now when the burr doesn't cross the lesion, what are the options that we have? Improve the backup support, increase the RPM, downsize the burr, and take a new burr. We now moved on to a new burr, and finally we were able to get across. That's the 1.5 millimeter burr, new burr. And now you could see that at some point of time, as we were pushing it through, it went across, and then we upsized it to 1.75 millimeter burr. That's the 1.75 millimeter burr at 200,000 RPM. We were able to get across. Then next thing is getting out of the vessel. Getting out of the vessel, probably on the Dyna mode, we should be doing that. Press the brake defeat and push the wire into the coronary artery so that the burr just comes out of the guide catheter. And finally, before doing balloon dilatation, do not remove the rota wire. But we nowadays remove the rota wire before balloon dilatation, because many times after the rotablation, we always try to do the imaging so that you wouldn't want to have a second wire doing imaging. So we went ahead with imaging. Multiple areas of polishing was identified. Then we went ahead with NC, OPN, and finally we were able to stent it. And again, when we imaged, you could see that there were areas of under expansion, and it was finally further modified, and we were able to achieve a good result. And that's my last slide. When you encounter hypotension during rotablation, what should be kept in mind? These are the things probably one should keep in mind when you have hypotension during rotablation. Always immediately go to the groin and see whether you have the bladder being compressed to the opposite side, like what you see here, because many of these patients do have calcification of the femoral arteries. Also, you're likely to have groin hematoma. So when you have hypotension during rotablation, look at the groin, make sure that there is no retroperitoneal hematoma. Nitrate inside the rota flush can lead on to hypotension. Slow flow perforation air embolism also can lead on to hypotension. So these are the points also that needs to be kept in mind during rotablation when you have hypotension. Thank you so much for the patient hearing.
Thank you, David. Deepak, wonderful lecture and very many important points. You have mentioned how we can prevent burr stalling by paying attention to the rota flush, and prevent burr entrapment by relieving tension on the drive shaft before actually starting burring. Very important points. What is your take on orbital atherectomy? How has it improved this situation?
So of late, we've been using orbital atherectomy also. What I find with orbital atherectomy is when you have an extensive calcification, it takes very long time for orbital atherectomy to work. So when you have a long lesion and heavily calcified lesion, the first option probably should be rotablator. And when you have nodular calcification, short segment lesion, those situations, orbital atherectomy would be easier because of two reasons. One, you take quite a long time for orbital atherectomy to go across. Second reason, you really do not have an end point when to stop it. once it goes across, whether to stop it or keep burring at lower speeds, higher speeds, you do not have an end point. So I prefer using orbital atherectomy in short lesions, calcified lesions, and when there is nodular calcification. Otherwise, when it's an extensive calcification, very significant intimal calcification, it's always rotablation.
Some cases in acute coronary syndromes, we come across calcifications, which we get our devices. We are not able to get our devices, stents, and all that to the desired location. So, how do you approach that?
In most, let's say we do 100 rotablation, it's 50% is acute coronary syndrome. Only 50% of them, they come with a chronic stable syndrome. So we wouldn't have any concerns in using a rotablator during an acute coronary syndrome, except in acute myocardial infarction. When you have huge thrombus burden, you end up having a slow flow. But at least 2 or 3 cases we have done in no option situations in acute myocardial infarction also had ended up with slow flow, but then it promptly got relieved after having intracoronary nitride or adenosine, things like that.
A temporary pacemaker is mandatory for RCA rotablator.
Yes, always we do that. Dr. Samim Sharma says that it's not really needed. I mean, aminophylline infusion is needed, but we always meticulously use temporary pacemaker lead for right coronary rotablation, dominant circumflex as well as left main rotablation.
Now, as a country, Deepak, you have given us a very clear picture of basics of rota. Congratulations on that. One question, in continuing with the acute coronary syndrome, you try dilating the vessel. You tried with balloons, balloon got ruptured, and then you're not very sure whether you have caused dissection or not. Will you continue doing it the same day, or you take the patient back later and proceed with the rotablation?
Yes, sir. Many of these failed balloon angioplasties will be having some amount of visible dissection flaps also. In fact, we do have certain patients who are referred to us wherein balloon could not be dilated, small dissection flap. Almost always we go ahead with rotablation during the same sitting without any concern. What is said is when you have an extensive dissection, probably rotablation should not be attempted for the next 6 weeks. But then I've never had a situation like that wherein extensive dissection had happened following balloon dilatation, preventing us from using rotablation in the same sitting.
What is your treatment for severe no reflow phenomenon which happens in the right coronary
So
artery?
it's always like treating an acute myocardial infarction, slow flow. During primary angioplasty, we get the microcatheter distally inside the vessel, then have nicorandil adenosine and nicorandil adenosine nitride. And if it doesn't settle down, then final option would be adrenaline, intracoronary adrenaline.
Have you encountered such kind of severe?
Yes, I have lot of examples also. Inferior ACS getting converted into ST elevation, MIs and all, we have examples for that. Severe no flow, but then all these patients have survived. Not even a single patient had required an IABP, but then with all these intracoronary cocktails, including adrenaline, almost everyone they settle down with that. But then at that point of time, we wouldn't go with a upsizing of bar, 1.5, and that's it.
Most of these calcified lesions occur in patients who have significant multivessel disease.
Yes, sir.
And they also have reduced ejection fraction.
Yes, sir.
So do you have any precautions you take right from the beginning?
So we are very careful in most of the situations where we do rotablation. It's all good LV function patient. We always try to avoid all those severe LV dysfunction, extreme calcification, because if at all a severe LV dysfunction and rotablation is needed, probably at least an IABP should be used.
How many vessels you do at one sitting?
2, not more than 2, sir.
Why do you routinely put a rotablation at the pacemaker? I thought always on a pacemaker you can have more complication with the pacemaker than without a pacemaker.
So we always have the pacemaker wire in the septum, not in the RV free wall. Because initially we had been keeping the pacing wire. While doing rotablation of the right coronary artery, we had the wire in the inferior vena cava. But then when you have a slow flow or when you have a brady, the temporary pacemaker wire, it never goes into the right ventricle. It just keeps rotating in the RA. So nowadays we never keep it in the IVC. We always keep it in the septum. So you're in a safer position. You wouldn't have a perforation at all. Always with right coronary, we would prefer having a temporary pacemaker wire. But every time with left main rotablation also we have the temporary, but then we have never seen a brady occurring during a left system rotablation unless it's a dominant circumflex artery.
Just nice lecture. Just one comment. Just for the beginners, what my advice would be in my experience, as you rightly said, we should start the rotablation at 180 or say maybe 200,000, and the final polishing run has to be done with the lower speed, because when we do on the higher side, chances of rotable stuck is less, and the final particles are less, slow flow is less, and it is a slow speed as against the people think the budding is more.
Yes, sir.
So the final polishing run should be at the 150 or 140, and you get a good bed size. And secondly, what we have done in the last few years, after to avoid the slow flow, we take with the 6 French, you can do easily up till 1.5 or 1.75 bar.
75.
But if you take a 7 French, you can inject normal saline with the each burring instead of a contrast which load increases. If you keep injecting normal saline 10 cc with the each burr, almost in all cases, even with the dysfunction, we never had any slow flow.
Sir, but have you ever had air embolism during this sort of
You
cell?
have to be careful.
Because we never do the saline injection, because when we started off, we have had at least 2 or 3 air embolism, because the sleeve would occupy the entire space, even in a 7 French guide catheter. So
I never had.
we never use.
He will, Dr. Mahesh will say, we have done it and we never had, but I do it myself. I don't give it to anybody else.
True, sir.
And the slow flow decreased like anything. Initially, we started off with the contrast, but the contrast load increases. So with the normal saline, but you don't give it to anybody else, because if it tries to suck and does
Careful.
something, then it creates a problem. And finally, what you said rightly, when you re-platform, in the same way, the second person is not required when the wire comes out. You just tighten the TUI, put on the Dynabud, and push the wire. It will go.
Yes.
The same fellow can do it.
Yes.
Deepak, can I revive an old question? After rota, what? If there is no, the increase in lumen has not been satisfactory after rotablation, what are our options?
So nowadays, there are many, like what I've shown in this particular case. Many times when you have left mains also, it's almost always 1.75. Start off with 1.5, upsize to 1.75. And it's just the first half of the story. Its ablation has been done. So primarily when you encounter a heavily calcified lesion, it's always going to be a volume reduction strategy as well as a calcium cracking strategy. So volume reduction strategy would be with rota or a beta-atherectomy or so. And then you obviously need a cracking strategy, which could be achieved with an OPN or IVL or a non-compliant cutting scoring also. It's always combined. In a heavily calcified lesion, we need both these strategies and not one alone will work.
Cutting balloon, opium balloon, or IVL?
Yes, sir.
Things may have to be considered.
Sorry to interrupt, sir. We will have to move
Thank
on.
you so much.
Yeah, this was
Thank
a
you,
wonderful
sir.
lecture. We invite now Dr. Mahesh for the lecture on IVL.
I wish this was a debate. Deepak Davidson would have no place to hide. All the technical know-how required for an IVL is all the technical know-how that everybody has who has been doing angioplasties. It's a 0.04 mm balloon. You should be able to get it across the lesion. That is all what is required. So there is nothing great about using an IVL. So I shall be talking about the theory of IVL and a little bit about the practical uses of IVL. It's got a generator, it's got a cable connector, it's got a push button, it's got an IVL catheter, it's got a coronary IVL balloon, inside which there are emitters which emit the electricity or the current or the sound waves or shock waves, whatever you want to call that. Okay, this is all what is there in the IVL. And the most difficult part of the whole procedure is getting the balloon across the lesion. So first, you listen to what Dr. David had to say, Deepak had to say. You do a rotablation, you do an NC balloon dilatation with a 2 mm balloon. If you've got a 2 mm balloon across, your problem is solved. So what does it do? It's a little bit of theory, but it has to be understood because people use IVL without knowing how it works. It creates multiple macro fractures in the calcified block, and this allows for opening up of the vessel before sending. They produce electric sparks, those small emitters I showed you, and they create vapor bubbles in the surrounding fluid medium and in the integrated balloon. So the emitters have to be always inside a fluid medium, and the emitters emit energy and the fluid medium gets activated. The IVL produces low levels of electric energy, leading to formation of rapid expansion of vapor bubbles, resulting in acoustic pressure waves that radiate circumferentially. Basically, the waves get exaggerated as they leave the air, bubble of the balloon that is surrounding the emitter. The acoustic pressure waves interact with high density tissues such as calcium without affecting the soft density tissues, hence the usage in calcium only. This interaction disrupts the calcium by creating micro and micro fractures and increases vessel compliance. So this is the way in which works. There's a spike and there's a rapid depression which causes waves to spread laterally, and it causes, for the more theory oriented people, it causes three methods. One is called spallation, one is called fatigue, one is called cavitation, one is called squeezing equator. I'll tell you one line about all these things so that we know how this thing works. Squeezing occurs between the difference of speed between the solid calcific deposit and surrounding a soft tissue. So when it crosses the soft tissue and hits the calcium, it hits it with much higher velocity, and that causes damage to the calcium. As a result, the shock wave inside the calcific tissue moves faster and away from the shock wave propagating through the surrounding soft tissue. This results in circumferential force in the calcium, leading to tensile strength and break of the calcium. So the velocity is multiplied multiple times as it hits the calcium. Acoustic cavitation refers to a generation of cavity, small bubbles in a fluid in the tensile phase. This also causes negative phase, and this is also a surface acting mechanism, and it's on the superficial part of the calcific tissue. You have fatigue, repeated ramps obviously causes fatigue, and you have spallation. Spallation is where the wave travels all the way to the other end of the calcium, then crosses the calcium, hits the soft tissue, and travels back. So it's like, it goes all the way up first and then travels back, causing more damage to the calcium. Basically, the calcium gets damaged, the soft tissue doesn't get damaged. You couldn't ask for better. So as the acoustic shock waves are propagated through fluid and impaired by air, so you should have fluid. First step is to wash out the catheter in the air in the catheter. So you have to fill a 5 cc syringe with 5 cc of 50-50 saline and contrast medium and connect the syringe to the inflation port of the catheter hub. Pull the vacuum at least 3 to 4 times to allow the fluid to replace the air in the catheter. Please supervise this step yourself, and the technicians may not do it as well as you would like it to be done. Inflated device with 10 cc again of 50-50 saline contrast medium to the inflation port, ensuring that there is no air introduced into the system. These are the basic requirements: 6 French catheter, guide extension. Anything more than 5.5 French can be used. Catheter length is 138, guide wear compatibility is 014. Balloon diameters are from 2.5 to 4. Balloon length is right now 12, the 19 is on the way. Balloon diameters are crossing profiles. Then lithotripsy per balloon is 2, pulse frequency is 1 per second, maximum duration is 10. After that, you take a pause. Maximum pressure generated is 50 atmospheres. 50 atmospheres of pressure is what is being generated on the calcium. Imagine any cutting balloon or any NC balloon can go up to 16 to 18 atmospheres. And 80 cycles, now it's changed to 120 cycles. We have a C2, which has got a 120 cycles. Balloon pressure is during shock delivery is only 4 millimeters. So you are not going to rely on the balloon pressure to do any damage. It is the shock wave generated inside the balloon that does the damage. So as the IVL emitters, should we do it for eccentric or concentric calcium? IVL emitters generate circumferential acoustic wave. So if you have a circumferential calcium, it is better. That is the bottom line. 270 degrees plus, it does a wonderful job. But even if you have a calcific nodule, it is useful provided you just concentrate on all your energy in one point. There is evidence it is also useful for eccentric lesions. I shall show you my studies. And what is the intravascular therapy application? The catheter diameter should be selected 1:1 ratio relative to the target vessel diameter. So if you have a target vessel of say 3, then you can afford to take a 3 millimeter balloon, provided the tightest area is about 2.5 because you have crossed to the 2 millimeter balloon. What you should understand is that if the target vessel is 4, the tightest area is 2.5, you take a 4 millimeter balloon, and if you are not able to expand the balloon adequately, the balloon will be folded inside. So, when in doubt and when you find that the lesion is a little tight, you may go in for a slightly smaller balloon, but as far as possible, go in for a 1:1 ratio. Proper apposition of the balloon to the catheter arterial wall is very important. There are several mechanisms I had told you. The estimated peak pressure is 50. So this is where the track comes in. So where does Dr. Deepak's thinking come in? Only here. Where there is an uncrossable lesion with a balloon, you use a rotablation. Rest everywhere where there is a suboptimal balloon expansion, your solution is lithotripsy. When you have mild calcification, balloon predilation, suboptimal expansion, again lithotripsy. If you have IVUS OCT assessment and the score is 1 to 2 points, high with very high with or very high pressure NC balloons, suboptimal result, lithotripsy. 3 to 5 points, lithotripsy straight away. Don't wait for all the stunts of doing NC and cutting balloon, may not just work. Anyway, lithotripsy works better. Only problem is if it doesn't cross. If it doesn't cross, then you go to rotational atherectomy and then come back to lithotripsy. So as of now, the choice of treatment of any calcium which is not in this, that is balloon predilatation. If there is optimal balloon predilatation possible, there you go in for a normal stenting. Anywhere else, lithotripsy is the option of choice, provided you can afford it. The baseline, 68% stenosis, post-IVL, 3 millimeter IVL balloon. You can see the result, residual post-stent, 8.7 stenosis. This is the left main trifurcation. You can see that post-IVL, we got excellent results. And this is how the pre-IVL area looks like, 3.4 with almost 360-degree calcium. You can see your lumen area is 7.02. Now post-IVL, you can see the lumen area has gone up from 3.4 to 5.7. These things, what you can see are the cracks that has developed because of the IVL. And this is the cracks in this second case because of the IVL. And post and lumen area, you got 10.565. From 3.44, you could go up to 10.65 area. Now, when do you image in an IVL is very simple. You image in an IVL pre to make sure that you require an IVL and then post stent. There is no specific thing that you can get by imaging in between. That is post IVL imaging won't give you much of information because of this reason. Most of the catheter, most of the cracks are very micro cracks which can be picked up only on CT scan, or in this case is a cadaveric superficial femoral artery where you can see pre-IVL, post-IVL. These cracks cannot be picked up with even OCT. I was so impossible. So there is no additional information that you get by doing post-IVL OCT. Then what is about shock ectopics? They're called shocktopics. So when you do a 10 frequency thing, can you see this red arrow? That is a one thing where the shock has caught onto the ventricle and given the ventricular ectopic. How do you know it's a ventricular ectopic? From the ECG morphology and the drop in pressure. So the third beat and here the 10th beat cause a ventricular ectopic. Theoretically, it can cause a VT, but it has not happened so far in my experience. A couple of case reports have been there. So these are the studies. Disrupt 2, Disrupt 3 has also come. So comparison, nothing much to compare. They are independent and indications are totally different. When you can't cross, use a rotablation. If you have crossed and a 2 millimeter balloon has crossed, then you use an IVL. The various steps, I'll skip this because it is too simple to be spent on. You have to just experience an IVL. Some things that can go wrong. This is a case where I first did a rotablation. And you see this, there are two lesions. One is a proximal lesion, one is a distal lesion. So the proximal lesion, we did an OCT, we found that the lesion was heavily calcified, 360 degrees. We have to take a IVL. We took a C120. The 120 has got a lot of pulses, 120 pulses. So I thought I could do this lesion and I could do this lesion. So this is OCT run. So the pre-dilatation was done with a 2 millimeter balloon. I managed to push my catheter through the IVL balloon, eventually reached the distal lesion. So this is brought there with great difficulty, and the IVL balloon was slowly expanded to 4 atmospheres. It's a long run. Please bear with me. It's a very important run. So as the IVL run, the balloon was expanded to 4. It burst. So the moral of the story is that even if you manage to reach the balloon to the area that you need to do, if you're tracking it through very difficult areas of the calcium, that is proximally, the IVL balloon is very sensitive, very thin. Any spicule can burst it. So what the solution to that is very simple. You please take your guideliner, take Guide Pro, and then pass the IVL balloon through the guideliner, and then go ahead and do this thing. Sorry, this is the. This is the second case. I'll just show you the second case just for demonstration of all the steps of how to tackle the calcium. Tight lesion, it's got a calcific nodule. Calcific nodule is very obvious from the angiography itself. The 2 millimeter balloon just wouldn't go through. So we had to put in a rotablation. We took a 1.5 burr, standard go-to burr, rotablated the lesion. We could manage to get across the lesion very well with the 1.5 burr. Once the rotablation was done, no perforation, always take a puff after the rotablation. Then dilated with an NC balloon. After the NC balloon dilatation, we got a reasonably good area. We thought we can just go with the NC balloon. Did an OCT at this time. We found that there was almost 360-degree calcium with the calcium thickness more than 0.5, and there is a significant calcific nodule in that particular area. So this is an ideal case where we can do this is the morphology of all the 3 areas as in the OCT run. Post-rota, we could see post-rota cuts. These are the rota cuts that you can see, these small shaved areas. And if you find an extremely smooth area across one place, that's usually because of the post-rotablation. This is the post-rotablation pictures. Length of the stent was determined, 46.6. Diameter was calculated. These are all advantages of imaging. Once the diameters were calculated, this is the final result. So we did a stent, we put 2 stents, 44 millimeter totally, and we got finally very good results. So the point I'm trying to stress is that IVL is the modality for tackling calcium. Anything beyond that cannot be tackled with a non-compressible balloon, NC balloon. If you can't do an NC balloon and dilatation, the next option should be IVL. And it's proven to be safe, it's proven to be effective, and it's proven to show excellent results. Thank you.
Very nice, Dr. Mahesh.
Yeah, sir.
Excellent talk. Your lesson that for targeting a distally location, for targeting a distally located lesion, you should use a guideliner was very, very useful.
Yes, sir. Learned it the tough way. Because first time I broke a balloon, they gave me one free. Second time they broke a balloon, I'd really break them to give me one free. So it's very difficult to get a IVL balloon exchanged once you damage the balloon.
Very nice.
After the initial few balloons, they modified the balloon technology so that the rupture chances are much lesser now. But it still does happen.
This is C2, which I broke is a C2.
C2 plus.
C2 plus.
Still does happen. What question is there from Dr. Mark Silvestri online? He wants to know your experience with IVL in calcified left main lesion.
Can you just open that file for me? Excuse me. Where is my this thing? Yeah. So thank you, Dr. Mark. I couldn't help boasting. So this is my presentation in TCT. I presented coronary calcifications of for 22 consecutive cases of calcific left main bifurcation undergoing angioplasty were enrolled. We did 22 cases, primary safety points. This diabetes, smokers, everything, the usual stuff. The number of calcium fractures were calculated. The MLA gain was calculated. Post PCI OCT was done, and we got these results for the pre-IVL and post-IVL. So the LM went up from 4.35 to 11.51, LAD from 2.14 to 6.92, and circumflex from 2.1441 to 5.79. So this is one of the largest studies of IVL in left mains. So we have Cosgrove, Salazar, Rollet, and we have our study in which 22 cases were done. 100% with OCT. OCT was done pre-IVL, post-IVL, and post-stent. 3 runs of OCT were taken, and we presented this in TCT this year. Freedom from MACE was 95.5, and no slow flow, no reflow, no major dissections. This is our study which we had presented in TCT. So left main, IVL OCT, very safe. Just make sure that you have your first inflation. Make sure that if there is a fall in hemodynamics, release halfway through, maybe after 4 pulses, maybe after 6 pulses, but release. But you'll find that subsequent dilatations, the patient tolerates better. So this is our case. We had presented this in TCT. We had done 21 cases of left main, all successful. Thank you.
Manish, one practical question. I know your IVL experience is much more than mine. One practical question in a sense that we have a long diffuse LED. I got stuck up in few cases. Proximal part is okay. Mid to distal LED, long lesion, and we want to keep Dr. Deepak Davidson out. Rota we don't want to use. Now, if we use IVL somehow by pre-dilating and doing something with the spicules, how would you use? Because if you take these balloons distally and then dilate and then try to pull, the whole catheter will come and stuck. If you do it proximally and then try to push it, it will not go beyond. Partially, you have already answered it by taking guideliner.
Yeah. Every movement
But
of the
either you take the guideliner right from the beginning,
right
or
from
you
the
don't
beginning,
take it,
right
because
from
advice of
the
everybody's advice, because otherwise you will get stuck up in the
right from the beginning. Guideliner to the distal most part. Deliver the balloon there. Pull back the guideliner. Do
then-
your thing. Take the guideliner back. Load the balloon. Withdraw it back a little bit. So don't let the balloon get into the calcific environment at all unless you're going there to dilate.
Otherwise it will stuck.
It'll break.
Your balloon got ruptured after the first dilatation?
No. When I was going through itself, it got ruptured.
Okay.
Otherwise, they wouldn't have replaced it.
Okay, one advice was I had a case, my case, the balloon got ruptured after 6th cycle. So the advice was I didn't change the position. My first case, I continued without taking out the balloon. So if you take out the balloon, slightly rotate and different part of the balloon, if it touches, might be the
Move back by 2-3 millimeters, that's good enough.
And then, that was my first case, the balloon got ruptured. That was the old balloon. Second thing, the initial days, they advised the preparation 60-40. Now you told it 50-50. So it's a change in the guideline or?
Just changing the guideline. This is the latest recommendation. Just right. Thank you.
There are no further questions. We'll.
Thank you,
It
sir.
was a very wonderful session.
Thank you.
Thank you very much. We'll conclude now.
Thank you, sir. Thank you to the esteemed chairpersons. We have Dr. Mark Silvestri waiting for us. He's been waiting for a very long time. Next session on LMCA. Chairpersons, may I please invite Dr. Anil Kumar, Dr. Rajiv C., and Dr. Baiju and Dr. Sibi Isaac also, please. Thank you so much, Dr. Silvestri, for waiting for us. You'll be on in a couple of seconds. May I hand over the proceedings now to the chairpersons, please? Over to you, sir.
Good evening. Good evening, Dr. Mark. It's been a very patient 2 hours you have been attending our sessions. Dr. Mark was supposed to be here in person. When I was going through his biodata and I realized In 1984, he has done his MD thesis in primary angioplasty and acute myocardial infarction when nobody has it still started thinking about it. And for 20 years, you have been doing left main angioplasties. The first person to publish on left main angioplasties. So he's the right person to talk to us in this CHIP Summit 2023 on left main, the practical approach to left main bifurcation and even trifurcation. Dr. Mark Silvestri, to you.
Thank you very much. Can you hear me clearly?
We can hear you very clear.
Thank you very much again for this organizers committee to invite me, and special thanks to Dr. Varma, my friend. Sorry not to be there in person, but nowadays it's more complex to get a visa than to do a left main bifurcation because of the bureaucracy. Sorry for that. Can I have the first slide, please? As you know, left main bifurcation was in the domain of the surgeon for a long time, right, in majority of the cases. Next slide, please. You know that, however, today the PCI with drug-eluting stent is considered, even if surgery is still a level of recommendation 1A, PCI is a valuable option for left main treatment, particularly distal left main. However, I want to mention this sentence just below the guidelines that if we really want to attempt a left main, and particularly a distal left main, and this is what I used to say for a long time, the result must be as perfect as possible. So we must use adequate tools to guide the stent implantation and deployment, because it is the only way to avoid the major complication, which is stent thrombosis, which is, you will understand, dramatic for the patient. And so there are many abnormalities after PCI on the left main. You can see in this trial that among 46 left main angioplasty analyzed by anatomopathology, unfortunately, we can find 50% of abnormalities, whether it is malapposition, clots, stent struts covering the ostial side branch, uncovered stent, even stent infection, bacterial infection. So the result must be perfect from the beginning when you decide to go for a distal left main PCI. Next, please. So if I had to give you one advice, of course, it will be to be very simple, as we used to do it in Europe from the beginning. So the distal left main angioplasty could be resumed by this slide with a very simple wiring of the LAD and the circ. Then to prepare the distal left main lesion, of course, to stent across, then to do a port, a proximal port, and we can stop there, or exchange a wire, dilate the side branch and report, and that's it. This is probably the most common way to do a distal left main and the more simple way. So you have to keep this in mind and try. I speak for the young cardiologists, the one who start the left main program. I think you can keep this simple way of doing distal left main, and then we will go a little bit further with the next slide. Next, please. Once you have done this crossover stenting, then of course the problem, you must focus on the side branch, which is most of the time the circumflex, but it can also be the proximal LAD in case of left dominant system. But most of the time you have to focus on the circ, whether there is a significant residual stenosis, more than 30%, MLD less than 2 millimeter, or if you use the physiology, FFR or IFR less than 0.8 or less than 0.9, which means that there is a significant lesion residual. So in this case, of course, you have to skip to a second step and do implant a second balloon with final kissing balloon or report. It depends of your beliefs, but in this case, of course, a second stent. But most of the time, we can say that we can achieve a good result with the stent crossover. Next. As I said, we usually follow the advice of the famous Leonardo da Vinci that simplicity is the ultimate sophistication. And it's probably true for left main bifurcation PCI but it's not always true, unfortunately, because we all know that we have a very complex distal left main sometimes to tackle. And so let's be simple, but not simplistic. That's the message I want also to give. And we are going to see, next slide, how to do more complex. And in its case, of course, even if I am from the generation of angio findings, I think imaging probably help us to tackle very complex distal left main, because imaging help us to assess the severity of the lesion, the degree of calcification, to size the vessel, to see where is the landing zone proximally and distally. Once you have done your final kissing balloon, you can also know by OCT if the stent is properly deployed or not, if you need a second stent in the second branch, and or if you have to add another post-dilatation or so on. So next slide. I believe imaging, of course, is not mandatory nowadays, but it's very useful. And also the physiology can help us at the beginning to assess the severity of the lesion, and at the end of the procedure to know if the side branch is compromised or not. Next slide, please. About the difference between IVUS and OCT, we all know that IVUS has a better penetration to media, so to analyze the calcification, it's probably one of the best tools. We know that we have now 2A, B level of recommendation to use IVUS and OCT as well. OCT has a higher resolution and surface detail, but of course we know that we cannot analyze the ostium of the left main. Next. We also know that a lot of trials, but it's mainly registry, but they show consistent benefits for IVUS to guide our left main PCI in terms of mortality. Next. But also in terms of target lesion failure and mortality. And you can see this recent meta-analysis, including the last trial, Renovate complex PCI, which is a subset of left main. We show definitely that the use of imaging, whether it is IVUS or OCT, provide a better target lesion failure. Next. There is not that much trial comparing by randomized trial the IVUS and OCT and angio. I will mention the ROC2 study, which showed definitely also a benefit by using imaging. There is no really difference statistically speaking, but there is a trend numerically to show that the IVUS definitely help us and provide a better TLF. Next. So nowadays, we can say that we are allowed to do left main and distal left main by angiography guidance, because we have only 2A recommendation with IVUS and with OCT. But of course, we have to select the case where the imaging will help us the most. Next. So why, next please, why do we not perform imaging in a lot of centers all over the world? Unfortunately, the catheters are very expensive, so there is a cost consideration. The patient sometimes can be unstable. Some cardiologists say that, you know, they know how to fix this left main without imaging. Sometimes some of them do not know how to deal with the imaging. So we don't know exactly, so we need randomized trial dedicated to the left main. So we are waiting for the optimal and the doctor's left main, which is a randomized comparison conducted in France by Dr. Meneveau. He will probably present the result in the next PCR in May next year regarding the comparison between OCT and angio findings for left main and distal left main. So if I have a message to give to the fellows and to the young cardiologists in the audience, if you want really to start with the left main program, you can do it with angio findings, of course, but we have to remember the lessons from IVUS and OCT when you use angiography alone. And I think IVUS and OCT are strongly recommended during the learning curve, of course, in complex cases, in angiographic ambiguities, and of course, if you have a stenting failure. So this is a case I did a couple of days ago, angiographically, with the angiographic guidance, only with the experience where you can do a complex distal left main. Oh, just by the experience, by the Finellos, by the MLD, by using the size of the catheter, I think this LED was 4 millimeter by the size of the 5 French guiding catheter. I thought the circumflex was around 3.5. So if you do the Finellos, you have a left main which is around 5.5. And this is what the MLD gave to me, 4.74 plus or less 0.50. So what we did next slide, is just to stent crossover. We use in this case an Indian stent. You know, it was a supraflex cruise, 4 millimeter by using the size of the distal vessel. And then we do a proximal port with this technique of proximal pot puff. That means it was a small trial conducted in France when you inject some contrast against the balloon. If the balloon is really at the right size of the left main or any bifurcation, there is no contrast distally. And there is a correlation with the OCT findings. So that means if you do this simple technique, you can be very close to the right side of the left main without using imaging. This is a little trick that we use sometimes. Then, of course, we cross the distal cell. And then in its case, we had a dissection, a severe dissection of the proximal circ. So we have to move to a two-stent strategy. So in this case, regarding the angulation, which was quite favorable for a T or a TAP, we use a small 3-0 stent proximally just with a T technique. Then we finish by a kissing balloon, of course, and then a report with a 5 millimeter short non-compliant balloon just proximal to the side branch. Next. And this is the final result. You can see which is optimal. We checked by the stent V's or the stent boost. We didn't use OCT or IVUS, but we thought that we had a TIMI3, we have a satisfactory result. So this is I would say, the old way to do a distal left main. Of course, you have to know the stent's expansion capacity that have been mentioned previously. In this case, we use SNT supraflex cruise 4.0. We can be expanded at 5.5, but I think everybody must have this table in the cath lab to know the capacity of expansion of each stent that you use. Majority of stent can rise 5.5, even 6 millimeter, but you have to know your stent before deciding to go for a distal left main. Next. So what is to come back to the practical approach, when do we use only provisional stenting? When you have, of course, a small circumflex or no disease on the circ with the Medina 100-110. If the lesion in ostial daughter vessel, circumflex mainly, is, let's say, less than 10 millimeters, some operators used to say 5, but it can rise to 10 millimeter depending on the trials published. When you have a wide angulation between LAD or circ, or when there is, if you use imaging, when there is no significant ostial disease by IVUS with an MLA more than 4 square millimeter, no calcified nodule, no layered plaque. We move to a two-stent technique if we have, of course, all those details of the parameter that I said. Of course, we have a long lesion in the ostial circ. If the angulation is not favorable for a T or a TAP, if the lesion on the circ is very complex or calcified, or if, of course, by IVUS, the lesion is also significantly tight. Next. So which technique? I have no time to go in detail, and all the technique has been discussed previously. To summarize, if you start even with the provisional technique, you can use all those techniques after that. But if you start with the idea to implant two stents, you have to evaluate the risk of side branch occlusion and the risk of the access of the side branch occlusion. So when you have a low risk, of course, you can do a provisional and then you can move to a TAP or a culotte as Dr. Verma described previously, or as I did for the previous case with a T or a tap. It is most of the time easy if you have evaluate your angulation and your access to the branch carefully before. When you have a very complex circ or daughter vessel in general in the left main, when you have a high risk, high branch occlusion, of course, the discussion is around the decay crush and inverted provisional, either the inverted teeth, inverted tap, or inverted culotte. So you must know your technique. You must have the knowledge of each technique and decide, of course, after provisional stenting or from the beginning if you decide for a two-stent technique. Next slide. One word about the report, which came from our French colleague also, Dr. Finet and Dr. Derimé, has been published a couple of years ago. It is very important, as it was shown in the bench, to do the report proximal and not crossover. If you see in this bench that if you put the balloon across after stenting for the report, you will have a lot of metal in front of the carina, in front of the ostium, and it will shorten, and you will have a ostium of the circ, which will be much smaller. Whereas when you use a proximal port, you will have your ostium, which will be covered by the metal, and you will not have so much metal in front of the carina, in front of the ostium. So it will be easier in the future to come back to this vessel if needed, and the ostium will be covered by the metal. Next. I cannot speak about left main bifurcation without mentioning, of course, the debate between the technique of decay crush and mention this Chinese trial, which has been published in 2019. And with this trial, the guideline has been modified, and we are now pushed to use this technique. But we believe in Europe, next slide, that is not true. It's not true because, next slide, please, because we had recently, and I personally participate to this EBC main trial, next slide, which randomized the one provisional stenting to the two-stent technique in the left main with, you can see 61% of angiography guidance versus 39 in OCT. It was a multi-center randomized trial. Next slide. And you can see that at 3 years, we didn't find the same result than the decay crush trial. Of course, this is not the same patient. In the first trial, we have mainly Asiatic patient, and we have a European patient. The lesion was much longer in the provisional stenting technique in the decay crush. So it's difficult to compare, but in our experience, we can achieve a very good result at 3 years, and it's not necessary to decide the number of stents before you start. Whether you use IVUS or not IVUS or RCT, you can see that in this trial, after 3 years, there is no difference in primary endpoint with IVUS OCT versus angiography alone. So the debate is still open. Next. A few words about trifurcation, because you know that it's 10 to 15% of all the left main. It's usually a very complex situation. There is limited evidence comparing clinical outcome of PCI in patients with bifurcation versus trifurcation, but the anatomical complexity, of course, and stenting strategy may affect the occurrence of MACE. Next. There are a few studies published, and you can see that the number of patients is very low most of the time, and the MACE rate and the TLR is much higher, of course, because the trifurcation usually provide a higher risk of target lesion failure and restenosis in one of the branch. Next. We have also this Medistra left main registry, which show that when you have a technique with 3 stents, it's only a small study with only 20 patients in 3-stent technique, but you can see that the Kaplan-Meier survival free is very poor comparing to the simple technique of 1 stent. Next. Which technique? First, we have to mention what is a true bifurcation. The true bifurcation, true trifurcation, sorry. The true trifurcation, it's only this case, 1111, 1011, or 0111 Medina classification. The others are not really true trifurcation. Next. Before attempting a trifurcation, of course, you have to evaluate the clinical risk, the patient itself, of course, the ejection fraction, the comorbidities, the bleeding risk, the right coronary artery status, all the angiographic patterns, the lesion morphology, maybe more than for bifurcation, and to evaluate the risk of side branch occlusion, the peri-procedural infarction, stent thrombosis, and restenosis. Next. The technique is, of course, a little bit more tricky. I think it's better to be very comfortable and to use a 7 or even an 8 French guiding catheter to wire all branches to prepare the lesion. It's very important to prepare with an adequate balloon, or why not with debulking or lithotripsy if needed, but the lesion must be really prepared because most of the time it's much more tricky to reach the lesion. Then, of course, the imaging can be very helpful in this case to assess the type of lesion. If the ejection fraction is poor, of course, you can have the help of EIBP. And depending on the lesion anatomy, of course, I'm not going to go into details. All the technique can be used. Try to start with a single stent if possible, then double and triple stent is also possible, but the lesser stent it is, the better. So pre-dilate, and of course, as I said, all the bifurcation technique can be used, but we have to double the standard bifurcation stenting, which is much more complex. And sometimes you have to innovate, of course, always finished by a kissing balloon. Sometimes it's double or twisting balloon. So it's much more tricky. So in conclusion, for the trifurcation, of course, all the bifurcation technique can be used. It's more complex. The syntax score must be evaluated. Of course, most of the time when you have trifurcation, you have a lot of additional lesion on the rest of the coronary tree. So next. So I think we should not forget the option of CABG. Sometimes, personally, I am very fond of distal left main PCI, and experienced operator must also think to the bypass when you have a complex calcified trifurcation. Next and last slide. So to summarize, I will say that the extent of ostial LAD and LSEG determines the need for crossover stenting or bifurcation stenting. So you must decide from the angiography what will be your option. It's a case-to-case selection, like the majority of angioplasty. The functional assessment and imaging, I think, is very useful, but experience also is probably important. We have some trials, particularly a Chinese trial showing that, and an English trial showing that below 16 cases of left main and distal left main per year, the rate of complication is much higher. And so there is an operator-dependent rate of complication. So this is very important to bring your patient, if you're not experienced for distal left main, to bring your patient or to do the cases with a senior operator and to learn progressively. Of course, for both branches disease, stent technique will depend on individual anatomy. We must use, of course, the best-in-class DES to know your stent, to know the stent expansion capacity, of course, to know the bifurcation technique, and as I said, the operator skill are essential. It is important, I think, to learn one or two techniques and to know them perfectly. For example, we don't use DK crush. Majority of the centers in France do not use DK crush because first, we don't believe, and second, we are not very skilled for that. So it's better to use a technique that you know very well. And the proper way, of course, to perform distal left main is still a debate, and we will need probably a long-term follow-up trial one day. Thank you very much.
Thank you, Dr. Silvestri, for that excellent talk. I have one question to you. Generally, it's the circumflex ostium which is causing a problem after this left main bifurcation. So, what are your suggestions on preventing a problem with the the circumflex ostium after left main angioplasty?
You mean preventing complication after
Not
wiring?
complication, not long term. I mean, it comes with the restenosis. Many times the circumflex ostium comes back with the restenosis. What are your suggestions on tips on ways and means of reducing that problem?
It's true that this is the weakness of the technique for a long time. Remember with Thierry Lefebvre at the beginning, we showed that the ostium of the left vein and the ostium of the circ were the places where we had the higher rate of restenosis. Once again, it's very important to have a tailor-made procedure. I mean, you have to focus on the circumflex ostium once you have done the left main crossover. As I said on one slide, if there is no significant lesion, we know that most of the time the lesion on the circ will remain asymptomatic for the patient without ischemia. If we have a dissection or if you have a TIMI 2 or TIMI 1, of course, you need a second stent. To prevent that, I think just a side dilatation with low pressure is sufficient most of the time, or even just a proximal pod will open the struts of the side branch, and the injury will be less. So what I'm doing personally, I'm not very aggressive. When there is no disease, no significant and long disease on the circ, I'm not very aggressive. And sometimes I don't even dilate the side branch very aggressively and just open the struts just to be able to come back one day, maybe, depends on the age of the patient. If you have a patient of 85 years old with a distal left main, you just stand crossover and leave the circ like this, because the life expectancy is what we all know all over the world, and it doesn't matter if there is a 30% on the ostium of the circ. If you have a patient of 50 years old, there's another story. Then you can maybe open the struts of the stent gently, not to have dissection. But once again, I'm not very aggressive, and this is probably one of the technique to avoid restenosis. If you have to put two stents, once again, we know that the final NSA is a predictive factor of restenosis. So optimization is very important, and preparation is also very important. So the more larger is the final result, the less is restenosis. So once again, a perfect tailor-made procedure is mandatory, either on the left main itself, but also on the proximal circ.
Thank you.
What is the size of the balloon and the pressures you use to open the struts?
We use the size of the balloon of the size of the size of the circ. You mean for the daughter vessel?
To open the struts to the circumflex, do you undersize the balloon or?
No, we just open the struts. It depends on the stent, because this is why also it's important to know, I didn't mention, but you have to know the size, the diameter of the cells of the stent you use. So some stents have larger cell, depends on stent. So most of the time I use the size, the balloon size of the side branch, but I do not dilate at very high pressure, just at the nominal size, just to open the struts gently.
Any advantage of using balloon assisted technique, that is keeping an partially inflated balloon in the circumflex ostium and deploying the stent to prevent the carinal shift, or so any advantage of using balloon assisted technique?
Yeah, this can be useful. There is we have not very large data, but it's a trick, and that you can use. Yeah, definitely.
Dr. Mark, you have shown that we should try to keep it simple, but know all the techniques required to get the optimal result. And you have told us that even in 2023, without imaging, you may get away, but ideal to do imaging for left main. And finally, if it's a trifurcation, rather than have a Trishul stent in your left main, it might be better to undergo CABG. Would you say that for a trifurcation?
Well, it depends. Once again, it depends of many parameters. The patient itself, the age, of course, the country, because I know that in India, surgery is very cheap, and comparing to the cost of 1, 2, 3 stents, especially for diabetic patients. If you have a total arterial revascularization versus a very complex technique, calcified, very costly technique, yes, maybe it depends. Once again, it's why I said it's a case-to-case selection depending of and even myself, I personally send some patients every year to the surgeon, not a lot, but I send a few patients to the surgeon, and it's mainly for trifurcation, heavily calcified lesions. This is why I was very interested with the previous presentation with IVL in the left main, because if it can help us to achieve a perfect result, because I remember in the old times, of course, it was with BMS, but the resonance rate was close to 30%. And I'm scared that in the trifurcation, the resonance rate is probably very close to this rate, unfortunately.
Dr. Werner? Yeah, I'm Gerald Werner from Darmstadt, Germany. You mentioned that IVUS, there are some limitations to use IVUS, and you put a list, and certainly financial reasons are some of them. But for someone who has written the first paper on IVUS in 1991, myself, after more than 30 years, I will still do every left main with IVUS, because even if it's 0.5 millimeter difference of post-dilatation, I think if we compete with surgery, as you mentioned, we must have a perfect result. My angiographic eyes, still today, after 30 years of IVUS, are not as good. So I would think it's not for the fellows. In my lab, IVUS is mandatory. 600 euros for the probe, it shouldn't be too much. Okay.
I know, but how do you manage to get the IVUS in your catalog? Who pays the imaging?
Well, that's of course the task of us interventionists, that we give good data to the authorities. So in Germany, if you use 1 or 2 stents plus IVUS, you almost get the IVUS reimbursed. I know in France, crazily enough, I think FFR has been no longer sanctioned.
Yeah.
How can that happen? So it's the task of the French interventionists to talk reason into the governments. So in Germany, at least, IVUS is not getting much money, but it is a flat reimbursement.
I think this is why we're waiting for a randomized trial, because with this data, I hope it will provide a result that show that imaging provide better result for the patients. So with the result of those trials, we will be able to go to the government and show them that it is useful and it has to be reimbursed. That's the only way to prove to this bureaucracy. You know, it's like my visa. I just wanted to come to India for a conference and just give a talk, but it was refused for, reason that it's difficult to understand, because when you speak to a bureaucrat, either for medical reasons or for many things, they don't speak the same language than us.
True, we did try to push a visa from here. Sorry, we were unsuccessful. Anyway, thank you, Dr. Mark, for spending this much time, and we all enjoyed. Thank you very much. Thank you.
Thank you.
We'll close this session. Thank you.
Thank you, Dr. Silvestri, and thank you to the chairpersons of this session. Move on quickly to the next session. May I please invite Dr. Anil Balachandran, Dr. Prabhadini Gupta, Dr. Sunil Shivadas, and Dr. Praveen, please, to chair the session. For the kind attention of the chairpersons, we are running a bit late, and request you to kindly intervene if the time overshoots. This is the session on access and hemodynamics. May I hand over the proceedings to the chairpersons now?
Very good evening. We are moving into a session of access and hemodynamics. We all know that after a properly conducted and well completed coronary intervention, an access site complication will always be a headache for the treating physician. So vascular access and closure techniques, especially in the background of increased number of TAVR procedures, gains importance in this context. We will straight go to the session. The first session is on vascular access and closure devices by Dr. Sanjog Kalra. Over to you, Dr. Kalra.
Good afternoon. My name is Sanjog Kalra. I'm an interventional cardiologist at the Peterman Cardiac Center, Toronto General Hospital. Thank you very much for the opportunity to speak to you today at this year's CHIP Summit in Kochi. I'm sorry I couldn't be with you in person today. My first talk is entitled Vascular Access and Closure Techniques. This is a general overview of how to do good large bore access, because we all know that often this is where the battle is won and lost. These are my disclosures. To do good femoral vascular access, you need practice. And the idea is to do it the same way every time so that you become very proficient at the individual steps. Good access begins with the use of ultrasound guidance. Recent evidence shows that this is all benefit, no risk to our patients, where ultrasound guidance, once the learning curve has been surmounted, is an excellent way to define the optimal place within a vessel to access. The use of a micropuncture kit has also become gold standard, because ultimately sometimes we miss. And the tax with the use of a micropuncture kit, if we puncture the artery and then have to repuncture because we're not happy with the place we're in, is very low given the tiny size of the needle. Once we've got access, we perform an ipsilateral femoral angiogram like you see here to ensure three things. One, we're in a large segment of the vessel that's disease-free. Two, we're above the bifurcation. So we're above the bifurcation of the common femoral artery and our stick is in the common femoral artery itself. And three, that the vessel that we're in is large, because ultimately the smaller the vessel, the higher the risk of vascular complications. In general, once placing a sheath, generally speaking, I start with a 5 or a 6 French. I'll take a 5 French pigtail and put it at the aortic bifurcation and do a femoral angiogram. This can be done with relatively small amounts of contrast, 10, maybe 15 cc's at most. And what you're looking for are the largest vessels that you can access and those with the least tortuosity, because ultimately both of those things are what drive vascular complications. And in addition, sometimes it's useful to take a peripheral runoff angiogram within the leg that you've chosen to ensure that there's no distal disease and that you don't need to put a distal perfusion cannula, which we recognize is much easier to place before you put in the large bore access, because then you have flow into the distal vessels that can allow you to access those vessels easily. Once you've done your femoral access angiogram, you also want to make sure that your bifurcations on both sides of the femorals are in fact not high, because even if you access the CFA, if your bifurcation is quite high near the pelvic brim, that's a high risk access because it may bleed underneath the access after you've dilated it. And in that case, you're going to want to move over to the other side. Generally speaking, we also want to look at the iliac anatomy to ensure there are no major points of disease and that the bifurcation itself is not severely angulated on the side you've chosen for large bore access, because severe angulations can cause pseudostenoses and end up with ischemia in the legs. In those patients where you really can't use a ton of contrast, you can actually use IVUS to do this as well. The way you do that is by using your ultrasound guided micropuncture access on one of the sides, usually the side that you don't anticipate using for your large bore access. Take a Lima guide catheter or diagnostic catheter or some other peripheral catheter and place a wire across the aortic bifurcation and down the contralateral leg. Ideally speaking, this wire will go down the SFA. And then with that wire in place, you can use your ultrasound and you can identify the wire, and then you can place an IVUS catheter along that wire. And once you've done so, you'll be able to see where your micropuncture wire has actually accessed the vessel. You can prove where the wire enters the vessel that you've actually accessed within the CFA. That's just another check to ensure that the vessel that you've accessed is disease-free, and that as you pull back your IVUS back up the contralateral CFA, up the common iliac, and into the aortic bifurcation, that there are no large segments of disease that are going to get into your way. That's one way you can do this without doing an aortic shock. Once you've done this, it comes down to pre-closure. This is particularly important for large bore access. Generally speaking, I'll do pre-closure in patients where I'm going to do accesses over 10 French. The way this is done is by placing a J wire through your 6 French sheath. And it's important to do this on a 6 French backbone so that the actual arteriotomy into which the perclose sutures deploy is still small. So you have lots of tissue to evert when the percloses close the access. You put the perclose in and you do 2 sets of percloses, one that is oriented to 10 and about 7 o'clock, two and about 7 o'clock, and the other one that's oriented at 10 o'clock and about 4 o'clock. And that way you have almost an X of sutures that are being used to pre-close the artery that you will be able to tamp down and close your arteriotomy with once you're done with your large bore access. These can actually be wrapped up in various ways and actually used for delayed closure as well, in case you need to use your large bore access for a longer period than just your procedure. This has been reasonably well described. This was described back in 2018 by some friends of mine. And what they did was placed each per-closed suture in its own snap, wrapped that up in a betadine impregnated towel and taped it to the skin. More recently, we're doing things that are a little bit cleaner and a little bit smaller, where you can use tourniquets. These are the little tubes that our surgical colleagues use to suspend their pericardial sutures in the operating room. These tubes can be used on the per-closed sutures to fasten them and keep them clean so that when you are ready to close, you can simply take the sutures out of the tubes, clean them off, and tap the knots down. It is important to remember to figure out which per-closed suture is that you put in first, because that is the order in which you'll tamp down the knots when you're coming back for delayed closure. So this is if you're doing closure, say, not at the same time as the procedure, but several days afterwards, where you need to send the patient to the ICU in the middle. Once you access the vessel, so once you've pre-closed and you've put a wire back into the artery, how do you dilate to make sure that you don't tear the artery? The most important piece of advice I can give you is use a stiff wire. Use something that has a good, strong backbone, because the more the wire bends, the more the arteriotomy goes from circular to oval, and as a result, the more likely you are to bleed behind whatever sheath you put in. The other important piece is to make sure that your access angle is not overly steep, because when you access very, very steeply, there's always an oblong nature to the arteriotomy and bleeding behind it. So what you'll do is place a stiffer wire like a Supracore or a Lunderquist or an Emplatz. This is particularly important in obese patients. You place it into the descending aorta or even up into the ascending aorta at the level of the aortic root. That's where I usually keep my wires when I'm doing this, because it gives you lots of freedom to move back and forth on the wire without knowing you'll lose your, without being worried that you'll lose your access. Then you sequentially dilate the arteriotomy. The pro hack is, before you start this step, make sure you therapeutically heparinize the patient, because once you put in a big sheath or a big cannula, the patient has to be heparinized, and you don't want to sit there waiting for the ACT to come to something over 250, which is what's necessary to make sure you don't create clot in the dead space of a large sheath. You sequentially dilate using provided dilators, and then gently and carefully turn the sheath into the arteriotomy as you advance it into the vessel. One way of making sure that you don't catch small vessels when delivering your very rigid wire is to use a diagnostic JR4 up into the descending aorta through which you can deliver your stiff wire. That way you avoid any issues with trying to wire a very tortuous aorta that may be stiff and calcified. And remember, it is important to perform that ipsilateral angiogram if you're not doing the IBIS guided access technique to ensure you know exactly what the runoff is before you end up securing your sheath. Remember, as far as artery sizes go, bigger is better. So the larger your femoral artery, the less likely you are to have femoral complications. What we know is that in arteries less than 5.5 millimeters in diameter, the risk of femoral artery complication goes up significantly. And as a result, it's really important to select the larger of the two arteries and to know the size of the sheath you're putting in, where with an Impella 2.5, for example, the sheath size is 13 French, and with an Impella CP, it's 14 French. Now it's time to remove the sheath. How do you close and make sure that you don't have a bleed? Well, your traditional closure, which is with your pre-closed sutures in place, is you explant the device per normal protocol. And generally speaking, what I will do is use the side port of the sheath to put a J-wire up through my arteriotomy so that I have control of that access site. Get a second person, have them come over to the same side as you are, and tell them to feel the sheath underneath the skin so they understand exactly where they're going to need to provide pressure. Then, as you explant the device, ask them to provide firm but not huge pressure, because what you want to do is keep your field clean but not make the patient bear down. Once the patient bears down, it becomes even more difficult to close the arteriotomy. As you remove the peel away sheath, you have to slide it back completely out of the common femoral artery before you peel it away. Never crack it within the femoral artery because it will bleed profusely and you can actually injure the artery. Once you have control of the arteriotomy and you have some pressure from your assistant, you take your per-close sutures in the same order that you put them in and you tamp them down to the wire. One all the way down to the wire and then you clip it, and then you take the other, tamp it all the way down to the wire, and then you clip it. And then stop. Allow them to slowly release pressure. And what you should see is reasonable hemostasis, certainly not significant bleeding. It is normal to have a small track ooze because, again, you still have a J-wire in place. If you're satisfied with your hemostasis, you can remove your J-wire and then in the same order, first one first, then the second one, tamp the knots all the way down to the arteriotomy on both sides and cut the sutures. It is not unusual to have to place a few moments of manual pressure at this point. That's a successful closure. One of the other things that I do after every single closure is check the pulse in the foot after the closure is done, because the last thing you want to do is leave the cath lab with a closed common femoral artery. If you're not happy with the hemostasis that you have after you've tamped the sutures down to the wire, keep the wire in place. This is not concerning. Allow the person to put additional pressure, and then you have two choices. You can either put a third per-close in a perpendicular deployment pattern to the other two, or you can use an angioseal on top of that wire. The downside of the angioseal is that it leaves something behind, and you will lose your wire access, but it is a very secure closure. So there's no reason you can't combine these closure technologies. Another alternative is called the dry closure, where you get contralateral access, you go up and over once again, and you place a balloon in the common iliac artery or at the tip of the common femoral. With that balloon up, you're going to end up occluding flow down that contralateral leg where you're trying to close. And what you should see is this. You can hook up your pressure transducer to the balloon that you've put up, and you should see that there should be a total dampening of pressure down that artery. Once you've got that in place, you're in a very secure place where you don't need the second person to put pressure. Instead, you can gently, carefully place your per-close sutures down and ensure that you have good closure. Once you've become satisfied with your closure or with the position of the knots, you can take the balloon down and allow there to be flow down the artery. And what you should see is very minimal ooze or no ooze through your arteriotomy site. The beauty of this dry closure technique, which is now being mandated in some of the large bore access trials that involve the Impella device, is that you can actually inject through your peripheral balloon and do a femoral angiogram and prove that, in fact, you have really nice closure. And that's what this looks like, where here's the balloon, and what you've done now after a closure is done an angiogram through the balloon so that you've proven that you've got nice, good, healthy closure and that there's no leakage into the skin or worse, into the retroperitoneal space. Once again, if the per-close sutures fail, the nice thing about the dry closure approach is that you have something where you can do balloon tamponade fairly quickly. So you simply advance your balloon and you put up that balloon at low pressures, okay? 4 or 5 atmospheres, maybe 6, depending on the size of balloon that you've chosen. Generally, if you've chosen a balloon for the iliac artery, it's going to be big for the common femoral, so keep your pressures very low and simply hold your balloon up and let it create some balloon tamponade at that site. More often than not, because the heparin will have dwindled off by the time you're doing this closure, you're going to find that you have a very nice, healthy closure just with balloon tamponade. In the rare scenario where you need to consider vascular rescue by deploying a covered stent, you can use a Viabon or alternative stent, and that's just all about knowing that only certain Viabon stents will go through an 8 French sheath, and you need to remember your Viabon stent sizes and your accesses. So this is what it looks like when you've got a perforation and then a closure with a Viabon stent, recognizing that you need to make sure you deploy the Viabon above the bifurcation of the femoral so that you're not closing off your profunda. So in summary, that dry closure step-by-step is you get contralateral access, you put a 6 or 7 French crossover sheath in, you advance an 8 millimeter or so balloon into the common iliac, matching 1-to-1 to the external iliac size, and you inflate the balloon until the waveform dampens when you hook up the pressure transducers through the end of the balloon. You explant your large bore access sheath, you tie down your per-close sutures, and then you deflate the balloon and observe whether or not there's any bleeding. If there's no bleeding, then you take a femoral angiogram through the balloon and prove that you have good closure. There are a number of other options as well, hybrid closure techniques, post-closure techniques that we talked about, dry field closures, et cetera, that may go beyond the scope of this lecture, but certainly things that we can talk about down the line. Briefly, if you have an occlusive sheath, here's what you do. The bottom line goal is to get blood to the distal vessel and obfuscate the inflammatory response. So remove your peel away sheath and put in the repositioning sheath. That's one solution. The second solution is an external ipsilateral bypass. The third solution is an internal contralateral bypass. And the fourth is an external contralateral bypass. And I'll show you all three of those quickly. Obviously, we know about removing the peel away sheath because that's much larger. Whereas in the case of the Impella CP, the repositioning sheath tapers from 13 French to 9 French. And that will remove the amount of challenge associated with blood flow down the leg. If you need to do an external ipsilateral bypass, here's how you do it. You do an antegrade puncture into the ipsilateral superficial femoral artery, and you place a 5 French or even 6 French sheath and simply collect using a male-to-male connector the sidearm of your contralateral 6 French sheath to the sidearm of your large bore sheath. And if you suspect occlusion based on the vessel size, put in the distal perfusion cannula prior to the large bore sheath insertion. So here's what that looks like. You do your downward micropuncture access distal to the sheath into the ipsilateral SFA. Okay, there's your access. Then you place your wire down the SFA, which is what you see here, right? Pull the wire back a little ways out of that small branch. Down it goes down the SFA. Okay, so that now you have a secure sheath. Now, on the contralateral side, you place a 6 French sheath, or on the ipsilateral side, you have your large bore access, and you simply hook up your sidearm of your large bore access sheath to your antegrade puncture sheath, and you have flow this way, down the leg. If you need to do an external contralateral bypass, it's essentially the same technique. The only difference is you put your other sheath in the contralateral side. So if your large bore access is in the left side, you put a left-sided SFA sheath, antegrade, and then you put your standard retrograde sheath into the right-sided CFA, and you simply hook up using a male-to-male connector from the right side to the left. And then rarely, when you have an occlusion of the ipsilateral SFA, generally speaking, there are collaterals from the profunda into the distribution in the distal leg. And so what you can instead do is an internal contralateral bypass, where what you will do is go from your contralateral side and place a 7 French sheath. Through this, you'll wire up and over the aorta, past your large bore access sheath, and into your ipsilateral profunda femoris. So that's how this is done, right? Where you go up and over, you go along the side of the large bore sheath, and you place a wire into the profunda. And then along this, you take a 45 centimeter 4 French sheath along that wire, and you place it into the profunda. And then you connect the sidearm of your contralateral retrograde sheath. So if your large bore access is on the left, your contralateral 7 French sheath that you have retrograde in the right, to the long 4 French sheath that's going through that same sheath, up and over and down the other side into the profunda. That will allow you to access the profunda femoris on the same size as the large bore access and be able to give the leg flow. And that's how this works. And this is how it looks in practice, where this is the tip of your femoral sheath, and this is the angiogram going down the profunda with the collaterals coming over to the other side of the leg. This is also well published and described in a paper by Amir Kaki and colleagues that describes the variety of these approaches and procedures. So the use of large bore access sheaths will continue to increase as we use more mechanical support devices, as we use ECMO, as we do more structural interventions. And so it's very important to have a very strong approach to how to deal with these types of challenges. Removal of large bore access sheaths in the cath lab is highly recommended, particularly when you're worried about the patient and whether or not you have a secure pathway to good closure. And with radial access becoming more frequent, you can even use radial access and long catheters to be able to deliver some of the balloons that we discussed to be able to occlude the iliac or the common femoral in situations where you need to do dry closure techniques. Thanks very much for your time and attention.
I think for the want of time, I think we'll go to next talk by Dr. Anil. He's going to talk about hypertension in chip.
A very good evening to you all. After some excellent and exotic lectures, mine is rather a back to basics talk on approach to hypertension during CHIP, rather any coronary intervention procedures. Imagine you are doing a rather straightforward ostial LED lesion with an awkward bend at the origin. You are wiring the lesion, suddenly the patient develops a chest discomfort. The BP comes down to 60 millimeters and the patient becomes irritable and you lose your wire access. So something like this, rather straightforward lesion, your wire misbehaves, goes subintimally and the vessel is closed off. Within no time, you are getting elevated to the status of operating a chip subset patient. And that is why hypotension is very important to be tackled for. So during these conditions, this algorithm comes to my mind. It's a very simple algorithm. You can very well see that the left and right hand side of the slide looks the same, only the order is different. The most important part is the first thing to identify, can the patient perfuse, oxygenate, and ventilate without support? If the answer is no, no time to think, act, enhance the cardiac performance, stabilize the blood pressure, rhythm, and reverse the complication, and then think of the differential diagnosis. If your patient is stable, think of the differential diagnosis, think of the reversible causes. You may be a superhero like Maxwell against Afghanistan on a given day, but not on all days. Always call your colleague and get your team on board because a teamwork always pays. These are the red flag signs when you have a hypotension in cath lab. The most important thing is always disengage the guide without losing the wire access. It is easier said than done. Always, if you are in doubt, always take a plain fluoro. You can look for the dye stain, which is suggestive of a dissection. You can even get clue about blood in the pericardium, which is suggestive of a tamponade. Even you can find about a broken wire or a dislodged stent or a broken balloon. Always think about these things like ischemia, tamponade, AV regurgitation. And mind you, contrast allergy is not that uncommon and it is easily reversible. And this is one important algorithm to hypotension in the cath lab taken from Emmanuel Brilakis. This is a very crowded slide. Let us go one by one. Always think about false hypotension. Check whether your Y connector is closed, your catheter transducer connection is okay or not, because this can give you false measurements of your blood pressure. Always relook at your angiogram. You would have missed an ostial plaque, which is causing a pressure damping. Or maybe your catheter has sucked in when you retrieved your pre-dilatation balloon. Look for any air or thrombus in the catheter, or look for any excessive equipments like a winged balloon sitting in the left main, a broken stent, or a broken wire. If the answer to everything is yes, everything is in place, think of true hypotension. This is one classical example of guide dampening, which is getting corrected when the guide is pulled back. And the guide is again sucked in during inspiration, during the next inspiration cycle. Never ever miss this true hypotension. You could see that the BP is 60 millimeters and there's a significant ST elevation with reciprocal ST depression. So when you have a hemodynamic collapse, you have a very wide checklist starting from ischemia to vasodilatory causes. I would always put a emphasis on two common causes, that is the contrast anaphylaxis as well as an exaggerated vasovagal reaction. So let us take it in a more organized way. The most important thing is hypovolemia. Whenever you think of hypovolemia, bleeding is the most important cause, especially in CHIP procedures. If you do a femoral procedure, the risk of retroperitoneal hematoma is very high. So if you suspect that, do a plain fluoro, which can give you the image of a shifted bladder, which is displaced to one side, which is suggestive of a retroperitoneal hematoma. Now coming to the second part, that is the cardiac failure part. We know that cardiac output is stroke volume into heart rate. Anything which increases or decreases the heart rate, like a tachy or bradyarrhythmias, should be corrected at the earliest. Anything which reduces the stroke volume, if it is myocardial, think of ischemia. If you want to get an idea of what is happening, you can do a small gentle puff to look for a closed off vessel. It could be a dissection. Or again, more important is always look for the most dreaded complication, that is pericardial tamponade. Pericardial tamponade, even if you don't have an echo, if you have a plain fluoro, you can very well delineate the presence of pericardial tamponade. This is a classical example of a mid-LAD perforation with tamponade. Again, if you look at the monitor, you can look for the classical sign of pulsus paradoxus in pressure tracing. Because identifying this is of paramount importance, because a simple pericardiocentesis can reverse the whole hemodynamics. Even at this age, these guys rock the box office. Likewise, in case of an emergency, two important things which is helpful to us in any cath lab are vasopressors, that's inotropes, as well as IABP. Why I told IABP is that IABP is easily available, and at least a good proportion of us are very used to using IABP. If you have the luxury of an ECMO or an Impella, definitely that is a welcome. And then treat the specific cause of hypotension. Most importantly, there's a myocardial dysfunction by myocardial revascularization and pericardial causes by pericardiocentesis. Coming to the hemodynamic support part for PCI, we know that IABP still holds a key. If you have an isolated LV failure in the pre-shock stage or severe shock stage, IABP still has a role. But if you have a biventricular failure, ECMO definitely have an advantage over IABP. And if the patient has had a cardiac arrest on table, ECMO definitely has an advantage. Whenever you think of a mechanical circulatory support, always think about the contraindications for MCS, like LV thrombus, mechanical aortic valve, severe aortic regurgitation, a VSD or an ASD. Preventing a complication is as important as treating one. So we should always know which patient is prone for a hypotension, and we should plan the procedure well in advance, as it was mentioned in many of the previous talk. It depends upon the patient characteristics like advanced age, cardiorenal dysfunction, reduced cardiac index, and the procedural characteristics like a multi-vessel PCI or PCI on the last available conduit, or a retrograde technique through the last available conduit, like using a retrograde technique via Lima to LAD in a patient to access a CT of the RCA or circumflex. These are patients who are prone for hypotension during procedure. So even a protected PCI may be of help to them. Checklists and algorithms work in cockpits, nuclear power plants, as well as in firefighters, but also in the cath lab also. You should have a pre-procedure checklist, specifically look at the hemoglobin, creatinine, get a blood grouping and cross-matching done. If you anticipate a blood loss, you should have a proper IV access, adequate hydration, a simple Foley's catheter pre-procedure, if you are anticipating a long procedure, can avoid a vasovagal-induced hypotension due to a full bladder. You should have a procedure room setup checklist also, a well set up emergency crash cart, a working defibrillator, suction and oxygen in the room. You should know what all instruments do you have. And in cath lab, echo machine is always advisable. You should have your own armamentarium of covered stents, coils, snares, and pericardial centers, etc. And most importantly, you should have your team on board for complex procedures. This is how the procedure room setup checklist should be. And most importantly, discuss the case with your team about the access site, target vessels, anticipated strategy or anticipated techniques, and what all do you anticipate regarding specific equipments during the procedure. To prevent true hypotension, radial access is always preferable. Always have a pre-procedure hydration, pre-medications for contrast allergy, a protected PCI for high-risk patient if required. and sedation and hydration for a vasovagal reaction, and avoid excessive nitroglycerins, intracoronary nitroglycerin, which is very common. So the take-home points regarding hypotension in the cath lab should be, it is important to work efficiently and systematically as a team. Teamwork pays. Have an algorithmic approach. Narrow your differential diagnosis early and in a swift manner. Support hemodynamics should be in place in time and treat the underlying cause. Let me conclude my talk on a philosophical note, just like this gentleman. Complications are bound to occur in people who do cases. After all, ships are made to sail in troubled waters. It is more important to identify complications and treat them at the right time. Thank you so much.
That was a wonderful talk. And you have summarized in a hurry what to do when there's hypotension in the cath lab. And the previous talk also showed how you can access the arteries to prevent distal ischemia. And I think both talks are totally related to each other. Because if you want to put a mechanical circulatory support in a hypotension, your vascular access should be correct. So does anyone have any questions? Okay. Anil, do you want to make any more comments? Then I think we can go over to the next talk. IABP insertion by Dr. Verma. Also related to this topic.
Good evening. Dr. Jimmy was supposed to deliver this talk, but due to unforeseen circumstances, he could not be here. So the same talk I'm going to present on behalf of Dr. Jimmy. So as you know, circulatory support systems are necessary for cardiogenic shock after ACS. It can be distinguished by the mechanism in which they support the system. They can give mechanical LV support by LV pressure unloading, as in the case of an IABP. They can support by LV volume unloading by means of an impeller. You can have mechanical biventricular support with membrane oxygenation, that is the ECMO device. These are the three common devices that we use. Coming to the IABP, there are different indications for the use. We'll come to them. Counterpulsation. What is intra-aortic balloon counterpulsation? The counterpulsation is a term that describes balloon inflation during diastole and deflation in early systole. So that is precisely the technique of the intra-aortic balloon pump. So the physiological effects of the intra-aortic balloon pump in diastole causes, when the balloon expands, there's augmentation of the diastolic pressure, there is an increase in coronary perfusion, and there is an increase in the myocardial oxygen supply. And when the balloon deflates during systole, there is a decrease in the afterload, there is a decrease in the cardiac work, and there is a decrease in the myocardial oxygen consumption, and there is an increase in the effective cardiac output. So indications in a pre-op patient, when there is an acute MI, when there are complications of acute MI like ventricular septal rupture, mitral regurgitation, cardiogenic shock, refractory ventricular arrhythmias, refractory unstable angina, refractory ventricular failure, high-risk coronary intervention of the left main when patients with severe LV dysfunction, intra-op when there is a failed PCI or a failed catheterization procedure, a high-risk CABG procedure, when there is difficulty in weaning from cardiopulmonary bypass in severe LV dysfunction, post-surgery LV systolic failure, which is unresponsive to inotropes. These are all some of the indications, and also as an indication in effective unloading when you use an impeller device or an ECMO device, where you need to effectively unload the heart. So you can use, along with the ECMO, you can use IABP to sort of vent the left ventricle. Absolute contraindications include significant aortic regurgitation, aortic dissection, aortic stents, severe aortic and peripheral vascular atherosclerotic disease. Relative contraindications include an abdominal aortic aneurysm, which you can possibly safely traverse across. Coagulopathy, again, because of the smaller size of the IABP balloons now, coagulopathy is not so much of a concern as it was in the past. When there is an LV outflow tract obstruction, again, this IABP insertion has to be done with care and monitoring has to be immaculate. Uncontrolled sepsis, again, is a relative contraindication. So what do we expect when we put an IABP? We expect the aortic, the systolic pressure to reduce, the diastolic pressure should increase. There's an increase in the mean pressure. There's a reduction in the cardiac afterload. There's a reduction in the preload. The blood flow to the coronaries improve. There's an improvement in the cardiac output. There's an improvement in the renal blood flow. The LV pressure reduces, the systolic pressure may reduce a little bit, but the end diastolic pressure also reduces. The left ventricular volume reduces. There's a decrease in the stroke work, and there is a decrease in the wall tension of the left ventricle. These are the components of the IABP. You have the console, and then you have the IABP catheter. Coming to the IABP catheter, you have the balloon at the tip with the shaft. The center of the shaft is connected to the, that is where the wire passes, and that is through that you can, once the wire is removed, you can monitor the pressure. It's connected to the pressure monitor. Around that, you have the tube, which is filled with the helium. The helium is the gas that is used. It's supplied from a tank, and there's a connector which supplies the gas to the balloon, which helps in the inflation and deflation of the balloon. There's a sizing chart of depending on the height and the body surface area. You can size the balloon. You have the different sizes of the balloon, the 25 cc, the 30 cc, 34 cc, 40 cc, and the 50 cc, depending on the size of the. So greater the balloon size, the greater is the augmentation, more blood volume displacement, more diastolic augmentation, and more systolic unloading. The IABP console, the monitor part will tell you about the ECG. It will mark the ECG trace at the top. Then you have the balloon pressure waveform, and then you have the arterial pressure tracing in the middle. So that will show us where the augmentation is happening and how the pressures are being influenced by the use of the intraabiotic balloon pump. You also have an indicator of the helium gas level. You can also know in numbers on the right side, you can know the actual systolic pressures, the actual diastolic pressures, the augmented systolic and diastolic pressures, the mean pressures, and the heart rate can also, or all these parameters are seen. The console also has the different modes which you can activate. You have the trigger source, you have the way of filling up of the balloon. You can use a button to see the inflation interval on the waveform. You can freeze and stop the display process. On the side of the console, you have the helium tank. You have the ECG cable which connects to the ECG port. You have the pressure monitoring port which is connected. You have all the power supply also. So this is the normal balloon pressure waveform. This has to be remembered because changes in this waveform will indicate problems in the working of the IABP. So there is an inflation overshoot. Following that, there is a plateau phase, and there is a deflation overshoot, and then there is the baseline, the falling pressure. So in the normal IABP blood pressure waveform, the inflation of the IABP intra-aortic balloon pump occurs. You have to time the inflation such that it occurs in diastole. It starts with the dicrotic notch on the pressure, arterial pressure waveform. Should not be early, and then it increases the diastolic pressure significantly. And then when the balloon deflates, as happens midway through, then the pressure drops down, and then you have the next systolic uptake of the arterial pressure tracing. You can use a 1:2 ratio of the balloon pump, where the balloon pump happens every alternate beat. And this will help us to time the inflation and deflation more manually also, and further titrate the inflation and deflation of the intra-aortic balloon pump. So the hemodynamic effects we have already seen, inflation, all these things we have already seen once. All these things. Yeah, IABP set comes with an introducer needle, a guide wire, vessel dilators, sheath, the IABP, which is 34 or 40 cc, commonly the gas tubing, a 60 ml syringe, and a three-way stopcock. The aortic balloon is packed like this, and the insertion steps are as follows. First, we connect the ECG, we set up the pressure lines, we access the femoral artery. We follow that by insertion of the supplied sheath, that is a 7.5 French sheath. Then we use the J-shaped guide wire and manipulate the wire under fluoroscopy till the wire reaches the level of the aortic arch. We remove the stylet, we aspirate, flush, we insert the balloon only over the guide wire. We hold the catheter very close to the skin insertion point so that there is no injury to the balloon and the vessel. The advancement has to be in very small steps of 1 to 2 centimeters at a time and stop if there's any resistance. The IABP generally should advance freely unless there are stenosis in the femoral or in the aorta. Vascular complications can happen during insertion and care should be taken to advance the balloon in a very safe manner. Any resistance, you should stop and see and assess. If there's kinking of the IABP, there's improper inflation and deflation. Positioning has to be at the just distal to the takeoff of the left subclavian artery. Console we have already seen. The triggering modes, they may be triggered by the ECG. It uses the slope of the QR segment to detect the triggering point. The arterial pressure is another way. There's an internal trigger which inflates and deflates the balloon at a fixed rate. Usually it's 80 per minute. You can, in a paced rhythm, because of the changes in the ECG configuration, you can have a paced rhythm, either a paced ventricular mode or a paced atrioventricular mode. Frequency can be set as 1:3 or 1:4 even, 1:2 and 1:1. So these are the different waveforms. I'll not go to. So suppose there's an early inflation, we can identify that by the earlier onset of the dicrotic notch. So there we need to make sure that the inflation occurs a little later. And if there's a delayed inflation, again, we have to ensure that the inflation occurs a little earlier so that optimal augmentation can happen. Again, there may be variations in the balloon pressure waveform depending on the heart rate, and it may be irregular if there's atrial fibrillation. So guidelines, what do they say? IABP insertion should be considered in patients with hemodynamic instability, cardiogenic shock. It's still a class 2A/C indication. And routine use of IABP in patients with cardiogenic shock is not recommended. That's a class 3 recommendation. Thank you very much.
That was a very interesting talk. Now, actually, I think life has come a full circle. In olden days, they said IABP is a class 3. But actually, even if you use an ECMO, you need an IABP to vent the left ventricle because an ECMO does not unload the left ventricle. So I think the use of IABP is again going up. And if any questions are there, we can ask sir to answer them. Because the randomized trial of ECMO versus IABP was not favorable to ECMO. So all mechanical circulatory supports are useful and they are needed to make patients survive.
Yeah, I think it's necessary to be very selective about the use of IABP or any other mechanical circulatory support device. Ensure that you use them upfront rather than use them after the patient has crashed. So one of the reasons for the bad name that MCS gets is because of the increased usage of MCS in futile situations. When the patient is already crashed, when there's no BP, when the chance of survival is very low, you use that as a method by which you can transfer the patient from the cath lab to the ICU, which is probably not a good advertisement for the use of MCS.
In fact, there have been data comparing prophylactic use of mechanical circulatory device in high-risk PCIs versus emergency use, and they have shown that there's an advantage for protected, the so-called protected PCI subgroup. And,
Yes.
And more importantly, whenever you use this MCS devices, vascular access site complications has also be considered.
Yeah, that's all. The first talk by Dr. Sanjog is all the more relevant in this situation. Plus, one other important thing is that when we use MCS device and you want to make a difference in terms of survival or in terms of clinical benefit, it is necessary to do as complete a functional revascularization as possible. The benefit is seen when with MCS only if there is a functionally complete revascularization, not with incomplete revascularization. So there was also a trial which showed this particular point.
Go to the next talk by on ECMO by Dr. Jobin.
Good evening to all of you. First of all, I want to thank all the organizers for giving me this opportunity. So my topic today for discussion is about ECMO. I know it's a controversial topic. Just now, so many questions I heard, sir telling about whether ECMO is beneficial, IABP is beneficial. I think my talk will give some light into it. So we will be discussing about VA ECMO mainly. So first we have to understand why VA ECMO. What is the position of VA ECMO among the spectrum of mechanical circulatory support devices? Indication for initiation, establishing ECMO in the cath lab, maintenance, monitoring, escalation, de-escalation, and complications. Of course, complications, I will take some time because complications are important to understand. A little bit of physiology, vicious cycle in cardiogenic shock. You know, any acute or chronic insult will lead to a decrease in stroke volume, which can lead to decreased tissue perfusion, acidosis, decreased contractility, which further decreases stroke volume. Oxygen demand supply mismatch, increased wall tension. I'm not going into the details of a cardiogenic shock physiology, but it is very important to understand this physiology because by a mechanical circulatory support, we are actually trying to break this cycle of events. VA ECMO is a short-term mechanical circulatory support. That is one thing we have to understand. It is only for a short period. So the indications are, it is either used as a rescue from acute low cardiac output situations, prevention of further myocardial damage, prevention of deterioration in multi-system organ function, bridge to the next step of management, or bridge to improved candidacy. So this we can understand from the physiology. The most commonly used temporary mechanical circulatory support devices are intra-aortic balloon pump, percutaneous LV assist devices. The LV support, we have the Impella, various types of Impella. RV support, we have the Impella RP or the Protect Duo. But when it comes to biventricular failure, you can either use a biventricular Impella pump or an Impella with a Protect Duo oxygenator, or more easily we can use a VA ECMO. And of course, when biventricular failure and there is a concomitant respiratory failure, VA ECMO is the only option. So VA ECMO is not comparable to any of the other mechanical devices. It is definitely superior as far as a short-term mechanical support is thought of. So in this graph, we can see that the amount of flow which can be augmented by using various short-term devices. IABP has the least value. The percutaneous devices for LV support, like the 2.5 Impella CP, the Impella 5 and 5.5, tandem heart example, etc., has a better flow. But it is VA ECMO that in any crisis situation which will help you the most, especially if you have a respiratory issue. So before going to the VA ECMO, I would like to throw light onto the SEAI shock classification. So it is very important to understand. Dr. Anil was talking about the hypotension, approach to hypotension. It is something similar. You have various stages. Stage A is a patient at risk. B is beginning of cardiogenic shock. C is classic cardiogenic shock. D is deteriorating, and E is extremities. So it is very important to identify in what stage the patient is based on a physical examination, biochemical markers, and hemodynamic parameters. So a patient A at risk is stable. His biochemical parameters are normal. His hemodynamic parameters are also normal. B is a patient has hypotension, but there is no signs of hypoperfusion. There will be decrease in systolic BP, there will be tachycardia. But when it comes to C, there is evidence of hypoperfusion and hypotension. Patient can be volume overloaded, he can be having a decreased mental status, lactate elevation can be present. And if you measure the cardiac output using a PA catheter, you can see that the cardiac index usually will be less than 2.2. Stage D is deteriorating from stage C, and in spite of ionotropes or short-term mechanical circulatory support like IABP, patient is still deteriorating. So in this context, I would like to tell that always when a patient is in stage C or beyond, it is always necessary that you have a multidisciplinary shock team. So various publications are there which will give you the evidence that the outcome is definitely better when you have a multidisciplinary shock team, comprises of cardiologist, anesthesiologist, critical care physician, perfusionist, cath lab technicians, etc., etc. And there should be a one-call activation of the team with well-integrated protocols and consensus. So it is definitely found to have an improved survival. Regarding PA catheter, there is no randomized controlled trials or evidence to prove that the use of PA catheter is beneficial or there is an improved outcome in cardiogenic shock. But in all advanced heart centers or all centers which perform complex angioplasties, the use of PA catheter is a must. So it is based on PA catheter derived variables or variables, as I show in the next slide, that we take many of the decisions. So these are some of the parameters and variables. You get the cardiac index. The advantage of PA catheter is that it is a continuous monitor. You can continuously see the cardiac output, and you can get the cardiac index, the cardiac power index, which is mean arterial pressure into cardiac output divided by 451, less than 0.6 watt is significant of a cardiogenic shock. RV parameters are also very important. You get the right atrial pressure by pulmonary capillary wedge pressure, the pulmonary artery pulsatility index, the right ventricular stroke work index, and also you should see into the pulmonary vascular matrices, that is the transpulmonary pressure gradient, the diastolic pulmonary gradient. So if you get all these values, you can fine-tune your management regarding a cardiogenic shock. I'm not going into the high-risk PCI category, we have already discussed about it. But I would like to focus on this chart. This will be the sum and substance of my talk regarding indication for a VA ECMO. So there are three categories. One is a patient at risk for cardiogenic shock. That is, you have identified that it is going to be a complex procedure. Patient can deteriorate during the procedure. So such patients, it is always advisable to have a radial access. And if the PCI is complicated by hypotension, which is reasonable to trial of vasoactive medications, and they strongly recommend the placement of a PA catheter also. If the shock is progressive, you need to activate the shock team because you will need multiple people's help to counteract this situation. If the patient already presents with cardiogenic shock or the simple high-risk patient has deteriorated and has gone into cardiogenic shock, it is a time when we have to activate the shock team and we have to take a decision about whether to go ahead with the primary PCI or you have to stabilize the patients and do something about to support the circulation. So if it is only LV predominant shock, it is reasonable to escalate to LV support. Either you can use Impella CP, IABP, or if the shock is persisting, you can think of VA ECMO. Or you can escalate to Impella 5.5 or Impella 5 also, but it requires surgical cut down and vascular complications are more. And of course, in a situation of cardiac arrest, you have only option of VA ECMO. So as the previous speaker was telling, VA ECMO can be used as a protection tool. It is used more and more as a protective device. And from the previous chart, we saw that in advanced SCII D or E shocks or cardiac arrest, it is only VA ECMO which will be of help. And it is VA ECMO only it is the only device that can provide full cardiopulmonary support. And previously, ECMO was used as an emergency situation. It was associated with high mortality and morbidity. But nowadays, when you anticipate that the procedure is going to be more complex, you can try with protected PCI. And also, it is more and more commonly used for TAVI, mitra clip, tricuspid clip, etc. Some concerns in PCI plus VA ECMO, you use a lot of anti-platelet medications plus heparin for the extracorporeal circuit. So the bleeding risk is very high. But even if the patient is on a VA ECMO, there is always the chance of stent thrombosis or stent getting occluded. So watching for myocardial ischemia is also important. And also watch for complications like interventricular septal rupture or papillary muscle rupture, cardiac tamponade or retroperitoneal hematoma. About VA ECMO initiation, in a cath lab, the typical configuration is for a peripheral VA ECMO. I'm not going into the details of cannulation. We have already discussed all these situations. And it is a large bore cannula. We are going to put a large bore cannula into the venous axis and a large bore cannula into the arterial axis. So regarding cannulation, the previous speaker has already covered. Axillary artery is also a option. What are the things to be monitored during VA ECMO? We have to monitor, we can do a transesophageal echocardiography and continuous monitoring, hemodynamic parameters monitoring, neuro monitoring can be done. Respiratory monitoring is also very important because the ventilation should be proper. And we have to watch for distal limb ischemia, laboratory parameters, the circulatory parameters, and the renal parameters. So weaning from VA ECMO, if it is an elective protected VA ECMO procedure and the patient is stable with regard to all your parameters, like your mean arterial pressure more than 65, CVP is less, LVEF is acceptable, absence of RV dysfunction, and preserved respiratory function with regard to FiO2 and PO2, absence of intra-procedural complications, you have successfully revascularized, physicians can consider tapering the mechanical circulatory support in the cath lab itself. But if the patient is not stable, patient can go to the ICU. So this is one of our patient who had a complex angioplasty done with peripheral VA ECMO support. Patient had a CKD, patient is on VA ECMO with IABP, CRRT, ventilator and inotropes. Complications are one thing which limit the usage of VA ECMO. Various complications are there. Anticoagulation and bleeding related complications, acute neurological events, acute kidney injury, infectious complications, lower extremity ischemia, thromboembolic complications, hemolysis, LV overload and with pulmonary edema and dysrhythmias. So we'll quickly go through each one of them. Bleeding is a major complication, as I told, in cath lab because of antiplatelets and heparin, the risk of bleeding is quite high. Most feared one is intracranial bleed. Other bleeding sites can be intrathoracic, gastrointestinal, etc. And all the invasive procedure sites, cannula sites, sternotomy site, central line, HD catheter sites are all sites for bleeding. Anticoagulation management is very important. ACT is the one which we monitor. I'm not going into the details. ROTEM should be done to find out any underlying coagulopathy. But of course, the surgical hemostasis also. Properly securing the cannula, proper size of cannula, proper technique for cannula insertion, all these will matter when as far as bleeding and coagulation management is concerned. So anticoagulation management plus proper surgical hemostasis is very important because if the patient continues to bleed, it will be very difficult to attain the adequate flows. It will be very difficult to maintain your perfusion. It will be very difficult to control other parameters also. And again, these parameters have to be routinely checked. I'm not going to the details of lack of time. Acute kidney injury is a complication. Usually when you go on ECMO, there is a lot of fluid resuscitation, especially when you have bleeding, you end up giving a lot of products and blood. So volume overload is a commonest indication where you require a renal support. And especially people with CKD, they need to have a MAP little higher. And diuretics also will be needed to decongest the kidneys. Infectious complications, there are a lot of lines and tubes placed, the patient factors, but most importantly, hypoperfusion on an ECMO. That is something which will lead to translocation of bacteria from the gut, and patient can rapidly go into sepsis. And it is very difficult to identify the sepsis from the SIRS reactions of ECLS. There will be quite similar to this one. Like patient can present with a decrease in the mean arterial pressure. That is the first thing which you will be seeing when the patient is going for sepsis. You won't be able to attain a mean arterial pressure even with high flows. Distal limb ischemia is a dreaded complication. It almost develops 11 to 17% of patients, even if you have a proper distal perfusion cannula. That is partly related to the patient characteristic also. If it's an elderly patient with a peripheral vascular disease, he is more prone for a distal limb ischemia, especially when you are using a lot of vasopressors. This is one of our patients who had a distal limb ischemia who had to be done fasciotomy. Neurological complications are also dreaded. As I told, intracranial bleed is something which is of great concern. But still on ECLS also there is chance of air or clot emboli and hypoxia or the Harlequin syndrome. That is, if the patient is having pulmonary edema or some sort of a desaturation happening, you can have the desaturated blood going to the upper part of the body. LV distension and pulmonary complications, that is also commonly seen, especially if your LV function is very bad. You can have acute pulmonary edema and patient can develop acute pulmonary edema. So with a competent aortic valve and poor LV function, peripheral ECLS pressurizes the aorta, resulting in excessive LV afterload. So LV overdistance and rapidly results in severe pulmonary edema and pulmonary hemorrhage. And also there is a risk of aortic root thrombus formation. So how you identify it is like you lose the pulsatility. If you see the monitor, you lose the pulsatility if there is LV distension happening. So it is actually counterproductive. You put ECMO for circulatory support, but ultimately you will end up in causing more of LV distension and LV dysfunction. So some of the techniques which we use to prevent this LV distension is, one is to use inotropic support, intra-aortic balloon pump afterload reduction, and peripherally inserted impella, where you call it as an ECPella, or if the LV distension is severe, you may have to do it with a transeptal left atrial catheter drain or a percutaneous pulmonary artery catheter drain. Still, if you are not able to adequately perfuse the patient, your LV distension is very severe, you may have to consider for a central VA ECMO. So this is one of our patient who recently had, this is not a chip case, this is a patient with a viral myocarditis. And she had bilateral thrombus also in the arteries. So we had done a thrombectomy. And after that, the patient had a circulatory collapse. So we tried for a peripheral VA ECMO, but the patient was severely bleeding and patient was at the verge of arrest. So she was taken to the theater and she was done a sternotomy and central ECMO. But after the central ECMO placement, patient had severe hyperkalemic cardiac arrest. Patient was supported in the ICU and CRRT was initiated and the heart slowly recovered. So this is typically the console where you see the RPM on the ECMO machine, that is a 3000 RPM. You are getting a flow of around 3.5 liters. And if you see the ECMO, you can echo, you can see that there is a cannula sitting in the right atrium. RV dysfunction is present. LV dysfunction is also present. But there is good pulsatility, the CVP of 13. As soon as you come down on the flows, you see that the mean arterial pressure comes down, the CVP goes up, your LV also is distending. So this is just to show that these are the parameters what we check or what we do in the ICU or in the cath lab, which we have to see. So recently there was an ECMO CS trial where they compared the use of early use of ECMO for cardiogenic shock versus not using ECMO. They found that the immediate implementation of VA ECMO in patients with a rapidly deteriorating or severe cardiogenic shock did not improve clinical outcomes compared with an early conservative strategy that permitted downstream use of VA ECMO in case of worsening hemodynamic status. So to summarize the entire talk, I can take some lines from the ESC guidelines. So regarding short-term MCS, the initial improvements in cardiac output, BP and arterial lactate may be counterbalanced by significant complications. So we have seen various complications. So even though you support the patient, it is very difficult to maintain a patient on ECMO and ultimately get the patient out. Ultimately, as Madam was telling, it is the revascularization or, Sir was telling, Verma Sir was telling, it is ultimately the revascularization or the heart improvement which will determine whether the patient will come out of the ECMO. And unselected use of MCS in patients with cardiogenic shock is not supported. As we see in the ECMO CS trial, we cannot use ECMO for all cardiogenic shocks. Still, it is only indicated for stage D or E cardiogenic shocks. And it requires specialist multidisciplinary expertise for implantation and management, similar to that outlined for advanced heart failure centers. Standardized team-based approach using predefined algorithms for early MCS implant coupled with close monitoring, that is invasive hemodynamics, markers of end organ damage may potentially translate into improved survival. So still we require a lot of studies and trials to conclusively tell whether...
No, I don't agree with you. So the minute you finish your talk, I'll give you my opinion about
Finished, madam. Thank you.
See, actually, he has put a very dismal picture about ECMO. But ECMO is not like that. There's an article which came in Lancet, the arrest trial. The arrest trial, what they did is patients who had a cardiac arrest, who even after 3 DC shocks and 15 minutes of CPR did not improve or put on ECMO. And out of the 20 patients they put, 14 went home with good neurological outcome. And so they recommend, in that particular study, they recommended putting the ECMO in the cath lab, because according to them, cardiologists are good in doing femoral puncture in hypotension. So the arrest trial showed that in a cardiac arrest situation where you have not delayed too much, that is 15 minutes of good quality CPR and 3 DC shocks, if the patient doesn't recover, you have to put an ECMO. So actually the position is not as dismal as you think. Similarly, recently from KIMS, they have shown there are 5 cases who had ECMO. 2 of them survived. So the basic problem is like what happened years back with IABP. When IABP came first, many people developed spinal paralysis. That was because the teams did not know how to use IABP. Now, do you hear of anyone with a spinal injury or paralysis after IABP? No.
But I
So the same
think
thing
you have
is there
also
with
data,
ECMO.
Jobin, your data on the number of ECMOs done and the survivals, you will have something to talk
Yeah,
about.
if you see
It's
the
time to learn the techniques.
if you see the ELSO data, the overall survival is, I think, for VA ECMO is around 40 to 45%, if I'm not wrong.
Dr. Arun,
Absolutely,
your
that's correct.
thoughts also you could.
That's correct.
Yeah.
With
Dr. Arun
the
is intensivist at Cleveland Clinic and cardiac anesthetist.
So, yeah, I'm coming back to what you just said. Yeah.
One more sentence. So the experts in ECMO have claimed that the arrest trial data is highly manipulated, but it's not. Okay. Now, sir, you
So the arrest trial was done in Minnesota under a very tightly controlled situation. There was a team of 9 cardiologists experienced in cannulation, femoral cannulation. It was one center, one ICU. So it was not multi-center. So all the patients were retrieved and they were taken to a single center, cannulated by the same group of people under very strict control. That is, I mean, but completely agree with you. There is a very first randomized controlled trial in eCPR, arrest trial in Minnesota. So under very tightly controlled situation, and they showed 43% survival to good neurological function at discharge from the hospital. So ECMO is useful. Now, my comments on ECMO, on what you said is ECMO is not bad, but ECMO has to be done properly. A lot of intensivists, a lot of cardiologists, cardiac surgeons think in the middle of the night when the patient collapses, stick in 2 cannula and go home. But that's not the
True.
way.
I completely
So,
agree with sir. Yeah.
when you put patients on ECMO, very important to say a couple of things. One is leg, if antegrade perfusion cannula is needed. People very often forget that. You have to monitor nurse spectrometry in the legs to see. Number 2, if your aortic valve is opening, if you are ejecting. If not, a lot of people just do not think about LV unloading. LV is a bad LV struggling against the afterload of blood coming back into the aorta. If you don't address LV unloading, I mean, it's criminal in this day and age not to unload the LV and stick somebody on a VA ECMO in a failing heart. There are a lot of other things like oxygenation and Harlequin syndrome, like you said, 8% incidence. These are things very conveniently forgotten. But so outcomes are determined not by the act of putting somebody on ECMO, but taking care of a lot of other things. That'll
I
be
think
my
that's
point.
exactly the reason why if you see the ELSO data, of all the best centers, the overall survival, if you take, it is still 45 to 50% maximum for a VA ECMO, whatever ECMO.
in spite of all advances in PCI, cardiogenic shock still has a survival of only 47%. Actually, there's an American data where when they use Impella more than 7 times in a year, the survival from cardiogenic shock is 47%. In all other places, the survival of cardiogenic shock is even lower than that. So if you're used to using Impella, you can improve the survival.
That is true, madam. But in our country, I don't think many centers are using Impella because of cost constraints.
No, I agree. So what I'm saying is ECMO is similar. There's a learning curve. Right now, all over the world, people are in the learning curve of ECMO.
Ma'am, okay, regarding what Dr. Jobin has mentioned, it was a very informative lecture. Again, whatever the data says, anybody with VA, more the mortality, the survival is only 40%. That's what the SLO data says. And again, when it comes to an eCPR, the percentage of people,
It's
they
25
go
to 30. Yeah.
it's only 20%.
25
It's
to
only
30, yeah.
20% and not more than that, ma'am. We analyzed our data in our hospital. We've had 12 cardiogenic shock, acute MI cardiogenic shock patients put on VA. Only 2 of them they survived, primarily because it was all eCPRs. eCPRs, even 40 minutes of eCPR and then putting in an ECMO, and only 2 out of 12 survived in acute myocardial infarction, despite doing a revascularization thing like that.
See, that's not the thing. See, the problem in cardiogenic shock is that even unloading the ventricle for half an hour and then doing a PCI is not enough. In cardiogenic shock, in the first 5-6 minutes, you have to do the revascularization. That is what the unload trial showed.
Yeah, ma'am. I agreed with you. And again, what Dr. Jobin has mentioned,
I'm
patient
not
is
disagreeing. I'm just
patient
telling.
is sick. We know that patient is going in for shock. You put in a VA ECMO and then do PCA. Probably the survival is going to be much better than rather than doing an eCPR 10 minutes, 20 minutes, 30 minutes and all. Then again, when we looked at our survival in fulminant cardiogenic, fulminant myocarditis, and we had 5 patients, all had cardiac arrest CPRs put on VA ECMO through the femoral artery, all percutaneous. Everyone survived. Everyone survived. First 2 days, as what he showed in the monitor, we don't see a pulsatile flow at all. But then 2 days later, 3 days later, the heart starts pumping, and they come out, and we just had to make the a surgical venting of the ventricle had to be done surgically, because we cannot think in terms of another 20 lakhs for an impeller to vent the left ventricle. So we put in an EABP also, hoping that it will vent the ventricle in few patients. We have done that also. But then when it comes to a pulmonary myocarditis, most of them they do survive. I hope that's your data also says. And just a query on your presentation. You mentioned that your fulminant cardiogenic shock, you had to put in a central VA. What was the reason for that?
Yeah, central.
Every situation
Yeah.
when patient is in shock or arrest or CPR, we managed to have percutaneous implantation through the femoral artery. What
No,
was
no.
the central?
This patient, actually, she had this femoral embolectomy done previously. And then when she crashed, the surgeon was called because we don't want to try percutaneous for this patient. So surgeon tried opening the artery, it bled. He couldn't control the bleeding. So within no time, patient lost a lot of blood and BP was in 30s. So it was in that situation that we had to open the chest. But
Sorry to interrupt,
still,
Madam
VA
Chairperson.
Okay.
Ma'am, I'm so sorry, sir.
Time is up.
Yes.
Okay,
We're
just-
waiting for Dr.
just-
Karthikeyan now.
Just one more comment about Deepak's thing. Deepak, that's the correct data about people surviving. You have to publish it.
Thank you so much, sir. Thank you, ma'am.
Thank you. Thank you.
Sorry to interrupt.
Dr. Jobin hasn't completed.
Sir,
Use the
we'll
answer.
let
No. There will be rare situations because VA ECMO, there is limitation to the circulatory support you can give when you use peripherally. It is not like a central ECMO because there is always concerns about your cannula size, your arterial cannula size, all will matter with regard to the flow you are giving. And actually you are giving it in a physiologically opposite direction. So peripheral VA ECMO is exactly not comparable with the central ECMO. Central ECMO, you can give maximum flows. That is what I showed, the 7-liter flows and all you can attain only with the central ECMO. So especially if suppose a patient goes into severe sepsis, patient will need a supranormal flow. Patient will have to be flown with 6 to 7 liters of flows. So you may not be able to gain that much of a flow with a peripheral small cannula. Such situations you may have to either put an additional cannula, or in worse situations with severe LV dysfunction where patient is already also in sepsis, you may have to do a sternotomy and go in for a central VA ECMO to have this supranormal flows. So all ECMOs are not the same. The flows and the perfusion you attain depends on your cannula size and the type of ECMO you are doing. Whether it is central ECMO is always better as regard to perfusion.
Thank you, Jovan. And thank you for the excellent discussion following the speech.
Thank you so much, sir. Sorry for the interruption once again. We're waiting on Dr. Karthikeyan for now for the symposium on the bailout models. Dr. Karthikeyan, please. No, ma'am, no. I think I forgot to say thank you the second time. Sorry, apologize once again. Thank you so much, sirs, ma'am. We have the hands-on symposium now, the symposium on the bailout. Dr. Karthikeyan, please. Over to you, sir.
Good evening. Okay. So this structure of this symposium is actually to practice certain things which, when we called upon, should be done at a really fast time. So we have got two bailout models from the Termo company. One is dislodged stent retrieval, and the other one is distal wire perf and how we are going to close. So I thought I'll just show what we are going to do, and then whoever is interested, who wants to practice, can practice on the real model. So because these things, when we are called upon, we need to do it quite fast. Okay, I'll just go to the case where this is regular PCI. And PCI to the RCA was done, good result post-stenting. And this is what we noticed in the final shot. So this pattern, I think everybody knows what has happened. There's a distal wire perf that is staining. So the effusion was not significant, and patient maintained hemodynamics almost half an hour, 45 minutes in the lab. We thought, okay, we come out and heparin's effect is going to wear out. So that was actually a big mistake. So 4 hours later, we had to come back, and the call was that of hypotension, vomiting, atypical chest discomfort. And we got back the patient. I did a pericardiocentesis and then did check. This perforation is actually sealed, but that slow buildup of 80-100 ml over this 4 hours has caused the patient into hemodynamic compromise. What would have been a very successful PCA would have lost, and if you had gone home and by the time you come back. So this is something we need to tackle. And so when there's a wire perf, it's better to handle then and there rather than wait and watch. Balloon occlusion of the feeding branch is something we could have done instead of waiting and watching. It occluded the feeding branch and then waited and watched. Or distal embolization of fat or particles. But the only problem we have with particles is that you can't control. And when you are doing it, if they are in a collateralized vessel, then these particles can go in a different place. So, of course, so now how do we do this? So this is a Nanto model which I have in my lab, where, people who are not used to doing, in those days, our exposure to coils was only coil closure of PDA. So at that point of time, choosing the right coil, choosing the right microcatheter, and delivering the coil is little difficult. And if your lab does not have the hardware, it's even more difficult. So what I did is just to simulate, I've shown deployment of how to load the coil and how to get your fine cross there. All of us know by this time that we either trap it or with a dock, you get your fine cross there. And then here I'm delivering this is a coil which is actually straight. It's not that traditional coil, but a straight coil where you can see in the distal bed here, I've delivered the straight coil. What to do if you don't have a coil? So now this is the cut end of a wire. This 30 millimeters of the cut end of the wire can also be cut, and then you can deploy it. And the wire which is used to push, usually I use a Pilot 50 because that's a very stiff wire and you can get your coil down. So this is something, generally it's said that the fine cross, the dia is only 0.08. So you need a pro grade, but then a traditional 0.18 coil will go over a fine cross, but not over a Corsair or a Caravel. So fine cross is the catheter to go if you have to do a coil. Okay, so these are the bailout options we have. In my lab, I've got this Hilal coil. I bought Hilal coils here. If somebody wants to try, you can. So how to load it? Because, okay, for this time being, just let this play. Whereas it comes with this is the deployed coil. So we actually load this, and you need it comes with a pusher actually. once you load this, you have that really stiff pusher with which you push the coil into the fine cross and then use the traditional 014 wire. As I told you why I prefer pilot, but any wire, because the space inside the fine cross is just enough. And when this wire comes out, it is going to push the coil and then only this can come out. So this was done in the bench in my lab, and it's very much reproducible. But only thing is, this took me, when I did the bench testing, it took me almost 10-15 minutes to do all this setup. When you are supposed to do it fast, then it's better that you have some kind of practice doing it, and that's why the model is here. And what if you don't have coils? What if there's published literature on using Vicryl? It's a bioabsorbable stuff. You can cut it into 4 or 5 small pieces of, say, 4 to 5 millimeters. And that is what we are demonstrating here. And there's a special, a technique of how to cut it also. You have to hold the tip and then cut it with your regular surgical scissor. And then how to load it. Use your introducer needle. You get your Vicryl there. You just load it from the distal tip and use that introducer to get into the fine cross. And then push as normally how you would deploy a coil. So you need at least 4 to 5 bits of Vicryl to kind of close the distal vasculature so that it will stop bleeding. And then, of course, it's going to get absorbed in 8 weeks. So that should be a better thing than a coil is going to stay forever. So this is, of course, all this, of course, there's no randomized data. It's all published in literature. And we have done bench testing. It does work. And there's another method. If you are having axiom coils, if you have an over-the-wire balloon, then you can just do what is called as a plug and seal technique, where we just kind of inflate the balloon and plug the leak first, and then over the wire port, we deploy the coil. So this is what 2 things we can try deploying coils and Vicryl in the model. If somebody is interested, can be done. And the other model we have is the stent which is got dislodged. So this is what happened in a real case where the stent, I wanted to bring it back to have better visualization, but then the balloon is out and the stent is in the left main. So the options we have, so what we have is the coronary snare and trying the coronary snare or a balloon and then taking it out. So these 2 methods can be practiced on the bailout model. So in this particular case, I made a mistake was 6 French guide. I used a 2 mm balloon and retrieved it. So what happened is this stent is not going to come into the guide catheter. So I didn't, that was a mistake at the spur of the moment. I didn't realize that. And it's actually smart to use a 1.5 balloon. And then I had to bring the stent all the way to the iliac and to realize that the sheath is also 6 French. And so I had to upsize the sheath through a 7 French guide and then snare it out. See, when all these things, when you are in the heat of the moment, these calculations don't come into your mind. So you must know what will work and then whether you are mathematically okay. So that is something. So in this particular patient, we bailed out snaring from the distal vasculature. So these are the methods, how are you going to snare from the dislodged stent. Either we can take a 1.5 mm balloon and retrieve the undeployed stent. And if it's a 7 French guide, you can use a 2 mm. And if the sheath size is more than the guide size, then we have the option of upsizing to a roomy guide. And then it's better to have a coronary micro snare, 2 or 3 mm snare for retrieval. And a 1.5 to 40 mm over the wire peripheral balloon may also be useful. So here, if somebody wants to try these things, the model is available. It's a dinner time. So whoever wants to try, the models are there. I'll just be happy to help. Thank you very much. Over the wire. Okay. Because coronary snares goes over the wire. And you have to be as close to the foreign object as possible. And then that 2 mm or 3 mm, you'll be able to catch it.
and then it won't be very coaxial.
Never
Some of
able
the
to
whole
catch.
thing has to come out without traumatizing. So you can practice it. The other method is like using a smaller balloon. In fact, if there's a paper I can show you, the best thing for a deployed stent. In my lab, I have for the payload for this particular situation, I have got, we have an undeployed stent. In an undeployed stent, a 1.5 balloon. If you can go this distal to both proximal
It
and
doesn't
distal.
get it. It doesn't get it.
I can show you this one also. How it works is that your wire will be a really good over the shaft. It's
Sister one.
Take your time.
Hello.
We have all the time.
The balloon into the
Ha,
center
ha,
even difficult.
ha.
We have tried it.
അപ്പൊ റൈസോഡേക്ക് കൊടുക്കണ്ട 10 units of actrapid കൊടുത്താൽ മതി. യാ നാളെ രാജേഷ് സാർ ഉണ്ടെങ്കിൽ ഒന്ന് കാണിക്കാൻ പറയണേ. അപ്പൊ ഒരു ECG കൂടെ എടുപ്പിക്കണേ, എന്നിട്ട് അത് എനിക്ക് വിട്ടേക്കണേ. ആ പിന്നെ എന്തെങ്കിലും ഇഷ്യൂ ഉണ്ടെങ്കിൽ ജസ്റ്റ് സജിത് സാറിനെ കാണാൻ പറയണേ. നാളെ yes. Okay. അപ്പൊ റൈസോഡേക്ക് കൊടുക്കണ്ട, മറ്റേത് കൊടുത്താൽ മതി. ശരി. Actually, patient needs amputation. Septicemia.
No problem. Take your time.
Yeah.
So the 1.5 mm balloon, the longest length available in a coronary balloon is 30 millimeters. Okay, so any stent up to 28 millimeters can actually get that 1.5 inside, because a crimped stent actually will accommodate a 1.5 easily. It's not difficult. Over the shaft of the, you should not be over the soft portion, nicely push it down to a very distal branch, and 1.5 into 30 also can go. So what happens is, even at 28, you can have the distal balloon inflated, so it will be little, won't scratch, and you can coaxially take it the whole system.
It is difficult to introduce the balloon inside that, but
No,
that's
madam,
what you
it
have
is
to
possible.
practice.
I can show it because I have cases we have done that. Okay. The other thing is that if you want a longer stent, the stent is over the wire balloon in the peripheral system, which is 1.5 into 40, which is available. This is a payload balloon which have its off table, of course. But if you can traffic, dock it or traffic, and then you can take even a 38 safely out, because that will accommodate. Even if you get one part of the control, rather than having this, you see, the snare will only hold one part. It will not hold the tip. It can, wherever you are getting control, you are going to catch it. So both ends of the stent can traumatize the vessel, especially if it's not a roomy vessel. So the snare is not a solution actually. It's good to
No,
have.
actually, I remember in one of the conferences in India only, the best case award I think, was given to someone who snared a stent. And the Claude Mary Morris, she asked one question: will you hold it from the proximal end or the distal end? And the answer was distal end. And that person got the prize. So I never understood that.
The thing is, it's not about distal proximal. It's about how you are going to control and how the wire is aligned. See, the best method today to retrieve any foreign object is not any of this. If you look at, say, if the stent is in the right coronary artery and you have got a stent, now what we say is telescoping.
Put a guide.
Yeah,
with it,
you have to
guide
put a
extension.
wire, a guide extension, and then this wire should have a balloon trap. The whole thing should come out. This is telescoping. It's a part of a bigger talk. Actually, on third day I'm giving a talk on this, where any foreign object, it may be a wire, it may be a stent. One of the methods is telescoping and retrieval. When you have adequately sized guide extension, that can go telescope. That is less traumatizing. See, all of us assume that vessel 3.5 is going to be pristine and it's not going to get damaged. What if you dissect all the way? That's going to be really a big trouble. So with what we have to using a coronary snare is a skill set we should have. And that is the reason why this exercise is there.
Yeah.
Because I did it for the first time in Franex in Termos when we had gone for CCT. We used two techniques we tried. Three wires, encircling the stent and retrieval. But trust me, it's so difficult. You can't control it. You can't take it coaxially into the guide. You can get it all into the aorta, but then you can't control it. Then we realized that the stent is better. But then over a period of time, now all of us know that even a snare, though it gives control, it may not be the best thing. Atraumatically removing the foreign object is the skin. So what works on that particular day? I have got
But
a
for
lot
me,
of slides.
nothing has worked. But I've seen my juniors collect it without any
We
problem.
can do it. What we can do
Without
now.
any problem.
Thermobase, you have the snare? Yeah. Okay. Get the snare, please. Load it first. So now loading the snare itself is a skill. It comes as a set actually. Suresh, where are you? Come, load it fast. And we have to get a coronary wire. Just get a coronary wire across, madam. Yeah. Just put it. I think you can get it on. Okay. So you take a regular 1-4 wire.
Using the balloon to stabilize the stent?
Okay, actually.
No, that have to,
the
one has to
balloon-
put it inside the stent.
No. Yes.
We are putting an uninflated balloon, right?
Yes.
So,
No. So you in retrieving the stent? Yeah. So 1.5 goes inside. It should preferentially inflate. Then only you can. Okay, and it should preferentially both sides. No, you should be having the balloon hanging. Why? Because it will not scratch. It will align itself in the center.
that needs the stent.
Yes, but you will be able to control it, and you can bring the whole system should come out. You should not try to just bring it out. Though it will hold, it should be a whole movement where the guide, everything comes out. Once it comes to the airtight, it's easy.
Earlier we used to cross the stent with the balloon.
Yes. Now there are two things. Yes.
Yeah.
Distally. Now the case I showed where part of the stent is in the left main aorta. Okay, now the distal part is to be controlled. Whereas if you are having the mid RCA, then either way is a problem. Either you hold it proximally also problem, literally it's also. You must have control both. In that particular situation, that is okay. Madam, you wired it.
I'm putting
Just
it.
put the wire distance distal wherever you want. In a case like this, the trick is to have the wire as close to the foreign body as possible. Only then the 2 mm, 3 mm loop, will be able to catch the foreign body. No, madam,
I damaged it.
No. Just wire, madam. It's okay. It's okay. Yeah.
No, I just touched it by mistake.
Oh, Harish, what is this?
Show me.
Okay.
I'm so sorry. And I thought it's the wire and held it. So where is it going? Unless, yeah, I can. Only if I take off my specs, I can see.
Better seen in the camera. Okay, now you have gone by the side of the skin. It's a good position, no problem.
Should I remove, pull out the wire a little more?
Oh, if you have gone to the distal vasculature.
Yeah.
That black one is a stent, no, sir?
No, the stent is here. The stent is here.
I can point.
Yeah, can you point?
You have a pointer, somebody can use a pointer. Okay, now
Snare
what has
is
happened is
the
our
snare got
fellows have,
damaged.
Damaged this. I'll show you how to load this snare because in the spur of the movement, it does not work like a regular snare.
Pointer is here, sir.
Pointer is. Bring it.
Okay.
Now, this snare, this is the coronary snare. Can you get the snare, please? See, it has two parts actually. See, one part is the snare. The other one is the sheath. Where's the sheath? Here. So you are supposed to load this. Load it this. You should not load it like this.
Oh.
Why? See, where is the? Where is the? Metal hoop is now not here. Basically,
The loop has to be pulled into.
yes. And what is the set, man? Where is the metallic component?
Can't see it now, sir. It is there, I think.
Wait.
That is not my fault.
That's okay. No, okay. I'll tell you what it is. This snare, should get loaded into the sheath, and that small loop is there, that should go over the wire. Okay.
It should be over the wire first.
Yes. No, that loop should load it actually. Once that loop is not there. Okay.
That loop has to be loaded on.
You have to get the snare. Maybe again we have to
Yeah, we'll
demonstrate that. So basically, the wire gets loaded, the loop, no, gets loaded like this, and then this will go on the side. Okay, there's no rapid exchange component here.
Oh.
This will go on the side like this, go
And
all
then
the way
How do you
up.
put the stilet?
Madam?
No, that you said sheath.
The sheath, yeah. Because how do you tighten the snare? Now, you should not pull. As you the snare, no, it is caught by pushing the sheath. It is not by pulling this tightening, because once you tighten, it will slip and go distally. To control the,
You just
that's what the
mimic
loop is
it.
told.
You just mimic it.
Okay, I can show it in my video. I'll show you. This, when you want to tighten a snare, you should not pull the thing. What will happen when it gets tightened? No, it becomes loose. So ideally, you should push the sheath and reduce the loop. The pushing of the sheath, the pressure it creates, that only holds the foreign body. Okay, when you try all this snaring in the periphery also, what we do is once you get control of the,
No, I
I will
understand.
show
You
you
push
that.
the sheath. You push the sheath like this, and the snare
No, I will
tightens.
try to. I have a video in my computer. I'll just show it. Then you will get the idea. 1 minute. Because this stand is damaged. If you anyway, this thing I'll show. 1 minute.
But this was like this only. I think that snare doesn't have the metal. This is a Ikeo sterilized, no? At that time it got sterilized. No, but it was in this, no?
Yeah.
So that I have not damaged. It was like this only when I saw it.
No, I don't think you have to take such a load.
When I held it like this, thinking it's the guide wire. Yeah, he's showing the video on how to load the snare.
Show it on. Probably it was done in the left atrium, but the principles remain. So the third day, but I think we can show it now also. Can you just come on screen, please? Just take that. We can do the coil deployment. I assure you the coils are good because it's. Go to my presentation. Okay. I can see here, but not here. Okay. So this is what happened. You have the BNB happening, the coiled wire breaking. So the retrieval of this foreign body, the snaring technique is something similar. How to use a snare is here. What was done was fashioning. Now the problem here is that there is a soft end and a sharp end. Whenever you snare, it's easy to control a soft end. It all depends on the foreign body. If it's sharp at one end, and that means you're going to traumatize. So how safely we can get? So when you have to sharp and a soft end, you have to do something called snaring and telescoping. The sheet should telescope the sharp end, and the snare should catch the soft end. So in this particular patient, this is what we did, and also the hardware you have in the lab. So I had only a snare which was used for an IVC filter retrieval. And I didn't have those long sheets which were used for AST device. No? If you have long sheets, you can go all the way and have less traumatic areas. So because once you go close to the foreign body, then we have more control. So in this particular thing, you have a very free floating foreign body. And what we did, the improvisation, we used a JR catheter and the snare goes in. So you can see that why the JR guide catheter was used was that a 7-French JR will accommodate a 6-French snare, and you will have that place for you, the loop to work. And then this snare can be the sheath, instead of a snare sheath, I'm using the guide. So guide can be used to telescope. Now you see what is happening. I'm controlling the soft portion. The JR can be manipulated. See, now the soft portion is being caught. It is not the end of the thing. If I try to tighten like this, it will slip. You can see that, see this loop, it catches comfortably. But once you try to tighten like this, just pulling the loop, what will happen? It will slip. Okay.
So what you have to do is do this. As you pull the foreign body inside, the sheet should go in. That will tighten. And you can see that I have very good control of the thing inside the guide. And this guide catheter goes and telescopes the foreign body. And this is called snaring and telescoping. Because it's not that you can just catch a foreign body. You don't have so much control. It's like playing a video game, no? Tying your shoelaces with golf clubs. It's not that easy. Snaring is philosophically looks okay, but it's not that okay. So you have to snare, you have to telescope, and then you have to retrieve. The sharp end has to be caught. Yeah. Okay. So here you see that the cap, I've caught it here, but the guide catheter keeps going, so that you don't perforate anywhere. And then you see this. You have to get your foreign body safe, and then you have to retrieve. So that is the philosophical difference when you have a sharp end. So when you have a sharp end, try to remove it into this. That's the reason why you have to have a 7 French. Or get it to the iota, then it's. So that's it. So that is the.
That's the same thing which happened when I tried to retrieve a stent.
Unfortunately, these people didn't get a research there, but it's okay. We can get from.
We can do it tomorrow.
You have wireless stents which are much smaller than this and go into the coronary artery.
Yes.
And we can,
Yes, we have. Yes, all of us. We have. I have a 3 mm stent. Yes. The only problem is that we are in a pristine vessel. There is no problem. If you are not in a pristine vessel, you can traumatize. Then your area of stenting is going to be more than what we have bargained for. So see, the whole crux of the thing is how to remove it atraumatically. It's not removal is not the success here. Removing it atraumatically without causing damage is the thing. All of us, I have even a 3-loop snare I've got. I will catch it. It's not about catching the foreign body. How to do it without traumatizing. If you traumatize the left main or if traumatize, then it becomes messy. Now the preferred technique for a foreign body retrieval is actually taking another wire, telescoping with the guide liner or guidezilla, and controlling the foreign body with the balloon inside the guide liner and removing en masse. That is the preferred method as of now.
But you have to cannulate the.
No, it's not that.
Stent.
Madam,
That's not easy.
once a stent is there, which is what stripped off the thing, taking another wire by the side is not difficult.
That is
Okay, and taking that also I can show because I have.
Anil. Simply was able to take out the stent. We ended up.
Okay, so now you see this, madam. Here.
Yeah.
Okay, you have to be sufficiently close in 3 dimensions. We are taking one view very close, but we are not close in others. So this can happen in iota. It can happen in and that's already the time. The guide is very big relative to the size of vessel. So you will all agree with me. The straight sheet of Perumal is 5 French. And this is Teflon, regular Teflon wire going to the side of the foreign body. My idea was to get as close to the foreign body as possible and then snare it out. But then what was providence was that just telescope. So next step, what happened? What happens? Foreign body, kind of sticks onto the vessel, and you have a balloon to catch it, nothing like it. So the only thing, once you have done it once, you will believe that you can do it many times. That's why this, because this whole thing, I was not prepared, since I've never done this before. But only thing I've done it was once I've done it, so I know that it is possible. You have to, at that part of the movement, you have to just believe that it's possible. So I've shown you, it's all there. So if you can do it in iota, catch a hole for wire, telescope it with the 5 French snare sheet, that is the currently the best method. You go to PCR
see our online bailouts. That's what they say. So, when what the current guideline is so good. You can take it as close. You can wire anywhere close to the foreign body. Get your snare close. And from then you can telescope. Telescoping with a guide wheel is the best method. Today I thought because we have a coronary snare and we can demonstrate using the coronary snare, but fortunately.
So, do you want to show us the coil? But I can
Of
tell
course,
you,
the coils are here.
I can tell you a method which we used in our department 2 times. One is we took this little contrast in a beaker and we scraped, add gel, and then put it at the end of the guide wire and close the coronary with that.
Yes, gel foam is a very useful technique. Only problem with gel foam is roll over gel foam. We don't know where it will go. Similarly, when we are having collateralized vessels.
You use it with the microcatheter.
No, of course. The microcatheter, what if we have a collateral? When we do CTOs, preparation happens many times in CTOs. We have collaterals. Once you inject gel foam, it's going to go all the way. That is the thing. Even interventional radiologists don't use gel foam when the distal vessel bed is not well defined. The reason why in a flu and this one is not commonly used in our literature is because we don't have control. If you ask the Japanese operators, coils on both sides of the collateral. That is what is recommended. You have to close from this end, you must close from the other end also.
No, but there may not be that many collaterals also.
Madam, that's what we think. Actually,
but
if you look at what literature says, and Dr. Sumitji has actually done this. What he has done in a pig heart has used a 60-gram weight wire, perforated, and shown that the time required, by the time in 4 hours, if you're going, what I showed you, that actually happens. The ooze, what we think is actually minimal, is not that minimal. You think you are reversed heparin, nothing will happen. You will have to come back, okay? Because the feeders for that thing is trauma, and once it is not what will actually close the thing is not clot formation. The pressure in the pericardial cavity that creates the tamponading effect. It is not clot formation because we are given heparin and all this stuff. And when you have more than one feeder, it is going to still ooze. That's why CTO operators, even if you are going to reverse the heparin, they are comfortable sealing from both sides. And why coils? Coils because we have control over where you are delivering them.
And if you don't have coils,
that's what I've told you. You can use Vicryl. You can use the cut end of the black end, the regular coronary wire. You can cut it into 2-3 pieces, and then that can be deployed. And Vicryl can be deployed. And there's another method. If you get all your microcatheter there, you can give negative suction. Collapse the vessel. Okay, that is one. These are things which we cannot tell in public. You can
write an article.
No, it's there. It's all published. You collapse the vessel and then create a thrombus. Other thing, the same 1.5 balloon can be used to tamponade that place.
Yeah.
And the last thing, we all know how to dissect. If you dissect, that vessel will close down. Intentional dissection sometimes, no? When we do ADR, what are we doing? We're doing intentional dissection. We are creating a knuckle. We do the intentional dissection. Sometimes if you have to close, you can lose a tributary to actually kind of. So these are things which you can't openly tell, but these have all been done. So if you want to deploy coils, we will do it because everything is new.
We can.
Fine cross is there because many time, we always think that prograde is what is required. But you see this end
So
of
should we take this out or no?
No, it's okay. We just take fine cross. Fine cross, Kappa. Sujesh, get us fine cross, please. Okay. As I showed in the video, the Hilal coil. So this is what you have to buy. This is the 018 Hilal coil, and what it does, you have to ask for this 2.5 loop coil, because what happens once it gets deployed, it will form 2.5 loops inside the vessel. So clot formation will be faster. There's another thing. This is straight coil. The straight coil is not available in our country, but that is also good. Just go and deploy. Okay. Okay. Now we have got the see this snare, no? Okay. At least
that is multi-loop. Single loop is also there.
Single loop. I don't know. Okay.
So do you want this?
Single loop. Single loop.
Navicross, doctor. You can use this Navicross.
Yeah. Now I'll just show you how this is loaded. This is very important. You see, this is the snare. You can see that the loop.
Yeah.
Now you have to load it back end. Okay. Okay.
This also.
Madam wants to try. It's okay. See, you know what you have
So
to
should
do.
I take out this needle?
Yes, madam. You have to take it out.
Navicross cut.
Okay. See, you have to load this like
The
this.
wire-
See, the loop. You should not load it from back. it has to be loaded like this. Okay. Now, and then you have to catch that end with the torque.
The loop is that side, huh? Sir?
Yes,
The loop
yes.
is
The loop
that
is
way.
here. You have to load like this first. Because if somebody who has never used it, they tries to load it from front,
The
you
whole
will
thing will
damage
go.
this. Okay, so this is first thing. Now, see how the coil is tightened is we think that we pull it, it will of course do it, but the correct method is to push this sheath and close the thing. Okay. Now, do we have that torquer? Do you have a torquer? Just put the torquer here, please. You must have control over this thing. Where's that? Will you put a wire torque or something? Okay. You push it. See, this is a limited loop. So even if push it, it's going to be only 2M. Okay. Now this thing must be carefully loaded over this wire, coronary wire. Okay. This it will go over this. Okay. The Y connector should be fully open. No, it's okay. Just remove. Pull it back, please. Pull it back.
So Y connector is open.
Okay. Pull it back. Pull it back. Nalla. Pinadi. Okay. Just be there. Be there. Okay. First thing you load it. Okay. Load it. Pull it back, please. Pull it back. Pull it back. Okay. See. Just keep it little loose and load it nicely. Okay. When you do this, the Y connector should be fully open. Okay. And then tighten it little bit so that it goes smoothly. You should not damage the snare. Okay. Now goes it.
Close the Y connector.
No. Till we get very comfortable inside the guide, don't close it. What you have to do is close it and just open it like this and keep it. Okay. Then this is what in the speed when we want to do, all this will not come to our mind. If we have done it before, now you know the precautions. Now it's closed. Now you can take it all the way. That snare. Okay. Now this you have to have control over this.
No, can I ask you? I mean, silly question. Can I hold? Do I hold the
Yes,
wire as usual?
you hold the wire as usual, and you try to push the this one. If you want, you can see now the
wire come out.
I think the wire has come out. It's okay, madam. Now you have got the thing how to load this snare. You take it over this gently. Where is
No,
the
the
guide?
wire is
Hey, the guide
here,
is out, Rade. See, the guide is out. See the guide which was here, no?
Yeah.
Okay. I'll give you 10 minutes. Get this ready, madam. Just let him get it ready. We'll do in the meanwhile, with the fine cross, you can start deploy. We can deploy coils. You get this ready. Okay.
It is
No, the guide will.
You just
have to hook it. Do it. So that the work should be only snaring it, not doing all this. Just take some time. In the meanwhile, I will take the coils. Okay. Because see, the coils come at 2 per thing. So how many coils you have? You have only 2 coils in per. So if you're going to have to deploy from both sides, then you must have 1 or 2 sets of this. So this is the size you have to order. 018. Anything, yes, because if you choose the wrong size, it won't go inside a fine cross. It will not go into a caravel. It will not go into a corsair. Okay, so that is important. Only fine cross or prograde. Prograde is a larger diameter. It's an interventional radiology product from Termo. I don't have anything to do with Termo, but that is the catheter available. Cook also has got a catheter of. I don't know what it's called. Merit Medical has got a catheter which can deliver the coils. Any one of the things. Okay. Now, that fine cross has to be well lubricated. Can you? Okay. Now, this is how the coils will come, madam. These coils will be coming with the delivery system like this. Okay. Okay. Now, I have already shown how it is. And where is the fine cross? Fine cross. Yellow.
Fine cross.
Okay. See. Now what you have to do is take this, go in, push this thing, this will go in. Okay, that is the first step. Push this will go in. Okay, then remove this out. Take your pilot 50 wire, give it a very small bend, and then over this start pushing. The front end or the back end? You don't need a back end. Back end is very sharp. It will traumatize. See, anyway, that back end has to come out. It will come out at some point of time. So what you do is take a pilot 50, 1.5 gram tip load, create a very small bend, take this pusher out. Okay, and through this you can put this 014 wire. Okay, if it doesn't go, take this out, put your 014 wire. As you push it, it will come all the way out here. That we can actually, do for yourself. Give this. You have a good wire. What is the wire you have run through or something? What do you have? Okay. The problem with the run through or this Huon blue or any of this wire, the tip is still soft. Okay, the tip
So it
weight
won't
is point. It will push because there's no space inside the fine cross. When you give adequate force, it will come out. Okay, we did this in India CTO. That's 2 months back. We did this. Now, so if somebody wants to try, you can try. I'm not going to push the coil. You can push the coil. Then your wire. Get your wire ready. Regular coronary wire. Yeah. Create the shape, everything, and so my preferred wire for this is 550 because it has that. The other side, please. Okay.
But what all the coils of 0.1 are compatible? Maybe this
No.
that a ProGrade microcatheter.
Yes, no, that's what I'm trying to tell you. ProGrade is also Thermo's product only. Cook makes these Hilal coils. So there is no compatibility thing here. Many of the labs won't have ProGrade. I'm telling you that you can deliver. Okay. And if you choose this dimension, it is possible. Okay. Theoretically, in our mind, we always think this is overnight, how will we be able to deliver? But it is possible. That's why we are here. Okay. You can now first push this, madam, and the coil will be inside. Okay. I'll show you the steps again if you want to.
Not at all going.
No, you not like that. You have to push this.
Only coil inside, right?
Only coil. Madam, the coil will go inside. Wait, I'll show you one by one. I'll just get back to the.
Yes. Oh, I have agree. Yeah, this is finished.
This contains the. You have to push it inside. Yes, and then then you have to remove that and push it.
But the wire is not being found.
No, after that you have
No,
to.
the coil is now inside.
The
coil is inside and you are pushing it with the wire.
Just
It will come at this end. Here it will come.
If it is going inside,
It drop.
You're holding there.
Right on, please. Have you loaded the coil, madam?
Yeah, we have put it in. But we don't know whether it's in or fallen out.
One minute, madam. Just see what.
Yeah.
This is how we load it.
You start.
The gynecology, push.
Okay.
There is no coming back.
Yes. Yes, sir, we're doing it.
Okay. Now please push it. Somebody can hold it.
She is holding it.
Yes.
I hope it comes.
It will come. You just
There's
start.
no resistance. That's the funny thing.
Yeah.
I was expecting there to be some resistance.
Control.
Run through.
Undo floppy wire. Oh, it's
Follow.
come. I think it's
No,
come.
push பண்ணுங்க. It will come with little difficulty. The tip, no? It will find it difficult, but it
Yeah,
is
it's a
possible.
little difficult now.
Yes.
It's not going.
No, it will go.
Yeah,
It's coming.
Ah,
That's it. It's right. That's all. So now you don't have a
Anybody
point.
else can have it.
Yeah. Yes, it is curling 2.5 times. We used to do this for PD, you know, the same thing. It's okay. Now, this, yes, 2.5. So at any distal vessel, no, anything 2 millimeter vessel, you will be able to. One coil is enough. Yes. Now that is important. So when you do, what is
Pacemaker.
that?
We use
Of course.
micro for pacemaker.
So 10 is how much, 20 is how much, 30 is how much. So 30 is the one which is compatible with fine cross. 30, 40 and above, no? Only. 10, 20 will not go in. So this is 30 monochrome. Why I personally, I tried with Vicryl. The Vicryl has multiple filaments which are kind of pinned, you know. So braided. So what happens is when you cut it, you don't get a clean cut. These filaments, no, they get caught, they get stuck on the side of the catheter, difficult to push. And this one you can't see fluoroscopically.
Yeah.
So what you have to do, the improvisation, what we can do
Put some
is use monochrome.
contrast.
Monochrome. No, if you put contrast, it will be sticky. So this is monochrome.
You can
Yeah.
use monochrome.
Yeah. Now, okay. It's okay. It's I
used to
think.
use monochrome for placement
Okay.
because my husband
Yes.
infection won't be.
Now, inga பாருங்க.
Vicryl is having-
Vicryl, if you want to, I just. Is there a scissor or something to cut and show? No. It's okay. Come. Blade is there. See, these fellows are. I told you to get a surgical scissor. A little professional, man. Okay. The blade. Balan will be very unhappy with you, man. Okay. See, this filament, no?
Give the dinner.
Hello?
I've not eaten breakfast or
Don't worry, we'll
Okay. நான் பார்க்குறேம்மா பார்த்துட்டு ஒரு 5 minutes கால் பண்ணுறேன் ஓகே ஓகே see this you can feel this, it's a single filament, this monochrome. So can you feel this okay.
It's just like wire.
Yes, so this is an O14 dia. Okay, cut it into 4-5 small pieces. And how
What's the size?
yes yeah 30 yeah. So how you see all this is now all of us know how to do it. Only thing in that time you must know how to do it because we have to do it fast. So you just hold it by this tip and then cut.
Acha.
Because if you do like this and cut, it will just fly.
Oh.
No, I have done this in bench testing. Okay, and this video was shot just 3 days back.
Oh.
Okay, and I realized that if you cut like this will only keep flying. And it was caught on camera. Okay, so you have to hold like this and then cut. Yeah, 5 bits. Okay, 3 bits. Then have it ready. Now, how to load this? You have that needle? Yeah. So just cut. Give me one small cut, just 3 millimeters. You cut it. Yeah.
3 millimeter.
Just one small 3 millimeter cut.
He's cutting
and
the
cut.
same like it.
That's what. If you do, this will only fly. So I told you, this will happen. Just cut it. See, you have to use a good surgical scissor. Okay, otherwise you see the tip, no, you should not flare it in any way. Only then it will go in through the fine cross. Okay, good. Yeah.
I think here the problem is seeing it and putting it.
Okay, I'm only feeling it. I'm not, okay, it's here. The color is, okay. See, what you're supposed to do, hold it, okay. It's that our introducer needle, wire introducer needle. So just hold it and you have to load it like this, okay. Load it. This should go into the fine cross.
Obviously, you have done it many times.
So
you loaded it very fast.
No, you can take this out, madam. You can take this out.
So 5 bits inside.
No, not all of it together, one by one. Okay. Now, please push. And you have that tip controlled, please.
Yeah. That
Somebody will control. So this 30 monochrome can be pushed easily.
We have to put the introducer needle and then only
Yes.
we have to do it.
This is the thing, no, to keep you
otherwise it will take long time.
And also the transmission of forces will be very good.
Coil we removed this thing immediately.
No, you can. I'm not sure whether that
not for
thing will
coil.
accommodate the O14.
For the-
Okay, you can use that pusher
the-
tube. No, you can use it.
For
You can
the
use it.
snare we had removed.
No. Yes, it will not work with a Corsair or Caravel because the distal diameter is less. Okay, so when the first thing that microparticle will come, the bit will come out, then only the wire will come out. You keep pushing, boss.
Run through, sir, or pilot 50?
The pilot 50, that's
it
all.
came
Yes,
out.
deployed once. So deploy 5 times. You will get your thing. You will this will go and adequately form that mass for a clot to form. But one bit won't be enough.
Every time you have to remove the wire, again you have to load it.
Yes. No, this is a run through.
You have to remove the wire each time.
Why I told use the which one? Yes, this wire you have to remove. Yes, I have tried Vicryl, but I feel that monochrome is easier because I told you because it's a braided wire. And the other thing is I made a mistake that I tried dipping it in contrast so that I thought it will enhance the visibility. But what happened is it got stuck. But
Can you load one piece behind the other?
you can, but see, the mechanism is that there's a restraining, the coil, inner diameter of the fine cross is so restrained that one bit pushing the, now how will you, when you use the pusher wire, if you have 4 bits, it's not going to follow in sequence. it may get, something jammed, we are done.
Yeah.
So you can just repeat.
And you will have to get a new fine cross.
Yes.
You'll be
And if you
done.
damage the fine cross, it's a bigger problem.
Finished.
This is the simpler method.
Yeah.
See,
Yeah.
1, 2, 3 you do. If the flow is stopping, you can always come out. Always keep I would encourage you to read that paper, because that's the video was also there. A video recording is also there. And for doing Vicryl, it can go over a Corsair or a Caravan. If you go 4.0, you can use even a Corsair or a Caravan, because you can, if you don't have a fine cross and you have Vicryl, then you can use a Corsair. All the 3 microcatheters have been tried and has been successful. Only thing is, if you think 3.0 is not going well, use 4.0 also. Because now we have the particle which can be size, we can modulate. Okay, so that's the thing. If we do it, because I have every 2 months in my lab, we have a complication drill. Like how we have a fire drill, we have a complication drill. That is how because the whole team has to be sensitive. It's not that I am sensitized to it. Once you start simulating a complication, because once I don't tell what complication you're going to do. Once last one was a covered stent. I said, get me the covered stent, and in the lab's covered stent, the size was not available. I had one. I said I want only my that thing of Biotronic Papyrus. I said I want the Papyrus, and the Papyrus was in my car actually. It was my bailout bag. It took us 20 minutes. So I told the system is not ready, because everything has to be timed. How fast can you get a covered stent? Finding out the covered stent is going 20 minutes. We are stuck. So this complication drill only improves the whole efficiency of the team. Because when I do that fire drill, and you think that fire is not going to happen, but you still do the drill, complications do happen. So complication drill in the lab is very important. Every cath lab director should do a complication drill. Because I don't know, we were doing this cath lab directors course last year. We were thinking of how to improve operational efficiency from employees as a whole team. The operational efficiency is not about one person. Nurse, tech, everybody should be ready. So complication drill is a good idea to start. And that is going to keep your lab. You will know what hardware is not there in your lab, what can be done better. Your technicians will do the research for you. You just have to get them involved in the process. So anybody else wants to, there's one more coil. There are enough and more bits of Vicryl. Here you are ready? Okay. Madam, you have to put the wire on the side. The coronary wire should go. Yeah. Yes, you have crossed, man. You go to the distal end, madam. You push it.
Unless it
Some more? Oh, I think we'll have dinner and come back. Okay, then we'll cross distal.
Your we need that needle? No.
Oh no, now we have the snare. I've loaded the snare for you.
Yeah, but I don't think I'll be able to catch it, but I'll try.
Okay. Now, where is the snare? Snare upon that black color. We have put it over this black color sheet, no? Yeah, it's here. Finger. I've loaded this over this. Okay, it's a 2.0. So it means the diameter of this thing is 2.0. So if your coronary is say 3 mm, then it's better to have 3 mm snare. So the chances of you capturing the foreign body is higher. 2.0 also will work. That means the wire should be as close, within 2 mm proximity to the foreign body. Okay. Now load this, madam. Gently, you have to load it like this. Have the loop. The loop, no? Just
over the loop.
Yes.
Reverse from here. That's it.
Yeah, just come this side. Okay. Now, keep it as loose as possible. Open the Y, because most of the damage to hardware happens in the Y connector and in the kinked portion of the guide.
Yeah.
So many a time we think that the Y connector is okay, but that is not. Now, madam, this have to be opened and
open.
No, you have to open and lock it. We open and lock it. This is how this Nipro thing works. Rotate it, it locks. Okay. Now just no. Go gently, smoothly. Once it goes in, pull it back. Just it will lock a little bit. Yeah. Now push this. Now hold the wire and push this thing gently.
Not going.
Not going. Loosen it a little bit. Stuck here. Should go.
Yeah.
Go.
This is like an aspiration catheter.
Yes. Okay. No. Yes. Where is the guide? See the guide வந்துருச்சு வெளில. Okay. One minute, sure. Now, just engage the guide, please. This is very important. No, guide must be a rock solid.
Just push it. Push what? This guide.
അതെനിക്ക് കണ്ണാടി
ഒന്ന് ബാക്കിലോട്ട് എടുത്ത്
He was only tried multiple times.
ഇപ്പൊ engage ആയി.
ഇല്ല എൻഗേജ് ആയില്ല
Just withdraw it to get engaged.
I think it's engaged. എൻഗേജ് ആയിട്ടില്ല കുറച്ചും കൂടി കയറണം കുറച്ച് മേലെ
Get this on camera. Here. So everybody can see what is happening here.
എൻഗേജ് ആയിട്ടില്ല എൻഗേജ് ചെയ്യണേ എൻഗേജ് ചെയ്ത്
Let the snare come. Okay.
സാർ ഒന്ന് പുഷ് ചെയ്യോ കത്തിയിട്ട്
Once the cap is nowhere, go outside in.
കുറച്ചും കൂടെ
Should I pull the wire back?
അല്ല കുറച്ചും കൂടെ അല്ല ഒന്ന് ഡിസെൻഗേജ് ആയി പോയി
Very difficult, trust me, to go all the way distally and cap.
വയറുണ്ട് അതിനകത്ത് വയറുണ്ട് വയറ് ബാക്ക് വലിക്കാൻ വയറ് വയറ് ബാക്ക് വലിക്കാം മാഡം വയറ് കുറച്ച്
ഞാൻ ബാക്കിലെ വലിക്കുന്നു. But it's not under vision, so I might pull out the whole wire. Then it will be a problem.
Okay. Now it's okay.
We'll try to.
വയറ് കുറച്ച് വലിക്കണം മാഡം വയറ് കത്തിയിട്ട് കുറച്ച് പുൾ ബാക്ക് ആയി പോയി
Again, the catheter came out when I pulled the wire.
വയറ്
Actually, if you do it right, this is the best simulation of the friction forces. I can do it outside and show you, but if you do it on this particular model, the nearest we can have to.
Wire has come out, huh? Oh, coming.
I think the models are going to be here.
Okay.
Always have it tomorrow also here, so that we can practice.
Yeah, otherwise the people will stop the